Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known, proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
Good morning from Athens and the Transcatheter Heart Valves Congress. Welcome here in the audience and online. And this is the second day of the Congress, and the session is around optimizing TAVI outcomes. We have excellent speakers, and we have to start from Dr. Parma, who works in the Department of Cardiology and Structural Heart Disease in Medical University of Silesia in Katowice, Poland. Please, we have to connect with Dr. Parma. Good morning, Dr. Parma. Thanks for participating in the Congress. We're ready to hear from you.
Good morning. I'm very happy to be with you. Thank you for your kind invitation. I'm going to present the experience of our center in Poland and also the cooperation with Professor Tarantini from Padua on the re-TAVI treatability and sequencing and how to plan these procedures. I'm sharing my slides, and I would like to make the point that we can experience the degeneration of all aortic myoperisthes during the patient's lifetime. As you can see, all myoperisthetic valves durability is limited due to calcification, leaflet degradation, and they fail in about 10 to 20 years due to mostly stenosis, but also regurgitation. These patients may be safely treated by redo surgery or redo TAVI, depending on the clinical profile. The explantation outcomes, so surgical, are not so supportive because, as you can see, and it has been repeated in observations in the US in several registries, the 30-day mortality varies from 6% to 20%. And the 30-day MACE is also not supportive to these procedures. On contrary, on the balance, the limited experience of re-TAVI outcomes is quite supportive because the complication rate is not higher than 5%, and 1-year mortality is about 10% in this patient cohort. However, until now, there is no prospective observation. So what we think for the strategy is that for older patients, as you can see in the right upper screen, the elderly patients may undergo first TAVI, and then depending on the clinical profile and the risk of reintervention, either to have another TAVI device inside or to undergo explant TAVR. However, this may be more risky in these elderly patients. For the younger ones, and this on the bottom, the patients may undergo surgery or TAVI first, then undergo a second intervention. It may be that the valve may be re-explanted and then to have a repeat TAVI or to have 2 or 3 TAVI interventions in the time. So in order to plan which second intervention or the third intervention is the best one, we need to know the TAVI device features and also to know several characteristics which are very specific to re-TAVI interventions. The TAVI device features are not very widely listed and known, so we gathered them in the publication, which you can see at the footer of the how to do re-TAVI implantations. And there you have the presentation of the features, what is the frame diameter at the inflow, at the waist, and also at the outflow, and what are the heights of the leaflets or the crown of the accurate neo, which you can see the characteristics on the right. So this is important to see on the CT of the patient, whether the device is properly expanded, what are the probabilities so that we can overexpand this device and to guarantee a good gradient for re-TAVI patients. There is another feature which is called the risk plane, meaning that this is the area of a limited flow to coronary arteries resulting from the skirt, which is non-permeable for blood, and also limited by expanded leaflets so that they may cover the coronary ostia and limit blood flow to the coronary arteries. This is why we may play with this risk plane. By low implantation, these leaflets will be further away from coronary ostia. If we do a very high implantation of another device, then the coronary ostia will be covered. So this is why now we learn how to play with the risk plane in these devices, as you can see, starting from balloon expandable towards the self-expandable on the right. This implantation depth actually may allow, as you can see here on the left, either to cover the ostium of the left main in these patients with coronary sinuses, but if you lower the implant depth, you may allow coronary flow in this high-risk scenario. But actually, you also can see that the skirt of this device is quite high, and the risk of coronary obstruction in this patient is also very high. So what we also learned to know is that in order to predict which intervention to do, is that we need to know the distance from the device to either the aorta, and this is valve to aorta VTA, or the valve to coronary. But as we try to know the valve to aorta by counting the distance of the frame of TAVI device towards the aorta, now we try to measure the leaflet valve to coronary ostia distance, because if the leaflets are movable after the second TAVI device implantation, then they will not be fully open. So meaning that probably there will be a flow, and also that we can engage a catheter for doing PCI after re-TAVI intervention. So this near-skirt height can be planed by implanting the second device first, or low, or implanting the second device higher. I'm showing to you the balloon expandable valve SAPIEN 3 and SAPIEN 3 Ultra, because these are the only registered devices currently in Europe for this re-TAVI application. And also what we are trying to know is whether we can overexpand the first device, trying to reach as big opening of this first device, and just to reduce the gradient and to optimize captation of the leaflets, and to reduce the pinwheeling of the second balloon expandable device. So you can see that by going low with this device, with the second valve, we can either have leaflet overhang if we are quite low, which is shown on the left, or we can actually open the device, open the leaflets of the first TAVI by increasing the height of the second balloon expandable valve. I think it does not matter if these leaflets are regurgitant and without calcification. We can also expect that calcified leaflets will be more stiff and will behave unlike on bench testing. And this is what we are currently learning in observational bench testing and also observation and registries. So to decide on the second intervention, we also need to decide on how low or high implant there will be. And we know from recent publication in Eurointervention that for accurate neo, actually the line of the alignment of the SAPIEN 3 should be probably the top of the crown of this accurate device, and not higher as we previously thought, because we are no longer very much concerned about the leaflet overhang in this device. So for future coronary access and obstruction risk, what we know is that we need to decide on the risk plane. So what is the maximum height of the leaflet obstruction, then to choose a design. And for now, it is the SAPIEN 3, so balloon expandable valve for all the valves to implant depending on the height. And then, of course, we need to know the commercial alignment of the first TAVI device, because if this device is not aligned, that then whatever we do with the height of the second device implantation, the coronary access will be impaired in this patient. So this is the example of the CT screening for a high-risk patient with the left main, after left main stenting. And you can see that we can safely treat this patient. However, the risk of impaired flow to this patient will be high. So just to choose the proper implantation, we also need to decide in the future on the anticoagulant or antiplatelet therapy, because you can think that the flow will be impaired in this patient, even with a leaflet overhang and reduced motion above the SAPIEN 3 device. So currently we are in cooperation with a DASI company, which is a US-based company, allowing us to predict the expansion of the first device and also trying to show us what will be the leaflet motion towards the left coronary ostium of the left artery of the RCA. And we are trying to provide more data now to simulate the expansions and to optimize the procedure for these patients. Also, what we know it exists, however, this is quite scarce, is balloon-facilitated basilica procedure, which in valves which are aligned may allow opening the access to coronary ostia. However, we need to know that if we are not able to align the second device, despite this opening of the leaflet, the second device may actually impair the access to coronary by posing a suture line across coronary ostium. So to go to the sequencing of the events, we think, and we have published it in the consensus, that for the first balloon expandable device in the patient implanted, we think that either the second balloon expandable device is optimal, of the same size, or we can also choose a self-expandable. However, it is not registered and so currently not advisable to use. The positioning will be outflow to outflow in these patients and of the same size. For the mechanical valve, which we saw it was Lotus or Lotus Edge, the second device would be balloon expandable valve and size to the true ID, meaning that we need to identify the diameter of the frame inside on the CT. The problem is, of course, the width of the posts of the Lotus, which significantly narrow the ID and also prevent full expansion of the TAVI device. And also the positioning will be outflow to outflow. If the first device is the self-expandable device, then the second device would be balloon expandable valve, oversized to the first THV. And this is what we are trying to learn, is what the size should be of the SAPIEN 3. And we think on average that it should be, so this depends also on the configuration of the index anatomy of the patient, because if the self-expandable device is not fully open, say in bicuspid anatomy or heavily calcified anatomy, then we will not be able to provide full expansion of the say Evolut R. If we have, for example, Evolut R34, theoretically SAPIEN 29 could expand this device despite the waist of the frame being 24 millimeters in width. There is possibility of expansion. However, in severely bicuspid valve, the RAFA may prevent expansion, and then we need to reduce to the SAPIEN 26. The positioning will be tailored to allow coronary flow. So if the left main is low, we also need to make a lowered implantation at node 4 or node 6. And there is also another play, because if the first device is very deep and somehow the Evolut can go as low as 15 millimeters, then we need to position according to the native annulus and not counting the nodes of the self-expandable devices. So to summarize this, there are many areas of uncertainty, and this is just the beginning of the story. We do not know the short and long-term safety. this is only, currently the evidence is only based on limited and several retrospective and finely selected registries. And we need to know whether low implantation and under expansion of the devices for the second use or the third use will lead to earlier thrombosis or degeneration due to, for example, pinwheeling of the device, of the second device implanted. We gathered these recommendations of TAVI and TAVI in a consensus paper, which we published in February. And here on the right, you can see a proposed reporting chart for recommending that always we need to have a pre-index TAVI CT. We need to have an index TAVI CT, and then to report the THV metrics to decide on the size and the positioning of the second device in our patients with degeneration. Also, what we are currently underway is the first prospective re-TAVI registry, which recruitment is currently ongoing in Europe and Canada. We already have 55 declared centers to participate. We are trying to observe 150 patients during 1 year observation, and the first valve will be any THV. The second device will be SAPIEN 3 or SAPIEN 3 Ultra, and we hope to observe these patients during the next 2 years to have the first prospective data on the TAVI repeatability also. So the main points from what I would like to share with you is that we will see the increased referral of patients with the degeneration of the first TAVI device, because we are going down with the risk and also with the age of the patients, and then they are expected to come back for the treatment. So re-TAVI is different from valve-in-valve because there is under expansion of the first TAVI devices, and also these devices are different depending on the height of implants and the height of their leaflets, so mainly causing the risk of impaired coronary flow. So the actions to take is to do a proper CT screening to decide whether re-TAVI is feasible and optimal for the patients. And we should choose quite carefully the first TAVI device now, because if we guarantee a good coronary access using the first device, then the second device will be possible in these patients, prolonging the first TAVI prognosis up to 20 years. So there is the first consensus available to you, guiding on the selection of the first procedure and on the second procedure as well. And we hope to observe the outcomes and share with you in probably 2 years' time when we finalize the prospective registry. Thank you for your attention.
Thank you, Dr. Parma. Excellent presentation, providing guidelines, tips, and tricks. I'm a cardiac surgeon, and I would like to ask something. First of all, I believe you are one of the most experienced in the field. How often is the possibility to obstruct the coronary entrance in your practice, according to your experience?
So the most, I would say, anatomical scenarios which indicate the high obstruction risk is usually patients with narrow sinuses, narrow aortic root, and especially if there is a high implantation of a self-expandable device with highly positioned leaflets. So usually this is a scenario of smaller women, especially with bicuspid anatomy, where operators implanted evolut R in a high position, because evolut R has the highest position of the leaflets with a long skirt, and then if we open these leaflets, it will cause impaired flow to the coronary arteries. So this is the most frequent geometry. And I think the rate of dismissal would be, from my observations, also I screen these patients from let's say 50 patients, about 5 patients, so it would be about 10% of patients not feasible to do the re-TAVI. There are techniques also to save these patients. Sometimes chimney stenting may allow positioning of the stents to coronary ostia. However, long-term durability of these unusual placement of stents is unknown, and also it is very difficult to do repeat PCI in such stents.
Thank you very much, Dr. Parma. This is Greg Patakos. I'm also a cardiac surgeon. We really, I think from all of these descriptions and data gathering and all of these efforts that are going on with TAVR and TAVR, I think it's going to make all of us better, because the fact of the matter is, I think many people are presenting this to patients as, a definite thing for the future, whereas it's not guaranteed, as you said, that it's going to be doable for all patients. However, we look forward to teaming up with you and contributing our own data so that we can have some joint productivity in terms of defining who these people are and what the best therapies are going to be for them. So thanks for being with us, and please stay connected if your schedule allows, as we'll have more questions from the audience as we proceed. So
Thank you so much.
Thank you. We will be moving on to our next speaker, Dr. Rahul Sharma, who's connecting with us from Stanford. Thank you so much for being online with us. It's our privilege and our honor to have you, especially given the time difference. I have many video chats and conferences with colleagues in the US, and I wake up at 3 a.m. to do them. So we really appreciate the fact that you're here at this hour. Dr. Sharma, it's all yours.
It's my pleasure, and thank you so much for having me. I wish I could be there in person, but nevertheless, I'm grateful to be there virtually. So the task I was assigned, or the topic I was assigned rather, was paradigms when you want zero PVL, zero pacemaker, zero pacing, and to PCI soon afterwards. So basically everything we want in the ideal TAVR procedure. So I took that lesson, and really I thought about it. And because this is ideally the situation we all want in our TAVR cases, I thought a lot about a question I get asked, and that is, what does the TAVR device or the TAVR procedure of the future look like? And to me, that incorporates all of these elements. So in the next 10 minutes, I will endeavor to describe where I think we've come from and where I think we need to be, or at least we need to be going. These are my relevant disclosures. And so when we think about TAVR of the future, or ideal TAVR and the paradigms we described, it's really about the metrics that are important and the outcome-based metrics that are important when we look at a TAVR procedure. And Dr. Palmer talked about very eloquently valve and a lot of the features that we look at and the outcomes we're interested in. But when we break it down from a high level, what are the things that we, and particularly our inpatients, are interested in when it comes to TAVR? The first and foremost is mortality. Stroke, particularly as we're treating these younger patients, is the most debilitating effect. In fact, a lot of patients would say they would rather die than suffer a debilitating stroke. Vascular complications, I still think, remain the most common complications. We often get so focused on the valve type, the valve selection. We're very good at the complicated parts of the procedure, but sometimes it's the simple elements like the access that can let us down. Perivalvular regurgitation is a big focus. We've swung the pendulum from all regurgitation is bad to only moderate or worse is bad. And now we're seeing data again saying actually anything more than mild is bad. And so that move towards reducing PVL, improvements in technology to do so with skirts and various other sealing mechanisms. The risk of permanent pacemaker implantation, while traditionally not necessarily a complication, definitely an additive element. And again, as we're treating these younger patients who are going to be around for a lot longer, the long-term risk of RV pacing, multiple additional devices, and of course, the risks that are associated with an additional procedure warrant consideration. Coronary obstruction, very well described by Dr. Parma in the setting of valve and valve, but also a consideration, again, we're treating these younger patients. Some of the valve designs are longer, they take up more of the space. We need valves that can treat almost all sorts of anatomies, and we know from vast experience that unfortunately not all patients have coronaries in large sinuses of Valsalva that sit well above the height of the initial valve, let alone a potential second or third valve. Annular rupture, fortunately a rare occurrence, but yes, a very catastrophic occurrence. And then again, this issue of durability and longevity of the valve, whether it's the leaflet or the valve frame itself. We've got revision of our VARC criteria and revision of the definitions of structural valve deterioration. And now there's a lot of data now beyond registry data as we've got more long-term follow-up of these patients to assess what is the true durability of these valves? And that's important when we talk about lifetime management of the patient. It's not just about optimizing their index procedure, but talking to that patient about how many procedures, be it transcatheter or surgical, or some combination of both of those, are going to occur over their natural lifetime. And then, of course, keeping in that realm of long-term durability and the future of that valve is the issue of coronary reaccess, either due to development of coronary disease after placement of the TAVR, or in the need for TAVR and the issue of coronary reaccess as part of that index procedure, or down the track, and the issue of commissural alignment becomes important. And then finally, bringing it all together for that lifetime management, which is really the hot topic, and very much including valve-in-valve, which Dr. Palmer did a fantastic job of going through. So what are the current standards when we look at mortality and stroke? What is the bar we're trying to achieve? So this is looking historically, starting, of course, with the PARTNER 1B historical cohorts, all the way to the PARTNER 3 low risk, which is obviously set the stage for now the all-comers access that we have, at least here in the United States, for application of TAVR. And you can see there's really a dramatic drop in the 30-day all-cause mortality over time. And this is similar with stroke. And I think this reflects a number of things. It reflects a change in the way we select patients, obviously a very sick, inoperable cohort to start with, and now we're including all risk categories, younger patients, healthier patients. But also it reflects an improvement in technology over time, an improvement in the engineering of these devices, an improvement in our understanding of how to do these procedures, and importantly, our experience as operators in identifying best practices. And I think all of those in combination are resulting in what you're seeing here today, which is a significant reduction. So now in the current era, less than 0.5% 30-day all-cause mortality, almost close to zero in large volume centers, certainly less than 0.1%. The 30-day disabling stroke risk, 0% in the P3 low risk group. We know it's not quite 0%, particularly depending on the definition of stroke, whether you're looking at imaging findings. Certainly there's been mixed data in the cerebral protection studies. Nevertheless, that stroke risk isn't quite at zero in absolute terms, but getting close to certainly under 1%. But of course, the goal is no strokes at all, particularly in these younger, healthy, active patients. How do we compare that to the gold standard? I know there's surgeons on the panel, and for very much up until now, this is the gold standard. This is the barometer by which we need to compare. And so fortunately, TAVR has fared quite well. And we look at, again, the PARTNER 3 low risk trial. When we compare surgery to SAPIEN TAVR, there's a significant difference there, 15.1%, at least at 12 months compared to 8.5% in those two groups. So faring well compared to that surgical gold standard, even in a low risk patient population. What about vascular complications? I mentioned that these are the most common, and we see this day in, day out. And a lot of the times it's not necessarily the large bore access site of the device placement, but sometimes even the contralateral side. And again, we see over time, the rates of these vascular complications have come down. I think this is mostly driven by experience with large bore access, the use of closure devices, pre-closure devices, particularly now there are a number of commercially available devices on the market, but also our skill, expertise in understanding how to access these. The role of ultrasound guidance, the role of micropuncture needles has changed drastically from when I started training, where we would just feel the femoral pulse, take an 18-gauge hook needle and stick it in. I think finally, the biggest improvement has been the engineering. The size of the sheets has come down dramatically, and we know that there is a distinct correlation between the diameter French size of these sheets and the rate of vascular complications, particularly once you get over 9 French. And so again, all of these things together collectively bringing down the risks of 30-day major vascular complications to less than 5% and ideally less than 2% in these groups across all risk profiles. And again, when we're comparing to the gold standard, you can see here in surgery versus TAVR, so 2.9% in surgery cases at 12 months compared to 1% in the SAPIEN 3 TAVR when you look at the rates of disabling stroke or death. So again, very comparable. And again, the most common fear of all patients who are coming in for TAVR is that risk of stroke, arguably greater than the risk of death. PVL, as I mentioned, the pendulum has swung many ways about PVL. Part of the issue is the way we assess PVL, whether it's angiographically at the time, whether it's echo immediately post or before discharge. But I think what's clear is that any significant degree of PVL is really unsatisfactory. And again, I think a lot of this has been driven by engineering. You can see the iterations, at least with the SAPIEN valve, but I think all of the other valve types have followed suit. The idea of placing a skirt an inner skirt and potentially an outer skirt, but with the goal of sealing at the valve-annular interaction, independent of an anatomy. So even if there's heterogeneous calcification, the idea being that you can create a good seal between your THV device and your native annulus to reduce the risk of PVL, which we know is associated with adverse outcomes and mortality, particularly when it's moderate or greater. I think the other aspect, in addition to the utility of the improved engineering and these additional skirts and sealing mechanisms, has also been our understanding of where to place these valves in terms of the depth of implantation. And I think we've seen a trend over time to go from rather relatively deep implantation to now much more shallow implantation where the anatomy allows. Of course, the caveat of the presence of calcification, dimensions of the sinus of Valsalva, the height of the sinus-tubular junction, and of course, importantly, the coronary heights. But all of those caveats aside, I think we're seeing a general trend towards moving to higher and higher implantations. And I think that's driven by improvements in PVL because of the zone of skirt sealing, and also, of course, the reduction in conduction disturbance as well. Speaking of conduction disturbances, the rate of pacemaker implantation is highly variable. A lot of this is based on patient factors, particularly pre-existing conduction disturbance, age, but also the type of valve being implanted, self-expanding valves versus balloon-expanding valves, clearly a difference there. And then, of course, the depth of implantation, the relative position of the valve to the conduction system, the bundle of His and the bundle of branches, resulting in highly variable pacemaker rates, anywhere really from 4 up to 20%. We saw with the Lotus valve rates as high as 30%. But overall, I would say the rates of pacemaker implantation coming down, mostly, again, driven by differences in radial force, placing pressure on the conduction system. But again, the valve design, but also the valve placement. We know that if we place these valves more shallow, the rates of pacemakers decrease drastically, particularly when you're below 5 millimeters under the annulus. We've seen this in the self-expanding literature, as well as the balloon expandable literature as well. Part of the appeal of the cusp overlap, which we see with the Medtronic platforms, has in fact been to reduce both PVL and pacemaker implantation rates while preserving the optimal hemodynamics of that self-expanding platform. Again, when we bring it back and compare this to this gold standard of surgery, because I think it's always important to compare to what is being done now. We don't want to do something different for the sake of doing different if we're not doing it different and better. And so when we look at PVL and pacemaker rates compared to surgery in these patients at 1 year, 30 days, really, quite a good performance there. Moderate or severe PVL, 0.8% at 30 days, 0.6% at 1 year. And then the rate of implantation of a permanent pacemaker, on average, 6.5% to 7.3%. Now, again, highly variable numbers depending on valve type and patient selection. But again, this is just as a snapshot on average. And really, I think we can drive the new permanent pacemaker down probably further as technology continues to iterate. And moderate or severe PVL, I think we can get down as well, particularly with some of the newer generation valves that are coming out. When we look at the current standard of efficiency, and this is particularly important, I know in the United States, I'm not so sure about Europe, but certainly in Australasia as well, is this idea of TAVR has proliferated. And if you look at the curves of SAVR versus TAVR, TAVR has well and truly crossed the curve of SAVR when you look at even isolated AVR. So it has become the preferred procedure of choice, not just for patients, but for physicians as well in large academic and non-academic centers in the United States. And so with that comes the argument of health economics. We know surgery has been around for a long time. The costs have been brought down for surgery, but the reimbursement is still very good. So net, it is a very profitable procedure for our hospitals and health systems. And we don't live in a fantasy world. It's important to consider health economics when we're looking at all of these procedures. It's not simply about what is the best device for the patient, and we can forget about all the other costs associated. So hospital efficiency and the importance of keeping these patients out of hospital as long as possible is important. When we look at the average data from TVT registry and other registries, 80% of patients are achieving next day discharge, with 90% of patients with a 48-hour discharge. I would say in most large centers doing over 300 TAVRs a year in the United States, that number of 90 to 95% is within 24 hours. Most patients are staying only one night and being discharged the next day. And I think that's the standard we're seeing across the world. Pleasingly, in spite of a lot of these patients still being sick and still being elderly and occasionally some sick inpatients as well, the vast majority are being discharged home. And that has significant implications, not just in terms of morbidity for the patient and return to function, but also from a cost perspective and a burden on the healthcare system. Discharging these patients to nursing homes or rehab facilities is an extreme cost to the healthcare system, but also has an impact on that patient's ability to regain their function and retain their quality of life in a more rapid fashion. Obviously, the big difference, and I say this to patients week in, week out in clinic, is all else being equal, when they say SAVR versus TAVR, what are the biggest differences? It really is the recuperation, the recovery, the time in hospital is obviously longer. The discharge destination usually involves some sort of rehabilitation. And then once they do return home, it is a more protracted recovery period that's slow and steady compared to post-TAVR. There's no doubt about that. Coronary reaccess are really a hot topic, and it's important because the prevalence of coronary artery disease in these TAVR patients increases over time. Obviously, as patients get older, their risk goes up. But what's important to point out is that even in these low-risk patients, these younger patients, it's still above 25% that have significant CAD. There's a study being done by Dr. Wood and colleagues about the role of revascularization in these patients and whether it makes a difference. And that's going to be an important study, a randomized study, a very large study. But I think the other thing is that we forget it's not just about the point in time estimate of coronary disease now when you're implanting that TAVR. It's what about those patients who have no coronary disease now when you put their TAVR in at 65 or 70 and in the next 5 or 10 years, then go on to develop coronary artery disease. So it's not just about seeing what's here in front of us now, but trying to look forward at what could be in front of us in the future. And we know that about 10% of these TAVR patients are readmitted for an ACS within 2 years after TAVR. Now, for experienced operators, like a lot of the distinguished faculty on the call and peers in the audience, this is not a problem because we see these patients, we're used to doing it. The issue becomes what happens when our TAVR patient presents with a STEMI at an outside facility that is not used to doing TAVR and therefore is not used to re-engaging coronaries after a TAVR. That becomes a consideration and potentially a conundrum, and we've seen it happen. There's a lot of best tips, best practices on how to do this, but until we get that experience, it's not going to be as simple as doing a routine access of coronary without a valve in place. So I think we need to be thinking about that and trying to future-proof our valve placements in these patients. Durability is a really hot topic. We talk about valve degeneration and valve failure. Obviously, now that we have closer to the 10-year data, we definitely have the 5-year data, but soon we'll have the 10-year data in terms of the long-term durability. There's been significant improvements in tissue technology with the Edwards, the Resilia anti-calcification. A lot of the novel valve technologies are moving towards a polymer-based valve. Again, the driving force behind this is how can we get the best durability out of the tissue of these valves? Traditional teaching is that surgical valves will last you 10 to 15 years. We're not necessarily going to be seeing the same thing with transcatheter valves for a whole host of reasons. So as material technology continues to improve, it's not just about the valve frame. Now it's about tissue material technology and how can we get the best durability, whether that durability is related to thrombus formation, leaflet thickening, calcification, resulting in either a significant regurgitation or stenosis. All of these are important factors as we improve upon current generations of these valves to ensure that we're getting as good durability, if not better, than the gold standard of surgery. And just as I wrap up, I think it's important when we think about all these metrics and all of these endpoints. Now, TAVR is very much a well-adopted technology. It's ubiquitous. There are sites, arguably, perhaps the same in Europe, in the US, sites that we think maybe shouldn't even be doing TAVR because we've got over 600 TAVR sites in the country. But we have to not forget that there was a point in time where TAVR was really just in the domain of the innovators and early adopters. And there was this chasm as exists in all technology where people thought, this is a crazy idea. The skeptics, of course, the conservatives waiting for data, and the pragmatists who said, well, we've got surgery and it works fine. So it's always important as we're looking at where technology is going and what's there, is that this adoption of technology is not always simple and straightforward. And it's only a small proportion of people who are those enthusiasts of new technology. And any new technology, even an improvement on current technology, whether it's new leaflet, new frames, new way of deployment, there's always this excited phase after a trigger of technology, this peak of inflated expectations. And then we get a little bit of experience and we enter this trough of disillusionment as we have some bad outcomes. that as we persist through, as we did with TAVR in the early years, where our outcomes arguably were not great in these sick patients, we now enter this slope of enlightenment. And I think the TAVR now is truly in this plateau of productivity. I think mitral and tricuspid is still well behind, but we enter this plateau of productivity where we're now making small iterative improvements on an excellent technology as we look to the future. And so just to bring it all together, you know, I have a lot of patients that play golf in my clinic. And so when I think about all of the paradigms, bringing it back to the topic of where we need to be in the future and what those standards are, I think we need to have a mortality and a stroke rate that is under 1% across all groups. Vascular complications have to be under 1%. This is taking into account complex, calcified, alternate access, but overall, we need to get down under 1% of vascular complications. We need to drive pacemaker rates under 5%. I think there are going to be a group of patients who inevitably would have received a pacemaker just by virtue of the natural progression of their conduction disease, and we've simply accelerated it with the TAVR. So it's not going to be zero, but I think we still can make improvements in terms of where we implant these valves and the radial force these valves exert to bring that pacemaker risk down, particularly in younger patients. PVL rates, I think we can get, again, consistently under 0.5%. We're almost there. Ease of coronary access has to be 100%. We need to be able to get into these coronaries easily, and not just us, our colleagues who are coronary operators who don't do structural heart also need to be able to access these coronaries easily. It shouldn't be a multi-step process which requires multiple CT planning and extreme expertise to be able to get into a coronary easily and quickly. I think we need to aim for durability of these valves of at least 10 years, if not longer. The average age of a patient we're treating in our clinic is now 70. I'm sure in the next 5 years, we're going to see patients get into the high 60s soon. And then, of course, all my patients want to know, will I be able to drive the ball any further with TAVR? And for now, I say no, but in an ideal world, if we can, that would be the ultimate TAVR valve. Thank you so much.
Thank you, Dr. Sharma, very much for your talk. I think it's always important to set goals. So I really liked your last slide. You had PVL less than 0.5% there. I assume you mean moderate and severe and not smaller grades. I think, you know, that's a lofty goal, and I think it's achievable. I think a pacemaker rate of less than 5% is going to be challenging, but I think all of the other goals on there are doable, and I think it's always important, as all of us have done who are online or here in the audience or up here on the podium, you know, you set loftier goals, maybe you try and achieve something, you set your goals a little bit higher than what you can truly achieve. So thank you. We see that you're on the visionary status of that curve that you showed as well. It's our honor and a pleasure. I want to ask if there's anybody in the audience or any of my co-panelists who has a question. Dr. Perez here, I think, has a question, who's a cardiac surgeon with us as well.
Thank you, Dr. Professor Sharma. This was really enlightening, and you are really visionary. So I fully agree with Dr. Patakos that the future is probably there because technology is running very fast. Just one tricky question. Do you think that there is a group of patients, regardless of age, which will pose a constant technical difficulty in the future, like you can choose the low coronary osteo patients or the fixed aortic root patients that we've had before in the previous talk? Do you think there's a group of patients which will be a difficult group to treat by either means, SAVR or TAVR? Thank you.
Yeah, I think that for me, the difficult patient at the moment in practice is the bicuspid who is not of inoperable or extreme risk, particularly the raphe calcified bicuspids, and certainly if they have an aortopathy, because these patients come to us almost with an expectation of TAVR because it's so prevalent, it's proliferated. And we have to be careful in our enthusiasm not to put the cart before the horse and not to assume the data that we have simply extrapolates to all patient groups. I think we've learned a lot. We have a lot of bicuspid data now in registries. We've not yet done a randomized trial. We may never get that randomized trial. But I think that is a group that I continue to struggle with, and I think for a while we will struggle with because, you know, the disadvantage of transcatheter is we can never directly visualize and touch what the surgeon can. And that's never going to change with transcatheter. And so that is the group, I think, where it's not necessary. All other groups, I think it's basically an equilibrium, but I think the bicuspids with heavy calcifications, and especially with aortopathy, are still very difficult to say that TAVR is equivalent to surgery in terms of its outcomes. Certainly there are bicuspids which are better suited. Certainly there are very elderly high-risk patients who will not do well with surgery, and so that may be their only option. But save that, I think that's the group that is the most tricky.
Thank you very much. Thank you for the excellent presentation. So we'll move on to our next guest speaker, Dr. Tang from Mount Sinai, who's a cardiac surgeon, luckily staying on the same subject, trying to perfect the procedure. So we're very happy to have Dr. Tang, who's the Director of Structural Heart Disease in Mount Sinai, who will talk to us about focusing on commissural alignment, which our surgeons consider an important task, important and how to achieve. Dr. Chang, we're here to listen to what you have to tell us.
Hello, today my presentation is on commissural alignment, on its importance and how to achieve. Here are my disclosures. What is commissural alignment? What you see on the left side is the commissural alignment where the native commissures of the aortic valve align with the neocommissure of the transcatheter valve. On the right side, you can see one of the neocommissure of the transcatheter valve faces one of the coronary orifice completely misaligned with the native commissure. Hello, today my presentation is on commissural alignment, on its importance and how to achieve. Here are my disclosures. What is commissural alignment? What you see on the left side is the commissural alignment where the native commissures of the aortic valve align with the neocommissure of the transcatheter valve. On the right side, you can see one of the neocommissure of the transcatheter valve faces one of the coronary orifice completely misaligned with the native commissure. And here are the definitions that we recently published in a state-of-the-art review in JACC intervention. Basically, if you can have mild or no misalignment on the left side versus moderate to severe alignment on the right side based on these angles. Now, why may commissural alignment be important in TAVR? Certainly with the taller valves, you want to preserve coronary access. For valve-in-valve, you want to reduce the risk of coronary obstruction. You want to maximize the possibility of redo TAVR by reducing sinus precipitation or coronary obstruction, especially younger patients. There's some early evidence of impact on durability or halt in gradient with misalignment. If you have a commissural post facing the coronary with misalignment, you can't really do leaflet modification such as basilica or shortcut. And of course, all valve manufacturers now are focusing on this topic, so clearly they know it's important. Here's some of the other factors that we talked about that can impact from commissural alignment, not just coronary access, but flow, paravalvular leak perhaps, redo TAVR, and leaflet strain and stress. So this is one of the definitions that I want to talk about is the prevalence of coronary artery disease in AS patients undergoing TAVR can be quite high. And you can see that over 60% of patients with intermediate risk has coronary artery disease. And the success rate of coronary angiography or PCI really depends on the series that you look at and the valve type. The problem is that the lack of device familiarity by interventional cardiologists who don't perform TAVR. There's a lot of aortic root variability from patient to patient. There's a native aortic valve in place. There's the transcatheter frame in place. And of course, the commissural post in place if you have misalignment. Here are two examples of why coronary access may be difficult. On the left side, you can see that there's a bulky calcium of the native leaflet, making selective engagement difficult. On the right side, you can see the left main is very low because of supraannular surgical valve plus an evolute valve, so it will be very difficult to engage because of this tapering effect. And of course, we know that this happens in CT as well, based on this paper, looking at 11 to 22% post-CT has commissural facing the coronaries, causing from misalignment, so making coronary access difficult. And with this particular paper, you can see that commissural orientation is one of the factors in terms of difficulty in reaccess. We recently published a paper on anatomic and device procedural factors affecting coronary access. I encourage you to read at your leisure, and we actually developed an app available for free on Apple and Android. Plus, on a website, you can see that here, allowing you to learn how to do access to coronary with both commissural alignment or misalignment with self-expanding and balloon expandable valves. So really the understanding the anatomic relationship is key. You can see that the shorter frame valves, balloon expandable or mechanically expandable valve, are more important for redo TAVR than coronary access, but taller frame valves certainly important in both. And you can see that this tutorial showing the commissural alignment is important in both coronary access and redo TAVR. The reason being, if you have misalignment, you can see that these triangles representing the commissural posts are much bigger than the surgical valve. So that's how you can impede yourself from accessing the coronary, because it's now a big scaffold. And you can see that example here with the Evolut system, that if you have suboptimal alignment, you have to go from either side to access the coronary, represented by the red dots. But if you have a commissural alignment, you can go directly from above, even if the valve is implanted high, as you shown here on the panel B. With commissural alignment, it's also important in valve with leaflet modification. You can see that here in panel E and G, if you split the leaflet like a basilica technique or shortcut, if you have a commissural post facing that part of the split portion, you can still obstruct the coronary afterwards. And if you have TAVR and then you want to access the coronary, if you have commissural misalignment on the second valve, if it's the first valve, the short valve, and the second valve is tall valve, you can have a problem. If you have a tall first valve and you have commissural misalignment, after the second valve goes in, it can also be a problem. So this state-of-the-art review on redo TAVR that we recently published show that commissural alignment is also important in redo TAVR. You can see that why in terms of CT analysis. And the reason being that if you have the commissural alignment, you might be able to modify the leaflet to reduce the neoscript height. You can see that here, down by almost half, because now you can only worry about the inner skirt, not the leaflets themselves. And of course, you can also consider other adjunctive techniques such as balloon-assisted basilica, you can show here, to improve the flow to the coronaries, but you still need commissural alignment. This paper has been published a number of years ago looking at aligned TAVR with a balloon expandable valve, at least with SAPIEN 3, it's not really feasible despite crimping on multiple orientation. And that's been validated in other studies. But with SAPIEN X4, you can see that there's a letter C that you can actually rotate and the valve actually align with the commissures before you cross into the annulus, and you can actually try to improve commissural alignment that way. And the trial is ongoing. With the Evolut system, you mount the C-tab, which is one of the commissures, the way you normally do facing the ceiling, and you actually have a relationship with the hat marker and 90 degrees to each other. And with the Evolut FX system, it's even better. You put the flush port at 3 o'clock, you put the hat marker facing you directly and cuts overlap view, and you can release the valve with the C facing the right side of the screen, confirming commissural alignment. And this has been validated also with this aligned access study from Giuseppe Tarantini's group with commissural alignment, improving selective coronary access with the Evolut platform. Now, there are other self-expanding valves that has commissural posts. You can see how they look on fluoroscopy, and all of these can be done using cuts overlap view to improve commissural alignment. I want to bring your attention about the accurate Neo2 valve. We now put the flush port at 6 o'clock, and you cross over just above the annulus. You want to see where these commissural tabs are. If you have the commissural tab on a 2-1 orientation, you would rotate the delivery system clockwise. And then if you have 1-2 configuration on the free cuts view, you go the other way, counterclockwise. If you have 1-1-1, then you don't need the rotation, and you just need to look at the cuts overlap view to confirm that the 1-1-1 is actually having one tab facing the coronary, sorry, not the coronary, the 2-1 view rather, to optimize your commissural alignment, and then you just deploy afterwards in your free cuts view. Now, with coronary alignment, there was a lot of discussion about this. The reason being is that sometimes the coronaries are not 120 degrees or 130 degrees, but 180 degrees sometimes. So you want to avoid overlapping one of the coronaries with a commissure. So by splitting the difference with a commissure, you may have some trade-off with the left main, but you won't at least overlap with the right commissure. And you can see by going RAO caudal, you can improve that, and this is how it works here. And so in summary, I want to draw to your attention this state-of-the-art review that you can read a lot more about commissural alignment and other details. So in summary, commissural alignment are currently not available in all the devices commercially available, but the techniques have improved the way we align commissures, it would make lifetime management of patients with AS and CAD easier. The technique modification, just as flush at 3 o'clock with Evolut, flush at 6 o'clock with the Neo2, have improved commissure alignment. And I think we really need to look at the CT and patient-specific analysis to do that on a case-by-case basis. Coronary alignment in eccentric anatomy may be beneficial, but we really need more prospective studies, some of which are ongoing, to confirm that commissure alignment really improve coronary access and reduce TAVR. And of course, manufacturers do need to improve this from a device and delivery system design standpoint. I'd like to thank you very much for your attention.
We thank Dr. Tang for a very enlightening presentation. As I said, we really consider that an important issue, aligning the valve as it should be. We recognize it is slightly more difficult when you don't have direct view. I'd like to ask a question on our TAVR experts. There is certainly a difference in the outcome if you create a problem in the left or the right coronary ostium. Is there any experience on the clinical scenario, the presentation of the patient, if there is a narrowing of the right or the left side? I presume the left side is always an absolute no. Maybe Dr. Spargias would like to comment on the right coronary. We do see patients in the elder group that already have significant problems on the right side, and if the heart has managed to function with this problem, then maybe it should not be so much of a problem. So do you consider alignment important on both ostia, or is there slightly more important for the left side and maybe less for the right coronary ostium? Thank you.
Of course, the left main is the most important coronary artery, so it gets a priority. So if you really want to have a commercial alignment in non-symmetrical anatomies, you go, as Dr. Tang said, for the left main as a main priority. The right coronary artery is less important, but in symmetrical anatomies, now we have ways and strategies to achieve commissural alignment with all self-expanding valves, and soon with the X4 Sapien valve that I think is available in the United States, but not in Europe for now.
Thank you very much.
And let's move to the last talk before we enter the cases, which is... it's not the last one. Sorry. We have Greg there, Dr. Patakos, who is going to be the last but not the least. So let's move to the before the last talker, who is coming from Quebec, Professor Pivaro, who is the head of the department there, is going to talk to us about the meaning of the gradient after the TAVI procedure. It's something that is very high on my sort of agenda, and I'm very keen to see what's going to tell us. Thanks a lot. It's a video case, so we are not going to have any questions on that, possibly a small discussion after.
It is a great pleasure to present our Transcatheter Heart Valves Greece 2023 on the post-TAVI mean gradient, 8 versus 18 millimeters of mercury. What does it mean, and does it matter? These are my disclosures that are listed here. So first, high residue gradients post-TAVI, what does it mean? What is the etiology of high gradients post-TAVI? Well, it could be related to prosthesis-patient mismatch, or to a valve thrombosis or endocarditis, or a structural valve deterioration due to fibrocalcific degeneration of valve leaflets, or overestimation of gradient by echo due to pressure recovery. So prosthesis-patient mismatch is defined as a prosthesis that is functioning normally, but that is too small for patient body size. So in this case, you have a normal AOA, effective orifice area, but the indexed AOA is too small. And when it is smaller than 0.85, this is moderate mismatch. Less than 0.65 is severe mismatch. And according to VAR3, if the patient is obese, then you have to use a lower threshold, so 0.70 for moderate mismatch and 0.55 for severe mismatch. And high residual gradients, according to VAR3, is defined as a mean gradient of 20 millimeters mercury or more. So this is a case of a patient with a small Sapien 3 valve, size 20. You see the leaflets are thin, moving well. This is a normal appearance and mobility. The valve is functioning normally, but you have a high residual gradient of 26 millimeter of mercury, kind of small AOA, 1.2, but this is normal for a SAPIEN 320. You know, the normal reference value is 1.22. So the prosthesis is doing what it should do, but the AOA is too small for this patient. The index AOA is 0.763, which is less than 0.65, consistent with severe prosthesis patient mismatch. So it is important to keep in mind that the echo and CAT do not exactly measure the same gradient. Echo will typically measure higher gradients because it measures the gradients at the level of the vena contracta. And whereas cardiac catheterization measure the gradient at a few centimeters downstream of the vena contracta, so after pressure recovery. And this is why, you know, in this study where gradients were measured by CAT and by echo immediately after doing the TAVR, you see systematically the echo gradients being higher than the invasive gradient in blue. And in fact, the difference is generally more important in the small transcatheter valve and particularly in the small balloon expandable valve. This is where you have the largest discrepancy between CAT and echo gradients. So high gradient post-TAVI, does it matter? What is the impact on outcomes? Well, according to this study, you see that the gradient measured by echo at discharge and high residual gradient was defined as a mean gradient of 20 or more, according to VAC3, was not associated with increased risk of mortality. And same, the invasive gradient measured at the time of the procedure and high residual gradient being defined as a mean gradient more than 10 was not associated either with increased mortality. Having said that, you see that very few patients actually had a high residual gradient by echo or by CAT. In this larger registry, national registry from Australia, the NIDA registry, they look at the association between residual gradient post-TAVR, but also post-SAVR, where you have more mismatch and more high residual gradient and survival. And you see that really the cut point is around 23 millimeters of mercury in this study. So below 23 millimeter of mercury residual gradient, there was no impact on outcome, but beyond, there seems to be an impact on long-term survival, not on the short term, but on the long term. And on the right panel, to answer the question that was asked in the title of my topic, 8 versus 18, does it make a difference? You see 8 is a normal valve function. It's very low residual gradient, below 10. 18 belongs to the mild impaired valve hemodynamics with gradient between 10 and 20. And you see that between these two categories, there is no significant difference with regard to the impact on one-year mortality, so the short-term outcomes. But of course, if you have higher gradients, so if you go into the category with moderate impaired hemodynamics between 20 and 40, so for example, a gradient of 28 would make a difference versus 8. And of course, more if you are higher than 40 millimeters of mercury. So now I would like to emphasize that what is more important than the absolute value of the gradient at the given follow-up is more the change in gradient during follow-up, and especially an increase in gradient, which may be the marker for an hemodynamic valve deterioration. And indeed, in the VAC3, we provided some criteria for classification and staging of bioprosthetic valve dysfunction. And the first step is to identify red flags. So a high residual gradient at a given echo, discharge, or during follow-up is just a red flag. This tells us, oh, there might be a dysfunction, there might be a problem with the valve, but maybe the valve is functioning normally. And then the second step, if you have one of the red flags that were mentioned before, then you need to determine what is the etiology and category of bioprosthetic valve dysfunction. And this often requires multimodality imaging. It could be a non-structural dysfunction, such as prosthesis patient mismatch, or structural valve deterioration, or thrombosis or endocarditis. And the last step is to stage the magnitude, the severity of the hemodynamic valve deterioration. So stage 1 means morphological valve deterioration. There is abnormal leaflets. The leaflets may be thickened, calcified, but not yet any hemodynamic dysfunction. So it's more subclinical, if you will. Stage 2 means moderate hemodynamic valve deterioration, and it is essentially based on an increasing gradient during follow-up, so a delta of 10 millimeters of mercury or more, associated with a decrease in the effective orifice area of at least 0.3 centimeters square. And stage 3, this is severe hemodynamic valve deterioration with a delta in mean gradient of 20 or more. So this is a patient who actually you have a major increase in gradients between discharge and 30 days with marked decrease in AOA. And if you look at the leaflets, you see they are thickened, diffuse hypoechogenic thickening of the leaflets with reduced mobility. This is, of course, a case of stage 3 hemodynamic valve deterioration related to valve thrombosis. 2 weeks after warfarin, there is a regression of the gradients and improvement in the OA, and the leaflets are now thinner and moving well. But interestingly, 3 years later, there was a recurrence of the gradient, of the increasing gradient in this patient. And actually, you see now that the gradient is to 24. So it's not back as high as it was, at the time of the thrombosis, but still. And the leaflets are not normal, but it's a different type of abnormality. As you see here, this is heterogeneous thickening with hyperechogenic, consisted with fibrocalcific remodeling and thickening of the leaflets, and so structural valve deterioration. So here we have a stage 2, so it's more moderate hemodynamic valve deterioration, but due to SVD versus, a stage 3 thrombosis before. What is the clinical relevance of this classification or staging of bioprosthetic valve dysfunction? This is a study from our institution, post-SAVR, more than 1,000 patients following SAVR at 10 years. And you see that if you define SVD based on reoperation, you would have had 3.5% SVD at 10 years, which is great. But if you look more at the VAC3 criteria, the stage 2 or 3 SVD, based on the echo follow-up, this would be 41%, not the same story. And this was associated with an important impact on outcome. This was associated with a more than 2-fold increase in mortality. And this is a more recent study, a pooled analysis from the CoreValve IRIS and SURE-TAVI trials, looking at a 5-year incidence of moderate or severe SVD, so stage 2 or 3. They used not exactly the VAC3 criteria, but close. Actually found, interestingly, that the incidence of SVD at 5 years based on this echo follow-up was more important in SAVR than in TAVR, so this is reassuring. And importantly, the occurrence of this moderate or severe SVD was associated with important impact on outcomes. You see in the TAVI group, close to 4,000 patients, this was associated with 2 to 2.5-fold increase in mortality, all-cause cardiovascular mortality and rehospitalization. So take-home message, high gradient post-TAVI may be related to different etiology, prosthesis patient mismatch, valve thrombosis, endocarditis, and or structural valve deterioration. So you have to do the differential diagnosis, and the best way to do that is to look at the leaflets. High residual gradients post-TAVI, so early post-TAVI, has actually no or minimal impact on the short-term outcomes, but may have an impact on the long-term valve durability and outcome, especially if this high residual gradient is more than 20, 25, well, 23 according to the NIDA registry. And it is more the increase, the deterioration in the gradient that is important during follow-up. And this may be related to valve thrombosis in the early years and SVD during later follow-up. And it has an important impact on outcomes. It really does matter, the increase in gradient. And so keep in mind that echo systematically measures higher gradients and smaller AOAs compared to catheterization. And it may, in some cases, overestimate mismatch and high residual gradients. So if echo shows elevated gradients, high gradient at the time of the procedure, the TAVI or valve-in-valve procedure, I think it is reasonable to consider invasive assessment by cardiac catheterization to confirm this finding before considering additional procedures, which of course also have a risk, such as balloon postulation, stent fracturing, or valve-in-valve. And if echo shows high gradient or increasing gradient during follow-up, Well, it is important to look at the other echo parameters, the AOA, the Doppler velocity index, and look at the leaflets using echo and other modalities. Thank you very much for your attention.
Thank you, Dr. Pivarot. And the last speaker is Gregor Patakos, one of the most prominent cardiac surgeons of the new generation of the Greek
With gray hair.
surgeons working in a year hospital, well educated, trained in States, and following the great career of his father, Evstratios Patakos. He is assistant director in both in second cardiac surgery department and the Transcatheter heart valves department. Gregor.
Thank you very much, Dr. Prapas, from an accomplished surgeon as yourself. It means a lot to hear these words. I hope some of them are true, but we'll do our best today. I'm going to focus on TAVI explant for device failure, and I'm going to make this talk a little bit in fast forward so that we can get on and see our live cases afterwards. So what we'll discuss today are the TAVI cases and indications are rapidly expanding to younger and healthier populations, the indications and the methods of TAVI explant, the outcomes of the global experience with this, and some of our cases at Hygeia, including new procedures to facilitate this, including surplus and open basilica. So TAVI, without doubt, is the biggest development of the past 20 years, but we all know nothing lasts forever. Even diamond turns into graphite over billions of years. TAVI durability is unknown. We had Michael Reardon show us some great slides about how things may be changing about our mindset with this. But up until now, we were uncertain about what is going to happen with durability, partially because crimping the valve leads to damage, and partially because we thought that the non-circular configuration of TAVI, with some cases, especially if you have an underexpanded valve, may lead to increased valve stress, as some in vivo and in vitro studies have shown. We all know that TAVI has its own complications. It doesn't always go as planned. We see aortic dissections and other things that can happen, aortic root injury. If we look at the Cleveland Clinic experience with TAVI explant, they've reported 59 patients who required any cardiac surgery after TAVI. This doesn't include only TAVI explants, but it also includes people who, for example, may have had a CABG. 8.5% mortality. These are frequently multi-component operations, with mitral disease being the most common non-aortic indication. We see that they have increasing TAVI explants with time. This is obvious as the number of TAVI cases goes up, so will the number of TAVI explants. When we look at the Michigan experience, they have a persistently high mortality rate of 15%. When you look at their data and they analyzed the cases that they've done, 49% of their cases are not eligible for TAVI and TAVI. And this may be due to coronary height, but it can also be due to things like a predicted patient prosthesis mismatch when the first valve is a small valve. They also saw in Michigan their TAVI explant rate rising with time, 5% at 6 years. And half of their patients, 49%, had a second cardiac problem at the time of TAVI that went untreated, and most of these are mitral lesions. Again, and these are pre-existing at the time of TAVR. One wonders whether they could have predicted that this patient is going to need a repeat operation. We all know that there's a risk of needing an ascending aorta or aortic root procedure. In their case series, this is 29%, with 79% of those being aortic root repairs, 43% being ascendings. Again, this analysis is an STS database analysis by the same group from Michigan, looked at 483 patients. I think, we don't need to get lost in the details, but again, you see an 18% 30-day mortality with self-expanding valves requiring more surgery of the ascending aorta or aortic root, 22% versus 9% for the balloon expandable valve. I think this figure is important, especially for the interventional cardiologists. The cardiac surgeons know this, but on the left-hand side, you have a sapien valve. On the right-hand side, you have an Evolut. And, we've done explants of both of these valves And clearly for a cardiac surgeon, it's a little bit more challenging, or at least you need to clamp at a higher level when you have the Medtronic Evolut valve. This is a systematic review and meta-analysis that looked at 1,600 cases. And again, you see a 30-day mortality of 16%. The time interval from implant to explant was roughly a year, and the concomitant procedure rate was 53%, giving us an idea that perhaps some of these patients had pathology that at the time of index TAVI, maybe it should have been treated, maybe we knew that this was coming all along. There's now an international registry for these cases that, again, as can be predicted, shows an increasing number of cases per year. That being said, it's not a huge number. When you have 42 centers and you only had 72 cases, that's only 1 or 2 cases per center. And most of these are occurring within the first year after TAVI. Perhaps the fact that endocarditis is one of the driving forces behind this is the reason for such early cases. And you can see the indications here, SVD, PVL, endocarditis, and these are the reasons why a redo TAVR and TAVR couldn't be done. Most of it has to do with PPM and unfavorable anatomy. As we said, the survival for these patients is not that great. This is a pretty bad survival curve here when you look at 12 months and 77% alive. This is the reason Gaurav Elawadi and Karen Kim, after analyzing all of their own data, said, you know, we need to be really careful when we have low-risk patients and we perform a TAVR procedure. I think it's okay, and they think it's okay if, you know, that's going to be the patient's only valve. When they're going to have another case done, we need to really think about this. This is a case example of a TAVR explant performed at Hygeia for a TAVI performed at another center. So we were able to get the fluoro of their case. So they had a really calcified case, really calcified valve and root. Their valve was severely compressed by calcium. They didn't pre-dilate. They're trying to reposition. And this is the final result. We can see a kind of crunched up, for lack of a better word, TAVR valve that has both transvalvular and paravalvular leak. They decided to balloon valvuloplasty this valve. Didn't really help that much. So the patient, we can see a CT scan where you'll see that the valve is severely compressed in the aortic root. It's not taking up the entire space. Patient comes to us with severe dyspnea with minimal exertion, severe trans and paravalvular leaks, PA systolic pressure of 100. This is the chest x-ray prior to surgery. We were lucky in that most cases do not go this smoothly. I want to show you a smooth case in the sake of time. So this is what it looks like when you take it out only 30 days later and it hasn't really had time to incorporate into the root. We're exploring the root to make sure that there's nothing stuck down there. Cold water lavage, mobilizing the valve from the aortic wall, almost there and getting it out. A little gentle tug is the final pull. And you can see this is very interesting. After the valve's been in there 30 days, folded improperly, even under the pressure of water, you can see 2 of the leaflets will close. The third one doesn't close due to what's happened to the stent frame. So you can see this severe distortion. I think this is a teaching point. Obviously, I'm showing you the worst case. Obviously, you know, this is an extreme outlier. But I think, you know, as all of us are implanting these valves, it's important to know what happens if you don't take the right step. And I think our interventional cardiologists are always surprised at the amount of calcium that we remove from these roots. Patient had a good hospital course and went home later. There's some now newer surgical procedures to facilitate TAVI, and these are the surplus procedure and the open basilica procedure. I'll show you one of our surplus cases. We haven't done any open basilica, but I'll describe what that is. So this is, I think, believe the first publication of the surplus procedure for redo TAVI. So this is when you essentially cannot perform a valve-in-valve. Surgically, you resect the leaflets, clamp the aorta, stop the heart, remove those leaflets. And this is what the surplus procedure looks like. In their case, this is our case, a 92-year-old lady, diabetic, hypertensive, bad lung disease. I think it's very reasonable at age 86 to give her a TAVI. However, she comes back with severe TAVI stenosis, moderate regurgitation. She's not a candidate for TAVI and TAVI, not even with a chimney procedure. We discussed this with Bob Bileros, who's our good friend out at Emory, and decided to proceed with our first surplus procedure. So you can see the aorta is cross-clamped. We're removing this valve very calcified leaflets. I was surprised how calcified these leaflets had become in only 6 years. It took a rongeur to remove them. And then you can see, obviously with an open chest, an open procedure is kind of interesting to implant a sapien this way. We put the valve in there. This is another procedure that can be used to facilitate a TAVR. This is kind of a true hybrid procedure. So this is the open basilica procedure, which essentially consists of removing the leaflets of a surgical valve through a standard way, and instead of going in there and possibly in some cases that might be a little bit more difficult, digging it out, just going ahead and implanting a transcatheter valve. I think it's also important to not only talk about the negative aspects of TAVR, the difficulties that it can have. This is one of our earlier cases. Since then we've done other cases, but this is one of our first cases with transatrial valve and MAC. So this was a patient who couldn't essentially have any operation. We felt that this patient was too high risk for a purely transcatheter valve and MAC case, so decided to perform this case in a hybrid fashion. This is the first case performed in Athens, at least. There have been other cases done in Thessaloniki. So even a 19-millimeter sizer wouldn't fit in there. We did a balloon sizing with a 20 valve and selected a rather small valve. Since then, we've never used such a small valve again. We placed a couple sutures wherever we could. Here we have the chest open. We're lining up the balloon. This is a real heart team case, and because it was our first case, we had all the members of the team there essentially. Implanted the valve, had a pretty good result, only one very small paravalvular leak we didn't feel was significant enough to go back on pump for. Good leaflet motion of the new valve, good hemodynamics. I think the conclusions are this. I think the takeaway from this talk should be that TAVI is a wonderful procedure for the right patients. We have to be very careful before performing this on younger, lower risk patients. There are still some young and lower risk patients that this is appropriate for, but I think it's just very important that we discuss this. And TAVI explant is rising with its concomitant high mortality. It's a very complex and high risk procedure to explant the TAVI, and maybe the cardiac surgery specialty of the future. That's something that all of us as cardiac surgeons are going to be seeing and dealing with and discussing at our own cardiac surgery meetings as well as at the transcatheter meetings. Thank you very much for your time.
Thank you, Gregor. I think there will be a new field for the cardiac surgeons, and it's very clever to remove just the leaflets, not the whole device, because this will be a good structure in order to put another valve inside.
Thank you.
The problem maybe will be the coronary.
Yeah, coronary osteo, what we'll do with that. Yeah.
Okay, I think you have to continue from there in
Dr.
order to present the
He's here. Yeah.
case 6 is a TAVI case.
Yeah. We'll have Dr. Katsianos come up here. He's going to give us the history, and I think we'll all discuss, as this is a surgical and transcatheter case.
Thank you, Dr. Patakos. Good morning, dear colleagues. I'm happy to present our next case. It is an 83-year-old male patient, BMI 25.4. In the last month's NIHA Stadium 3. In the transthoracic echo, we see a Vmax for 4.2. We see a high peak and mean gradient, AVA for 0.64, EF for 60%, and we see a pass from 55 millimeters of mercury. For the previous cardiac history, a PCI, the LAD 2019, atrial fibrillation, elevated blood pressure, PCM, IDTM. The vascular history, PAD with stent in the RIA, then complicated by hemorrhage and requiring surgical correction. The medical history, additionally, CKD and COPD. Other video is a bit slow. We see the parasternal long axis, the heavy calcified valve, atrial valve. aortic valve, sorry. We see the mild regurgitation of the aortic valve. Go a bit fast forward. There is also regurgitation of the mitral valve. We see the transesophageal echo imaging with a very small opening of the valve in the short axis view. And the regurgitation of the mitral valve. And now we can proceed with the imaging analysis.
So I think, you know, we've all done a lot of these. I think it's just important to show it, and we'll go on to the live case. Just to give you an idea of the aortic root anatomy, we have the CT scan and reconstructions. I think it's important when you think about access in these cases that we're really evaluating every single possible access site. And so we've really expanded things these days from transfemoral, transapical, transaortic, transcarotid. There's a transsternal for a while that some people were doing, essentially going to the innominate artery, which I thought was one of the more interesting ones. And obviously transcaval is there, transcarotid I mentioned, and transubclavian, transaxillary, every way you can get to the heart, somebody's put in a valve. So for us, one of the things we think about when we're looking at whether to do this transaortic is, you know, do we have the length needed? And I think we can go on and show the live case. And we really want to make this, you know, interactive. Dr. Perez, when you have a case that's not going to be transfemoral, what's the protocol at the Onassis Heart Center? What do you personally prefer, and what do your cardiologists push for? I want to ask both because we don't always see eye to eye on this. What is your viewpoint?
Well, yes, we do have a heart team, but it depends how you translate it sometimes. You are doing a great job here in IGEA. I think the preference of our expert cardiologists are to go through a subclavian, left subclavian artery access. And most of the time, to be fair, it's an easily accessible artery. It's rarely that much calcified and problematic. Of course, there is the group of patients that do have subclavian stenosis. They're becoming more and more frequent as our group of patients is aging. So yes, a transaortic is a great option. Final option, if there are absolute no's for our cardiology team, is, because this is not a fully porcelain aorta, as I can see, is a minimally invasive implantation of a stentless Perceval valve through a very high aortotomy. And that is also obviously a high-risk case, but it is feasible, and we have done quite a few of those.
So you mean just an on-pump rat Perceval case? Yeah. Okay. So we're going to be looking at the procedure now, and I think it's more interesting and a little bit better. We'll discuss that. Obviously, we're performing the initial steps. We do a small J sternotomy, as I think most people do, to do a transaortic. You can do a right thoracotomy as well. It's just a matter of patient preference. With the wonderful talks that we've seen by Dr. Kafidis, who I see here in the audience as well, we have gone to doing an endoscopic procedure. I would like, if we can get a microphone or get Dr. Zacharoulis up here as well, to tell us his preference for cases that are not going to be transfemoral. I just wanted to give the introduction, so as we're watching, we can see with the surgical procedure that's going on. I'm not going to describe this play by play because I think everybody here has done one of these in their center, but kind of a good background to have a small chat about alternative access TAVI. And, you know, I think every center has a different algorithm, which is interesting.
Great, thank you, Greg. In regards of how do we access the patients who have no femoral access, which is the case here, as I understand, is that for us, transaxillary access is the way to go in most of the cases, I have to say. We have been able to implant also from the left and from the right subclavian axillary artery, and surgical cut down is up to now our preferred way to go. We are very happy to have good cardiac surgeons and friends that are very happy to help us with that. and we've been very successful. The other important thing I would like to stress is that when you have these cases, it's very important that you have a very good CT scan. First of all, to see what is the angulation, what is the angle of insertion of the subclavian artery to the aorta, and what is the distance that you have there. And I would also like to stress is that what is it could be a populated region there. You could have leads, you could have Lima going into the LAD. So these are things that you have to take into account before deciding to proceed from the left or either the right.
I think most of us would consider the Lima to the LAD being there as a contraindication to the left side. Would you agree with that?
It is, but in some cases, if there is room, you could do that. I mean, if you have, if there's no other way to go and you have to go there, you could do it. Well, we've done a case. It's stressful, I have to say. But also you have to consider the transcarotid axis. Yeah. It has been shown that for some reason, I don't know why, but it seems that it has a little bit less stroke.
Yeah,
I think
once we start talking about routes that are not transfemoral, I think we need to pay attention to the stroke risk, because with subclavian it has been shown to have a slightly elevated stroke risk, and I think we also need to pay attention to the trials that showed that if you're going to be opening the chest, perhaps you're losing a lot of the advantage of doing a TAVR in the first place. So you may want to reevaluate just doing a surgical AVR for whatever reason. We have a lot of surgeons here in the audience, and if we can get a microphone to them, Dr. Kofidis, Dr. Reardon, and whoever else would like to chime in, we would love to hear the experience from your centers. Dr. Reardon.
Well, you know, I actually helped Medtronic develop the direct aortic years ago, and at one time we were doing 12% of our cases like that. I haven't done a direct aortic or transapical in years now. If we can't go transfemoral, our next is left carotid, then left subclavian, and then transcaval. There's very few reasons you need to go in the chest. If you need to go in the chest, you probably ought to be thinking about operating these people, because you lose most of the real advantage, unless they're really a real elderly patient. But you know, it's almost never used in the current day.
Great, thank you, Dr. Kofidis. At your center, if it's not transfemoral, what do you vote for at your center if you're not going to be doing transfemoral? Do you have a preference?
Yeah, axillary indeed. But I have to recognize the fact that there is an increased tendency with us and other centers to take the hybrid approach. I like your valve in MAC, which you've shown.
Thank you.
Basically, I'm giving them the endoscopic axis, a 2-centimeter axis, just to have direct camera view, and then they can access everything.
Yeah.
Aortic valves, mitral valves, and so forth. Yeah, we've been doing that increasingly. Valve in MAC, valve in valve, and so forth.
Yeah, I think as you showed us yesterday, you know, having a camera there really facilitates your approach. The one thing I think you lose a little bit of is your tactile feedback, which we're so used to as cardiac surgeons looking for a soft spot on the aorta. But I think with the quality of CT scans we have today, you know, perhaps we don't need that anymore.
It's a matter of good communication and interaction with the cardiologist, because obviously while the endoscope is positioned, you know, you hold the introducer yourself, and the cardiologist deploying with the other hand, and he guides you on, you know, how to pull, how to push, and at which point exactly to deploy. So it's a very good and tactile communication.
Yeah, wonderful. Dr. Spargias?
Just to describe that now we're in the phase of advancing the valve through the safe. I believe it's 26 millimeter sapien ultra valve. And just to remind you that this case there were no subclavian option, because there were a lot of calcification and small diameters everywhere. And it's interesting how the preferences vary from center to center depending on their experience and the composition of the heart team. So we had yesterday Dr. Vellano saying how his team moved away from subclavian to carotid, which I think is something I'm hearing more and more. I think it happens more and more often lately. So I want to ask about your experience on carotid, and because we heard yesterday that the composition of the features of these arteries are very different, and that the carotid is more similar to the femoral artery and more predictable in terms of complications compared to the subclavian, which embryologically it's a different origin from the other arteries, and this is something our vascular surgeon also told us. So he doesn't like to use the subclavian for this reason. He doesn't like the subclavian for some reason.
And I think you bring up a good point. In the US, you don't really have vascular surgeons involved in the heart team. In Greece, it's mandated that you have a vascular surgeon involved, I think because not all cardiac surgeons are comfortable with the femoral artery, perhaps, or the axillary. Perhaps that's the thought process. Perhaps the thought process is to be more all-inclusive. Dr. Reardon, you had some thoughts on this?
We were part of all the early core valve trials, and our second access was always the axillary, and we've kind of gone over to the left carotid. It takes a while as a surgeon to get used to the fact you're not going to stroke people. I mean, you get really worried that you're shoving this big thing down the carotid artery, and you're going to occlude flow, and they're going to stroke. It's really a lot lower. It's a much easier access even than the axillary. I do a lot of axillary, just got to do a lot of arch work, but it's really quick and it's really easy. There are some tips and tricks that you need to learn to do, but Keith Allen has written a whole lot about this. But once you do a couple of them, I think you'll probably switch over to the carotid. It's an easier artery to use. It's quick. It's easy.
When you're using the axillary, I assume you're sewing a graft on?
No.
Is that right or no? You're going directly?
No, never sew a graft on.
You're not sewing a graft on?
No,
okay.
Well, just to completely agree with your great experience, we find the carotid a very easily accessible artery, and that's what we've been using for years. We've shifted from subclavians and auxiliaries for the dissections, and we find that we protect the brain much easier. In fact, we have a big database that shows, in fact, that these patients do much better during the so-called circulatory arrest, which is not a full arrest because the brain is perfused. So we are ready to we usually put a graft, to be honest, on the carotid, because then we can play on both sides. But it's a matter of heart team, as you said, and our cardiology colleagues in my hospital are more familiar with the subclavian. I'm really in full agreement with what you say. If they were prepared to shift to the carotid, I think they would find a much better results, but it's a matter of experience on both sides of the table.
So when you quit using a graft, which is pretty easy to do, the key is don't just shove the big sheath in there. Actually make a slit so you have a nice opening in the artery, and all you have to do is this nice tiny closure. It's quick, it's easy. We early on, I thought I'd put a graft on all my axillaries because that's what I did for my arch stuff, and then we quit doing that. We quit doing it on the carotid, and it just makes the procedure go even easier. You mentioned the supraclavicular. I actually helped Andy Kaiser develop that thing. We were so desperate not to do transapical that we would go to the arch through your neck. So there are a lot of crazy things we thought up early on. But in today's world, there's not many reasons you need to do it. This little tiny thoracotomy really does work quite well. It's just that in today's world, there aren't many reasons we have to. They still come up, so you need to know how to do it. But it's and if you're going to use a sapien, just reload it before you put it in there.
Right.
That's the other key. You don't have enough space to load it in the artery.
Yeah.
But you don't need to do that either.
Right. Perfect. Wonderful. I think, Dr. Spargius, if you have any closing remarks, otherwise we can go on to the next case, perhaps. Great. Let's get the next case up here. And then I think we'll be doing pretty well with keeping on time.
I think we can continue with our next case, which is a very boring case compared to what we've seen now. It's just a straightforward transfemoral case. So, Kyriakos, if you want to present the next case.
I don't think there's anything boring about transcatheter valves. I think that each case, has its teaching points, including, from indications to looking at the analysis.
Mr. Kostopoulos and Dr. Eftihio are here, so you can come over here. Better.
Let's have them come up.
Christos, you can.
So our next patient is a 72-year-old female, a BMI 30, NYHA stadium 2 in the last 6 months. The transthoracic echo, a severe AS and mild to moderate AR, the Vmax for 4.26. We see the peak and the mean gradients, elevated AVA 0.5, LVEF 65%. Additionally, mild MS with a mean peak gradient for 4 millimeters of mercury, ex-smoker. In the CT scan, thorax, emphysematous upper lobes. We see also a Euroscore to 1.9%, STS mortality score 1.83%, and STS morbidity and mortality 8%. The X-ray of our patient, we see here the elevated, the Vmax 4.89. And this is the mild mitral stenosis. We also see the small regurgitation of the aortic valve, heavily calcified. And here in the 3-chamber view, we see also the regurgitation of the heavily calcified aortic valve. The coronary angiography with a diffuse CAD, the dominant right coronary artery. And now we can proceed with the imaging analysis.
So, Christos, what is your assessment of this case imaging and your proposal for treatment? So we see it's a small area on CT scan, less than 300 square millimeters, and a perimeter of 62, if I remember well. Small anatomy, although the lady is not slim. If you remember, the BMI was 30. It's a high possibility of PPM, especially after surgery, for a patient of this body type. Christos?
Yeah, I'm waiting for my slides to come up. All right, great. So from the echo imaging, there's severe symptomatic aortic stenosis, mild MS, left ventricular hypertension, normal LV systolic function. Nothing to comment on the coronary angiography. And let's go to CT. So from the peripheral arteries that I always look first, you can see that there is calcifications and atheromatosis on both iliofemoral arteries, but no significant stenosis. Probably the right femoral axis is better because of a lower bifurcation and probably less calcium at the puncture side. Now the annulus appears to be a small anatomy here with a diameter of 18 by 22, mean diameter 20, an area of 300 square millimeters, and a perimeter up to 62 millimeter. Large enough sinotubular junction, 26 by 26, and large enough sinuses of Valsalva with 30 by 13 by 31. The coronary arteries are high enough. The right coronary artery osteum is at 11, the left at 12. Right coronary cusp height 15 millimeters, and the left side is 19. So no significant issues from there either. Now for the viewing angles, the aorta angle actually is only 40, which is not a horizontal aorta, which is also good news. And both the coplanar view and the cusp overlap view are comfortable to work with. The coplanar view is at LAO15, cranial 5, and the cusp overlap view at RAO17 and caudal 15. I always like to have a look at the shape and the size of the outflow tract. I know this image here is for the bicuspid valves, but it's also important, especially in small annulus, to know how smaller the outflow tract is becoming below the annulus level. Now, maybe I should show this slide first, because our main concerns here is that we have an overweight patient with a rather small annulus, so we should try to avoid patient-prosthesis mismatch, and it's a relatively young patient, and we should ideally try to maintain future access to the coronaries. I believe all these three platforms are suitable. My first choice would be a 23 millimeter Evolut Pro Plus with a coronary alignment, of course, and a rather high implantation to avoid a pacemaker. The accurate neovalve is also an excellent choice for a small annulus with low risk of a pacemaker need. It's a single-digit pacemaker in our center. You can do coronary alignment as well, and you can have a good future coronary access. But also the 20 millimeter Sapien 3 makes an acceptable choice with a slightly higher risk of a patient-prosthesis mismatch. Thank you.
Thank you, Christos. Now, Donis will tell us his preferences, assessment and preferences.
So I would disagree that there is no simple TAVI case, because every TAVI case may be simple, but you never know what the outcome will be. So you have to be prepared for everything. So regarding this patient, for me, if we see her age, she's 72, so we have to select the valve carefully in order to have coronary access, because she is very young. But also, because we do not know yet the durability of the TAVI valves, we must be able to foresee if there is a problem, if there's a degeneration, what will be the second valve that we have to implant. So regarding this, that we have to think always of the second valve if we are ever going to implant, we have to see that for the small annulus, so we have to look at the hemodynamics. So for my choice, I would rather go with a self-expanding valve, an Evolut or an accurate Neo. It depends on the experience of the center. I would not probably go with the Sapien 3 Ultra, but I'm really looking forward to what you decided to do with this case.
Okay, let's start the video, and if we can dim the lights down a little. Just dim them down, yeah. So, okay, we went directly to the orthography. So, although it's a small anatomy, the sizing in the root, aortic root, is quite large area and acceptable to all three devices you described earlier. What is noticeable here is the calcium in the mitral valve annulus and the mean gradient of 4 there. So there is some mild mitral valve stenosis. And if you remember, there was calcium extending in the anterior mitral valve leaflet. So you wouldn't like to compress the anterior mitral valve leaflet with your device, because this might increase your gradient. So this is valvuloplasty with a 16 millimeter balloon. So you can see that the 16 millimeter balloon almost completely seals the annulus. There's no regurgitation, very minimal below that. So our choice here was a 20 millimeter Sapien 3 against your recommendations with 2 ml volume on top of the nominal. And the reason was that the anatomy was really small, so it was below 300 millimeters, and we didn't want to have like a deeper implantation to compress the anterior mitral valve leaflet. And also, I should say, our experience with the small Evolut valve is not very great. So when it comes to the 23 millimeters, our experience, almost all the valves we did TAVI in TAVI with Evoluts were 23s. I don't know if this is just a simple coincidence. So here is the positioning. So you see where the middle of the valve is a bit higher than the annulus plane. And here should be the fast pacing, last test, and inflation of the valve. Can we put it fast forward? Do we have this option? Okay, this is the aortogram. You see the position is almost perfect, just a little bit of the valve below the annulus. You see there is space above the valve to engage the left main or to do TAVI in future if you have to. Why we see that again? Can we just fast forward, please? Okay, that was the post-dilatation that we missed. So we also did a post-dilatation to make the valve more straightforward. You see there's no invasive gradient here, pure invasive gradient, and very good diastolic separation of the LV and the aortic pressure. And we should see the echo on the other side. There's no regurgitation on the echo. As you can see, the position of the valve is the expected. And we should see now the measurements. So this is about 2, the velocity. So this comes down to the presentation of Dr. Pibaro earlier. So we have a mean gradient of 9 and a maximum of 20 on echo, which is very acceptable. So our prediction of PPM didn't happen in this patient. And we'll see now the DVI calculation here, which should be fine. Okay, and this is the completion of the case, the removal of the cyst. And I think we are close to finishing this case. If there are any comments, please, now is the time.
Christos, Adonis.
No, it's a great result with very low mean gradient, and I wonder how predictable can this be sometimes. But I remember when we used to have only the Sabian platform, and we were implanting the 20 millimeter Sabian 3, and now that we have in our hands in both the Boston and the Medtronic, we try to avoid to put in 20s, which is probably not, we shouldn't. I mean, you've showed very nicely that you get really nice hemodynamic results with the 20 millimeter Sabian 3 as well. This comes to match with the previous talk by Ibarot, showing that not just the gradient, it's other things as well that you need to have in mind.
Well, I'm sorry Piro's not here because he and I argue about this all the time. So first of all, you got to really know, the patient has some mitral stenosis, so you need to know what your left ventricular stroke volume index is. And if it's down, you're going to have a low thing. Abbas always shows these things that people with low gradients don't have a loss of life, whereas the people with higher gradients do. The problem is that group of people with really low gradients is filled with people that have low stroke volumes. And if you have low flow, you're going to have low gradients. But if you have low flow, you're also going to die more often. And so it then balances those people out. And so when I see a case like this, one of the first things I want to know if you're using something like a 20 S3 is, what's your flow? And if your flow's low, you're going to have low gradients, but that's just part of what goes with it. So you got to be kind of careful. And we also need to get beyond the idea that somehow pressure recovery is a good thing. Pressure recovery is not a good thing. Pressure recovery is actually a bad thing. Pressure recovery comes only because you have stenosis. Pressure recovery comes basically just from thermodynamics. You can't create or destroy energy. So when the ventricle builds pressure up and it's higher than the aorta, you have potential energy. When it moves to the aortic valve, you develop kinetic energy, so you give up potential energy and your pressure goes down. When it gets through the valve, it slows down again, so the pressure comes back up. But the work the heart's done in getting that blood through that valve has already been expended. You don't get any of that work back when the pressure goes back up and the gradient seems to be less. And so we need to get into the concept that what the heart cares about is the amount of work it does. So what you're measuring with your echo, that's the force the heart's using to get the blood out of there. That's the work that the heart's doing. And it doesn't come back when the pressure goes back up again. And so pressure recovery is just nothing but a sign of stenosis. So we have to be very careful when we kind of listen to, I mean, Philip Piro is a very bright guy. I'm sorry he's not here. But there's a lot of nuances that go into these things. So you got to be very careful. Remember, it's all about flow. Flow is what keeps the patient alive.
I just would like to correct something. This actually was a 23 Sapien Ultra valve that we used on this case. We used a 16 balloon for a very conservative pre-dilatation, but we did see there was significant regurgitation on that, so that's why we used the S323. The original inflation volume was minus 2.5, so very under inflated S323, and the post-dilatation was with minus 1.5 mLs. We had an excellent outcome in hemodynamics, but I'd like to correct for the accurate size of the valve. Thank you.
I'm sorry, I fooled you. I didn't have this data in front of me, so
Yeah,
Michael came down and corrected me. So this is a result with a 23 valve, not a 20. Yeah, I agree we avoid to put 20s. Yeah, that's true. Okay, so I think it's time to close this session, and I would like to call the panel for the next very interesting session, moving to mitral and tricuspid. Thank you.
and gentlemen, good morning. On behalf of my co-chairs, Dr. Garambinos and Dr. Tsolakis, I welcome you to this very promising session of mitral and tri-tier outcomes, how to optimize the results of mitral and tricuspid tier. We're going to have 4 presentations of 12 minutes each, and then we're going to discuss 2 interesting cases. The first speaker will be Professor Pras from Bern University, and he's going to talk us about the patient selection and outcomes of mitral tier in functional mitral regurgitation. Professor Pras.
Good morning, everybody. Thank you very much for the invitation. Let me share my screen, and thank you. I think you can see it now. And thank you for the invitation as well to speak about this very interesting topic on patient selection for edge-to-edge repair in secondary mitral regurgitation. So I like to start by looking a little bit at the situation in Europe and concerning the treatment of secondary mitral regurgitation. And as you can see, even after the introduction of edge-to-edge repair for the treatment of secondary mitral regurgitation, these data are for, you see on the right side in green from 2019, you see that still a minority of patients is getting treatment. This about 1/4, we have to say, in Europe. And this is probably something that is still concerning because we have a lot of patients with secondary MR who are not sufficiently treated interventionally. In the US, the situation is improving a little bit. You see on the right side the data from the TVT registry, and you see that after the publication of the COAPT data in 2018, the number of procedures has increased a lot, mainly for the treatment of secondary mitral regurgitation. So a positive development there, but still a lot of effort to be done for a better treatment of patients with secondary mitral regurgitation. What do we have? We have different treatment options actually that are approved. Edge-to-edge repair, that would be the main topic of my talk. But we also have indirect annuloplasty with a carry-on device that is implanted through the transjugular access to create a reduction of the annular dimension. And finally, actually, we also have transcatheter mitral valve implantation, an indication in secondary mitral regurgitation that is decreasing, probably because also this device is introduced by the transapical access, which is a difficult access in patients with heart failure, but also some data for transcatheter mitral valve implantation. So let's concentrate a little bit on edge-to-edge repair. And of course, the first pillar when we talk about patient selection of patients with secondary mitral regurgitation is medical treatment. Medical treatment is very important and actually a condition for the selection toward edge-to-edge repair. You need to be installed. You need to have a combination of different treatments and drugs, as you can see here, providing actually the best reduction in terms of relative risk of mortality. If you compare this in patients, of course, with treatment in the COAPT population, if you compare this with MitraClip, you see that MitraClip is an additional treatment option on top of medical treatment, providing an additional relative risk reduction of mortality of about 37%, with a number needed to treat from 6 in the COAPT population. So a really large effect in terms of mortality reduction on top of everything that can be done on the medical part. I like to show this as well to make people realize also that the amount of mitral regurgitation reduction is much less using medical treatment and resynchronization. If you look at quantitative values, you will have a reduction of about 30 to 40% in terms, for example, of regurgitant volume or PISA, regurgitant orifice area, in using medical treatment or resynchronization in a minority of patients, only in about 40% of the patient, while transcatheter edge-to-edge is providing you 80% reduction in 95% of the patient. So a much more effective therapy that really target mitral regurgitation in this patient. every decision in terms of treatment need to be done in on a multidisciplinary way. Very important for a secondary MR patient. It's an extended heart team, including an electrophysiologist to determine the indication for resynchronization, but also heart failure specialists to look at the optimization of guideline-directed medical treatment. I don't want to come back in too much details. There have been a lot of discussion regarding these two studies. COAPT on the right side showing a tremendous reduction in terms of hard endpoint, mortality and heart failure reduction at 2 years, and with the same follow-up, MITRA-FR, as you know, no differences for the same endpoint. And the reason for that have been extensively discussed. But I would like just to remind you that the inclusion and exclusion criteria of this study were different. COAPT included patients with less advanced heart failure, less dilatation of the left ventricle, less damage on the right side, less tricuspid regurgitation, and also less probably pulmonary hypertension. And of very important point, there was also a monitoring of the medical treatment and eligibility committee in COAPT, while in MITRA-FR, everything was left at the discretion of the investigator. And this had consequences on the baseline population. You see that the patient in COAPT had more mitral regurgitation, less dilated left ventricle, and finally also a more durable result in terms of MR reduction. And if you look at the quantitative distribution of mitral regurgitation severity, most of the patients in MITRA-FR had less than 30 square millimeter of regurgitant orifice, while it was more than this in 87% of the patient in COAPT. So a different distribution of mitral regurgitation severity. You may have seen this data published in the New England very recently and presented by Greg Stone at ACC. Very interesting data by two aspects. I would like to mention here of the 5-year follow-up of COAPT. On one side, a very high mortality in both treatment arms, which is a very important information, I think, and it's not unexpected in that population of elderly patients with secondary mitral regurgitation. But the second information that is very important is the curve in orange, which has a crossover patient. This patient could were in the medical treatment group and could get MitraClip after 2 years. And you see that even with delayed treatment, you are able to reproduce the study in the crossover patient. This patient fall on the curve of the device arm and benefit from a reduction of mortality even after 2 years. So a very elegant way to reproduce a result of the study after crossover that makes, I think, the data extremely solid for that population of patients. Are the COAPT criteria effective and useful? The answer is yes. If you apply these criteria retrospectively on a big population of secondary MR patients, you will be able to define two groups of patients with different prognosis after edge-to-edge repair. But the point I want to make here is that even patients without these criteria or not fulfilling the COAPT criteria benefit from a symptomatic point of view. You see it, COAPT ineligible patients had also a significant improve in terms of 6-minute walking distance. And this is reflected also in the guideline with a 2B recommendation beside the 2A recommendation for the COAPT patient. For other patients that do not fulfill this criteria but could benefit from symptomatic improvement after edge-to-edge repair. And there are a few categories of patients I would like to show: atrial functional mitral regurgitation, advanced heart failure patient, and patient with secondary myocardial infarction who will benefit from it. And we have emerging data showing an improvement after edge-to-edge repair in terms of exercise capacity, but also remodeling of the left atrium in patients with atrial functional mitral regurgitation. Certainly a category we need to investigate more and define better. But an emerging indication also for patients. These patients were included in COAPT to some extent, but are very different from the one with a low ejection fraction. And this is an example of a patient with a very low ejection fraction, a young patient that is actually decompensating again and again. And this patient is actually a patient that is a candidate for transplantation. And what we did first as a bridge to transplantation, we did an edge-to-edge repair. You see that the medical treatment has been installed, the patient has a resynchronization. And after treatment with edge-to-edge repair, we could stabilize the patient. He had no need for rehospitalization and could be has been transplanted now. It's now, I think, something like 8 years after the initial procedure. But you see that with that strategy, you are able to gain a little bit of time. You can delist some of these patients, about 1/4 in the mitral bit registry, and you are also able to stabilize them from a symptomatic point of view. So I think a very useful strategy in selected patients with advanced heart disease. And the final data and category of patient I would like to show you are patients with acute or subacute secondary mitral regurgitation after myocardial infarction. Here, classically, a patient with a circumflex occlusion that has been revascularized, and you see then the severe mitral regurgitation that has been treated with clip, and this patient clearly benefit from that strategy in comparison to surgery, because surgery is very invasive in this patient with myocardial infarction and ischemic disease. And if they are revascularized and can get a transcatheter edge-to-edge repair, then you will be able to stabilize this patient and maybe even improve their survival. So relevant, as a conclusion, relevant secondary MR is very frequent disease. Of course, medical treatment and resynchronization are the pillars of the treatment of this patient, but a reduced MR, if MR is present only in a minority of patients, the patient fulfilling the COAPT criteria have actually a very good indication, a two-way indication for edge-to-edge repair. And this is, I would say, in comparison to surgery, also the primary treatment option. The data regarding surgery are very limited for that population of patients. And then we have also other indication I just mentioned: atrial secondary mitral regurgitation, advanced heart failure as a bridge to transplantation, and also patient after myocardial infarction. And of course, multidisciplinary counseling and consultation also of heart failure specialist is needed to treat this patient. Thank you very much for your attention.
So thank you, Professor Pras, for an elegant and comprehensive talk. Are there any comments or questions from the co-chairs?
Thank you for your excellent presentation, very comprehensive. I would like to ask you, all the patients with FMR, according to that are eligible according to guidelines or represent a COAPT patient, may receive MTIR. I mean, there are exclusive criteria according to ECHO. What ECHO criteria you think that are putting a patient out of this treatment?
So if you look at the exclusion criteria of COAPT, then clearly a dilatation of the left ventricle that is more than 70 millimeter in systole is a clear exclusion criteria for this patient. Then the patient with a left ventricular ejection fraction that was less than 20 were also excluded from COAPT. And finally, I think the things we are starting to understand better and better, and that's something I have to say that changed also a little bit my practice. We have to integrate the fact that this patient need really to have severe mitral regurgitation, and probably not severe mitral regurgitation defined according to the previous criteria we had in Europe only. That was the 20 square millimeter for the regurgitant orifice area, but they need to have probably at least 30. I would not say, that this patient that does not fulfill this criteria should be excluded to the therapy. There are other parameters you need to take into consideration, like variability of mitral regurgitation during stress or during exercise. all these need to be taken into consideration. But I think in the patient not fulfilling the COAPT criteria, in the conversation with the patient, you will mention that a prognostic improvement will not be expected in the more advanced patient, but rather symptomatic improvement. So I think it helps you to define a little bit what is the strategy, what are the goals, and also to talk with the patient.
Regarding the morphology of the valve, I mean, if a patient is a COAPT patient, in which this study included patients with moderate to severe mitral regurgitation without quantitating, as you remember. But about the morphology of the valve, I mean, a very short posterior leaflet would be something that would exclude the patient. What do you think?
Yeah, no, that's for sure. You know, I think the factors that need to be taken into consideration are the size of the leaflet, the level of tethering. It may be something, but you know, I think we have done a lot of progress in terms of technical and also quality of the treatment of this patient with edge-to-edge repair. So in secondary MR, there are not so much patients that are absolutely not suitable for that treatment from an anatomical point of view. You will need to be very careful, of course, with short posterior leaflet, and some patients have a very short posterior leaflet due to the tethering. But I think using the new technical option we have, optimization of leaflet grasping, using maybe different device, using Pascal device for very short posterior leaflet, you will be able to treat the vast majority of these patients anatomically.
Do you listen to me now?
I can hear you, yes.
Excellent presentation. I would like to ask if there is any more criteria for the right ventricle before starting this kind of treatment?
That's an excellent question. And what we have to acknowledge is that the COAPT study excluded patients with what has been called moderate to severe right ventricular dysfunction. We don't have a good number for that, and probably we are not able to really look at right ventricular function. You know, when we use only TAPSE, it's probably not sufficient. We have to be aware of that. And these patients are very advanced patients with the consequences of heart failure, pulmonary hypertension on the right side as well. And also, we don't have patients in COAPT with severe tricuspid regurgitation. So we have patients with moderate but not with severe. They were excluded, which was not the case from MITRA-FR. So we need to be cautious and look, more at the staging of the disease, the consequences of the disease. And if a patient has a severe mitral regurgitation secondary plus severe right ventricular dysfunction or severe tricuspid regurgitation, then we have a very advanced patient. But and I just want to make this point, what was not considered, of course, in the COAPT population is that we are now able to treat tricuspid regurgitation transcatheter. So that's something we need to consider as well, and we don't know exactly what can be the impact of that therapy when you treat both mitral regurgitation and tricuspid regurgitation, maybe in a stage procedure, waiting for the improvement of tricuspid regurgitation. But that's an additional tool we now can use to treat this patient on both sides. So it's a bit of a game changer in terms of thinking the COAPT population. But we have to be very clear, patients with severe tricuspid regurgitation or right ventricular dysfunction were excluded.
Thank you very much. We proceed with the next presentation. Thank you very much, Professor
Thank you.
Braz. Thank you. So I call Dr. Asnauridis for the next presentation regarding mitral TRIR in DMR, patient selection and outcomes.
Many thanks to the organizing committee for the kind invitation. So let's move on to the degenerative MR. Here, as the valvular apparatus is a problem, the left ventricle is more or less normal, especially in the early stages of the disease. And it's very important to differentiate between primary and secondary MR because treatment depends on this selection, although it's not always easy. Degenerative MR is actually a spectrum of diseases ranging from myxomatous MR, ruptured chorda tendineae, flail leaflets, and especially in the elderly, tethered cusps with annular calcification may also contribute to this disease. Here's a drawing of a typical prolapse with the leaflet extending more than 2 millimeters into the left atrium during systole, whereas here we can see the typical version of the leaflet tip that we see in flail There are some extreme cases with diffuse degeneration of the valve that we see in typical Barlow's disease. So degenerative MR is the most frequent cause of organic MR. We know from several studies that effective surgical repair provides important survival benefit. However, many elderly patients, high-risk patients, suffer from degenerative MR, and there is significant under-treatment of these elderly patients with degenerative MR. We know that the natural history of chronic severe MR left untreated is not that great. More than 50% of the patients are dead by 10 years after the diagnosis. And we know that there are some stages in the natural history of these patients, and we have to select the right time spot in order to intervene, especially when the pulmonary vasculature gets sick, when we have significant pulmonary hypertension with involvement of the right ventricle. We know that by that time, the patient has likely missed the boat. So the guidelines are very clear regarding which patient with DMR should be offered TEER. The patient must be symptomatic. Asymptomatic patients with degenerative MR should not be offered TEER. The patient must have a high surgical risk, must meet the anatomical criteria for TEER, and futility must be excluded. So which are the criteria for selecting those patients? First of all, we have the typical initial Everest criteria, a flail gap or height of less than 10 millimeters in order to enable adequate grasping of the leaflets, and a flail width of less than 15 millimeters. Here there's an example at the bottom where the height is acceptable. The patient at the bottom will have likely a very good grasping, whereas the other patient at the top, you see there is a great gap, a big gap, which poses great difficulties in grasping these leaflets with TEER. So these are the criteria set by the initial Everest trial. The ideal patient is a patient who has a flail, who has MR in the central segment A2, P2, no calcification, orifice area of more than 4 square millimeters, mobile posterior leaflet, coaptation depth of less than 11 millimeters, and as I said before, a flail width of less than 15 and a flail height of less than 10 millimeters. Is this always the case in everyday clinical practice? Unfortunately, no. Here there is, I'll show you a case that this patient had a broad jet, a gap of more than 15 millimeters. We knew that we would likely end up with putting more than 2 clips. The good thing was that the orifice area was more than 4 square centimeters. Indeed, after we put the first clip, there was significant residual MR. We decided to go ahead and put a second clip. In this time, you have to see whether the second clip would induce stenosis. Due to the adequate orifice area, after the first clip, the mean gradient was 3 millimeters mercury, allowing us to put the second clip and efficiently decreasing the residual MR with this good final result with the good clips. So there are some anatomies which are not ideal but are doable. For example, flail width of more than 15 millimeters, as I showed you before, and sometimes Barlow syndrome with diffuse degeneration of the valve it was initially considered a contraindication for TEER, but in experienced groups and experienced hands, even this anatomy is not an absolute exclusion for a TEER. Team's experience is very important. This paper has provided some predictors of adverse outcomes, predictors regarding the mitral apparatus, for example, an orifice area of less than 3.8, and a distance, mediolateral distance of the LV inflow of less than 33, and a flail width of 15 millimeters are predictors of adverse outcomes, whereas there are some non-mitral apparatus outcomes of adverse predictors of adverse outcomes, such as the severe tricuspid regurgitation, pulmonary hypertension, and dysfunction, severe dysfunction of the right ventricle. In some cases of degenerative MR, the etiology is not that, is more complex. For example, this is an elderly patient we did a few months ago. I think Dr. Dimitriadis will be presenting this case this evening. This patient had a prolapse of the anterior leaflet combined with a tethered and restricted posterior leaflet due to severe calcification of the mitral annulus. So these cases are not ideal, but can be treated with a TEER. So regarding the outcomes, we know from the initial Everest trials that here we can see that the TEER is effective in reducing the degree of mitral regurgitation effectively. We don't have much randomized data. Regarding the, as you know, for the function of the secondary MR, there are head-to-head comparisons between TEER and optimal medical therapy in the COP trial. Such data regarding degenerative MR are missing. So we have some retrospective data, some registry data. This is a study which combined 3 different registries. The middle registry followed patients with severe degenerative MR who were left untreated, whereas the 2 other registries, the mitral switch and the MHI registry, were included patients who were offered TEER. So patients were matched from these 3 registries, and the researchers found that in these patients with primary degenerative MR who were very symptomatic, TEER was beneficial and was combined with better outcomes compared to optimal medical therapy. And the amount of residual MR was a significant predictor of outcomes. If the residual MR after TEER was more than moderate, these patients had a rather grave prognosis. So which are the patients who are currently treated? More or less resemble the characteristics of the CLASP 2 trial. This trial was a head-to-head comparison between the 2 available technologies, the Pascal and the MitraClip. So the patients that we currently treat are elderly, severely symptomatic, high surgical risk. They have comorbidities like renal insufficiency, and most of them had hospitalizations for decompensated heart failure. As far as the MR reduction is concerned, both technologies, MitraClip and Pascal, are very efficient in decreasing the amount MR, and concerning the heart outcomes, it seems that TEER in primary MR is a class effect. Both devices were associated with a very good outcomes and good prognosis during follow-up. This is a German study showing that, contemporary study showing that residual MR is a significant predictor of outcomes, and as I said before, if the patient is left behind with a residual MR of more than moderate, this is a bad sign for his future prognosis. Of course, this TEER is a developing therapy, as we see here in the left, even with complex anatomies of the mitral apparatus, using the newer, larger XTR devices is associated with a significant reduction of the mitral regurgitation. The Pascal is also a very efficient device. This is the Pascal 2 registry. In the previous study, I showed the anatomies which the patients with complex anatomies, for example, with more than 2 independent jets or with severe calcification were excluded. The Pascal 2 registry included all the patients, including those with rather unfavorable anatomy, and it showed that, of course, compared to the patients with optimal anatomy included in the CLASP trial, the patients of Pascal 2D registry had a slightly lower procedural success, longer procedures, somewhat lower reduction of the MR during follow-up, but still, this registry showed that even in complex anatomies, Pascal is doing very well. This is the future. This study is ongoing. Repair MR trial is a study, is randomized trial, which will see whether TEER is better than surgical repair in patients with severe symptomatic degenerative MR who are good candidates for surgery. This study is currently recruiting patients, and the first results will be available, if I'm not wrong, in 3 to 4 years' time. So, who should be offered mitral clip or Pascal device TEER in general among those patients? The patients must be symptomatic, must fulfill the echocardiographic criteria for eligibility for TEER, must be inoperable or high surgical risk, and as I said before, futility must be excluded. There is no point to do a TEER device in a patient which is not expected to live for more than 6 or 12 months. Take-home messages: severe symptoms and high surgical risk are prerequisites for this technology in degenerative MR patients. Avoid futility, favorable anatomy, as we said before, presence of enough flexible tissue, not too high gap, not too wide, no much calcium, no multiple prolapse zones or Barlow disease, and of course enough space to maneuver these large devices. Newer devices can do better even in more complex anatomies, and of course impact of team experience. Team experience is very important in this procedure. Thank you very much for your attention.
Thank you very much for your thorough presentation. From your conclusions, I keep that actually DMR is a surgical disease, and only in operable patients, very well selected, MTEER may have a place. Do you agree?
Yeah, high-risk patients in general, but the population is not that small, I think, because out there are many patients with degenerative MR, especially elderly patients who are not offered surgery.
Okay, of course, we expect the repair. Any questions from the floor, because the time is very limited? Any comment? So, I think we may proceed. Okay.
We can proceed with Professor Kofidis from Singapore to present us a reproducible repair platform using grinding sutures.
Dear Chairman, while setting up, please accept my very cordial thanks and appreciation for having me on the podium today. I'm very delighted to be here in front of friends whom some I haven't seen for a long time. Now, I do thank you in advance for the next 20 minutes of attention, because I'm going to try to take you on a different journey for some content that is the first time to be shown in front of a Greek audience. We just shared that at the Mitral Conclave in New York, and I do invite cordially your criticism, scrutiny, comments, and anything you may have to say. When Alain Carpentier announced his French correction exactly 40 years ago, he had to think laterally. And I must confess, as a surgeon being in the business for 27 years now, sometimes we fail to think laterally. When Carpentier thought laterally and invented mitral valve functional physiological repair 40 years ago, he took some risk. He exposed himself to criticism and scrutiny, but he broke new ground. Perhaps 40 years later, it's time for the Greek correction. Some claim it as the Singapore correction. Some call it the Cofidis correction, but I really don't care. All I care about is that we add value to our patients, we standardize mitral valve repair, and add value to the surgeon's armamentarium, lower the threshold for a surgeon to enter the field of mitral valve repair. Majority of the cases I'm going to show you today were done endoscopically, 11 out of 13. 10 were done in Singapore, and 2 in Greece, in Thessaloniki, and 1 in Italy by the Alfieri Maizano team, so we're entering the phase of validation. You should know that whoever is involved in innovative surgery or innovation, cardiology, whatever, we go from the stage of conceptualization through the stage of verification, where we do it in patients and we show that it works, and then move on to the ultimate stage, which is the stage of validation. That means we wait for long-term follow-ups, or we expose our technique and to be done by other surgeons, independent surgeons, and see what they say. Last point, I take the podium today with the utmost humility and with a sense of responsibility. You should know, these are my disclosures, to the pantheon of mitral valve repair. You see up top, Alain Carpentier, Carlos Duran, Freddie Moore, Randy Chitwood, my teacher, Perrier, Gillinov, Frank Wells, Gilles Dreyfus, David Adams, the great Alfieri, and the list goes on and on. Change and progress is an inherent part of human nature. This was Singapore 100 years ago, and this is Singapore now. How do we do mitral valve repair for the last 40 years? And I must confess, I'm also a Carpentier follower. I'm doing exactly the same things. For example, cord implantations, ring implantations, trying to establish coaptation and a good function of the mitral valve after repair. For the cardiological audience who are not visiting us too often in the operation theater to see how we do the repair, here you have an asymmetric prolapse, for example. One surgeon may put one cord, another surgeon may put the cord there. The third surgeon may use 2 cords or cord loops. So everybody does it slightly different way. Then resect opposite to respect. I may do a triangular resection. Stratis may do a quadrangular resection. Sotiris may do a sliding plasty. Apostolos may do a butterfly plasty, and it goes on and on. When it comes to Barlow's, which is the most complex pathology to repair, it's open to imagination almost. And the Carpentier, the traditional Carpentier techniques, or other people's techniques that added on over the years, they may not take care of adjacent pathologies like clefts, like commissural prolapses, and so on and so forth. You may insert closed clefts, do resections, insert multiple cords. I've seen people trying to repair Barlow with 20 cords in the same patients, using a lot of foreign material. So there is a lot of variability. Let us distinguish between complicated and complex. What is complicated? If we follow exact systemic mechanistic steps, we're always going to reach the result. Complicated is, for example, shooting a rocket to the moon. If you follow the steps, the rocket will land on the moon. Complex, however, is running a country, running a department, running a family, because of the variables and factors that play a role that are uncontrollable and not in our hands. This is complex, and mitral valve is made complex. So here are the pain points. How standardized are the techniques we're using currently? How comprehensive and how intuitive are they? How much variability from surgeon to surgeon is involved? Are they complicated or complex? Do you resect or respect? You use nail cords or loops? Where do you insert them? Here, 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 or here? I was in a mitral conclave and I heard it over and over again. Individual cords tear or calcify because they excite very punctual traction on the leaflet, and that's not very physiological. Why does surgeon XY walk out the operation theater with a different result? Soterios may do a mitral valve repair with his technique, same pathology. I may do the exact same thing. He goes out of the operation theater with a perfect result. I walk out the operation theater with a 1+ or 2. How come? So obviously, there is some guesswork involved. When I developed 12 new techniques for mitral valve repair, which make it simpler, less foreign material, standardized, and can produce a solid result, eliminating the guesswork. I was inspired by, obviously, Greek mythology. I was inspired by ancient Roman architecture. Look, what can support a free structure like the prolapsing margin of a leaflet or a bridge better than the arch? Nothing, not individual columns, the arch. That's an ancient principle because it distributes the pressure, the tension over a large area. I was also inspired by the inverse suspended parametric test by Antoni Gaudí, the famous architect from Spain. So I developed 12 new techniques, ladies and gentlemen. You don't need to memorize all these techniques or like them all. So some of them are good for the majority of the pathologies we're facing. These techniques have been published fast-track by the European Journal of Cardiothoracic Surgery just less than 2 months ago, almost fresh off the press, in part 1 and part 2, back-to-back. And they're available for reference, for your reference. I'll show you a few. The Roman arch. You have P2 prolapse or A2 prolapse. One single running suture. So my principle are running sutures. Enter the anterior papillary muscle with the first needle of your neocord. This is a Gore-Tex cord. By mistake, it was painted blue. The images were produced by an American artist, medical artist. Enter the anterior papillary muscle. Come up to the prolapsing leaflet. In and out 2 times. Come down on the posterior papillary muscle and wait. Do the exact same thing with the second needle. Into the anterior papillary muscle, up the prolapse, travel along the margin of the prolapse, down through the other papillary muscle, and wait. Now you can do whatever you need to do. Put in your ring, close clefts, whatever. Once you are done, you can do your saline test, take 2 hooks, as we do in mitral valve repair, either lift it a bit or pull on the cords, reduce it a bit, and that's it. You see, you don't have to guess whether you put 3 cords, 4 cords here or here, this papillary muscle or that papillary muscle. You follow a standard pattern. So let's see how it works. In the interest of time, I'm showing you cases here, recorded vignettes. You enter this case was done endoscopically, obviously. You see here TK, that's my invented endoscopic camera retraction system that doesn't need to penetrate through the chest. I call it endopsis. That's another invention of ours. That has the camera on the underbelly of the retractor. So no fogging, no spilling with blood, no penetrating the chest, uncluttered operation field. So you see that I went through the anterior prolapse here and down the other papillary muscle. The cord is waiting there. Same with the second needle. In the interest of time, I move forward. Then you put in your ring, as we always do. This is a semi-rigid ring at the anterior leaflet. We clip it using the Cornot device. I do my test. I adjust. I'm happy. And we close. And here's the final result. Regurgitation gone. Very good coaptation. Let me show you one for the posterior. Again, in the interest of time, I skim through the video. Same. Enter through the anterior papillary muscle. This is a flexible retractor of the leaflet, so you put it in so you can have access to the papillary muscles, invented by my good friend Ingo Kuchka from Hanover. So, out the posterior papillary muscle, you do your test, you have a good smiley face there. The test is okay. I hope to be able to show you the final result. Regurgitation is gone. Let me show you the next one is the crescent technique that captures P1 and P3 as well, same concept. I like that very much. I discussed it with Alfieri when we did the first case in San Raffaele in Milan just a month ago. It's up for publication in the journal as well. You know the Alfieri stitch, a bit of an unphysiological salvage stitch, which divides the orifice into two orifices, anterior leaflet with posterior leaflet. I'll show you something I believe is more physiological for, let's say, A2P2 prolapse. Enter with one single vortex, enter the anterior leaflet, come down the papillary muscle, exit on the posterior leaflet, tie. So basically, if you look at it from the side, it looks like a V, a Roman V or a Roman 5, okay? And that takes care of the anterior, takes care of the A2P2 prolapse. The closed omega technique. The Longhorn technique, I'll stick to that a bit. The Longhorn takes care of whatever leaflet you pass it through, either posterior or anterior, and I found it very useful in Ballot's disease. Instead of putting 12 cords, 15 cords, and trying to take care of all this subplus tissue, go in through the commissure, under P1, papillary muscle, through the prolapsing leaflet, down the other papillary muscle, out the other commissure. Put in your ring, do what you have to do, wait until you test. You can do it with a ring inside as well. The Argo technique, the Nessie technique for two leaflets, the square technique, which approximates the two papillary muscles in terms of in dilated ventricles with ischemia. The corset technique, because it looks like a corset of the Belle Epoque era, which takes care of your papillary muscle, your prolapse, and your dilation of the annulus. I'll show you a corset. You see the obvious prolapse here, extensive, and I don't care how long is the prolapse. I don't need to guess how many individual cords I'm going to put in. You go in through the anterior papillary muscle. One needle, one Gore-Tex needle will come out the annulus right away here. You can use pledgets or non-pledgets. You can lock it or not lock it. I'll leave it to you, up to you. One Gore-Tex needle went under the leaflet and came out the annulus here. The other Gore-Tex will travel along the prolapsing leaflet, down the posterior papillary muscle, and out the annulus. Then the two Gore-Tex will travel and meet along the annulus. And basically, you tie them after implantation of your ring, as you see here. It's a pattern. You don't have to guess. So you see excellent postoperative result. The buffalo head or minotaur technique, the phoenix technique, anvil technique. Here is, for example, a posterior leaflet prolapse. Another case, a 3D demonstration of a very extensive posterior leaflet prolapse. Again, the principle of the retractor we have invented, the endopsis system, where the camera goes through the shaft, clips under the underbelly of the retractor blade, and it's there. You have a beautiful wide-angle view without any of the complications you face when you move the big camera that goes through the chest. So here is the case itself. Big P2 prolapse. Again, the first Gore-Tex flows through the margin of the posterior leaflet. It will go into the posterior papillary muscle. There you go. And the second needle follows the same pattern along the margin. In the interest of time, here is the postoperative result. Mitral regurgitation gone. Good coaptation. The modified Longhorn technique, I think that was a case done in Greece. You see a multi-scallop, multi-segmental prolapse, a Barlow's or a form-frust. That's the concept of the Longhorn: commissure, papillary muscle, prolapse, papillary muscle, next commissure.
Αρχικά, μπορείτε να συντομεύσετε λίγο γιατί έχουμε τα δύο περιστατικά.
Okay. So you follow the pattern, your repair is done in the interest of time. I'll show you the end result. A very solid repair. That was the case that was done in Italy. I wasn't present. Independently, it was done with a median stenotomy, this one with, again, very satisfactory result. In the interest of time, I just move on. So the techniques I propose are simple, standardized, and more intuitive. They involve all structures of the valve apparatus. They use less cords, less foreign material. They reduce variability and make it accessible to surgeons, both seasoned as well as junior surgeons. There are many ways to skin a cat. Try those techniques, get back to me, tell me what you think. I'm open for discussion and comment, and I hope they will be validated. Or we surgeons, we should just think and produce better prostheses. I'll close with a message for the next time eventually. These are the prostheses we're using on the market right now, mechanical, biological, but this is how the human mitral valve looks like. We are implanting washing machine valves in a very delicate structure. So this is how a mitral valve looks like during repair, scalloped, D-shaped, flexible annulus. So the concept we're proposing in the valve we're building now, which I call the avatar, is we take the scans of the patient. It's going to be the first personalized and biomimicking natural prosthesis on the planet. We make it and we send it for implantation. Here, for example, I'm just showing you data from Irvine, where I just came back from. We're testing it preclinical according to FDA ISO standards. Orifice area, 4.9 square centimeters. See the nice D-shaped scalloping of the mitral valve. And I'll close with this promising image, hoping to be able to stand here for you next year and showing you some publishable data, which I can't show here for commercial reasons. Fish mouth effect, flexible annulus. This will be the avatar. And with that, you'll be fortunate to know that I came to the end of my presentation. Thank you very much.
Thank you very much. Unfortunately, we have no time for questions or comments. We have to proceed immediately to the final talk. It will be given by Dr. Dragopoulou from Hippocrates Hospital, and she's going to talk us about the iatrogenic atrial defect when we have to close it. Dr. Dragopoulou.
Thank you so much. I would like to thank the organized committee for the very kind invitation. So this is a very interesting topic, and I will start presenting this case, which will be presented during the next week in EuroPCR. This is a 41-year-old patient with a medical history of ARVC in good functional class prior ICD implantation that underwent catheter ablation for symptomatic paroxysmal atrial fibrillation. So the procedure was done through the transeptal puncture under fluoro and TOE guidance. And after the procedure, the patient developed acute deoxygenation, desaturation, and the saturation decreased to 81%. The patient became symptomatic. There was marked exertional dyspnea, fatigue, and poor exercise tolerance. So as you can see in the images, there is a huge RV with poor systolic function and at least moderate tricuspid regurgitation. And if we observe the atrial septum, we can see the iatrogenic ASD shunting from the right to the left due to the high right atrial pressure. So the patient underwent in our hospital closure of this iatrogenic ASD, as you may see. This is the defect. And of course, there was a very successful result after the deposition of the applanger-occluder device at the septum. This is the post-procedural echo, so the patient remained asymptomatic for the rest of the admission, and you can see from the transthoracic echo that there is a huge right ventricle due to the ARVC. There is a severe tricuspid regurgitation, but there was no remaining atrial shunting at the level of the atrial septum. So this was a solution for the patient that kept a very good oxygen saturation on ambulation. So the iatrogenic ASD is a consideration in several procedures, as we may see. Beyond the EP studies and the ablation procedures, we know now that there are several cases that we need to go through the transeptal puncture, as in mitral valve balloon valvuloplasty, in edge-to-edge repair, in tricuspid mitral valve replacement, and also in left atrial appendage occlusion. So in all these cases, we create an iatrogenic ASD. And of course, if we want to concentrate on the edge-to-edge repair, you see that there are several cases where the iatrogenic ASD remains at the intermediate and late phase during the follow-up. Are all ASDs the same? No, because it depends on the procedure, the size of the sheath, the time of the procedure, but most importantly, not all hearts are the same. So depending on the heart, we should consider whether the iatrogenic ASD should be closed or not. And this is very important. And concerning the edge-to-edge repair, we need to know what is on the literature. Some of the ASDs created during the procedure are spontaneously closed during the follow-up. And we know that we need to identify patients that develop a permanent ASD, resulting in adverse events, and to consider whether we need to close it during the procedure or maybe afterwards. And this is the first study that raised this issue, the iatrogenic ASD after the edge-to-edge repair, and we know that at first most of the patients have an iatrogenic ASD, but further on, at 12 months, not all patients have an ASD, but 27% based on this study has a remaining persistent ASD. This study showed that patients with significant MR had left atrial pressure increase, so this patient tended to have iatrogenic ASD persistence. This is another study showing that at 6-month follow-up, there was a 62% of persistent ASD. And in this study, another factor was found to be predictive of persistent ASD. That was the low left ventricular ejection fraction, again, showing that LA pressures may be a factor that lead to persistent ASD. Among structural factors, we know that procedural factors may have an impact on the persistence of ASD. And based on this study, we know that at 6-month follow-up, 50% had a persistent ASD, and depending on the timing of the procedure as well as the manipulations of the catheter, these two factors showed that there was an impact on the persistence of the ASD. And of course, in this sub-analysis of the mitral trial, we see that another factor, that is the eccentricity index, the shape and the size of the hole, was the only factor that played a role for the persistence of ASD. What about right to left shunting? Is this a consideration? And of course, we know that in a minority of patients, there may be a right to left shunting through the iatrogenic ASD in edge-to-edge repair. And in this study, only 5% showed that they have right to left shunting, and 1 out of 3 had also acute deoxygenation. What was the problem in these patients that presented with right to left shunting? Of course, it was elevated RA pressure with concomitant pulmonary hypertension, significant decrease in LA pressure, and of course, right ventricular dysfunction. What are the hemodynamic complications and outcomes if we leave an iatrogenic ASD open? And we need to consider all these functional characteristics of the patients, the atrial compliance, the LV function, tricuspid regurgitation, pulmonary hypertension, RV function, and initial valvular pathology. And this is a very nice paper showing what are the changes that we do in the heart after remaining ASD. You see at first there is a left-to-right shunt, RV volume overload, LV underfilling, reduced LV output, unfavorable ventricular intercontraction, and of course heart failure symptoms that may develop. So the pressure volume loop in the left ventricle shifts to the right, whereas if we close the ASD, there is a shift to the left. And as we can see also that the right ventricle has an impact on these functional characteristics. The right ventricle after closure of the iatrogenic ASD the pressure volume loop shifts to the left and the outcome is better. However, we have other issues to consider. As you know, in some cases where the LV ejection fraction is preserved or over 40%, there is a beneficial effect of the iatrogenic ASD, and these patients with heart failure and preserved ejection fraction showed that they have a beneficial effect if we have an iatrogenic ASD. Also, rehospitalization rate was higher in the iatrogenic ASD as we found in this study. So is the iatrogenic ASD the cause or the prognostic factor for these patients that may have a worse outcome? This may be answered by the MITRAS trial that was conducted recently, and we know from this trial that randomized patients with iatrogenic ASD in 1 month after edge-to-edge repair in closure and conservative therapy. And this study showed that there was no difference between closing and leaving the ASD open. However, there was a difference between patients that had a persistent ASD versus patients that did not have a persistent ASD. And also at 6-month follow-up in this recent meta-analysis, subgroup analysis of the study, it showed a numerical difference in the end point of hospitalization between spontaneous closure and residual shunt at the follow-up. What happens in patients with right to left shunt? We see that there is a worse outcome in all cases. So I'm getting to the end of the presentation. We may see a case in the first department of cardiology. This is a young lady of 56-year-old with ischemic heart disease, a coronary angiography that was done on December of 22. You may see that there was a PCI at the right coronary artery. The patient had heart failure with reduced ejection fraction, and she went for ICD implantation later on. So as you may see, there was a short QRS duration, so it was only an ICD and not a CRTD, and the patient had a poor functional class of 3 or 4 under optimal medical therapy. This is the transthoracic echo. You can see very reduced left ventricular ejection fraction, severe mitral regurgitation. There was dilation of the LV and also poor function of the RV in the presence of severe tricuspid regurgitation, the jet directed to the atrial septum with severe tricuspid regurgitation and pulmonary hypertension. So for this patient that went on to the heart team and there was a decision for mitral clip procedure, as you may see here, there was a functional MR, there was dilation, severe dilation of the mitral annulus, also due to the dilation of the LV, but also due to the dilation of the left atrium. There was no, at the beginning of the procedure, atrial septal communication. However, at the end of the procedure and after a good result concerning the mitral clip deposition, there was no, only very mild mitral regurgitation. We observed that there was a big shunt from left to right, and then we considered and discussed the closure of this shunt after thinking that this shunt would lead to right ventricular volume overload and further right ventricular dysfunction. Going to the next slide, please. Okay, and this is the procedure concerning the deposition of the ambulatory septal occluder device. As you may see here, there was a very good result with no residual shunt. So in conclusion, overall, after checking the bibliography, we see that the iatrogenic ASD closure may be considered in the following cases. First of all, severe baseline or RV dysfunction, systemic desaturation due to right-left shunting or acute hemodynamic decompensation, right to left or bidirectional shunting, a large ASD over 8 millimeters, and pulmonary hypertension defined as mean pulmonary pressure over 20. This is a very nice algorithm that was published in 2016 that takes into consideration clinical factors, echo findings, and invasive hemodynamics so as to decide in priori whether a patient needs to go for an ASD closure or we may wait and further evaluate the patient during the follow-up. Thank you very much for your attention.
Thank you, Dr. Dragopoulou, for the clear messages about how to deal with iatrogenic ASD. I would ask you to join us to the panel, and Dr. Eftichiou too, from Nicosia Hospital. And if there are any comments, then you can answer it throughout the case presentation. Dr. Spargas, please join us. So Dr. Katsianos is going to present the case number 8.
So, hello, dear colleagues. Our patient is a 93-year-old male, but fully active, BMI 26.1, NIHA stadium 3. He had a recent hospitalization for heart failure decompensation. The patient presents a severe degenerative mitral regurgitation with ruptured cords to P2, LVEF 65%, pulmonary hypertension, moderate TR, moderate AS. The stress echo, LVEF 40%, AVA 0.9, with a mean gradient from 22 millimeters of mercury. In the coronary angiography, March 2021, middle AD stenosis treated with a PCI. This is the diagnostic angiography. This is the mid-LAD, the stenosis, and here after the PCI. This is the SPECT analysis. The X-ray of the patient, the characteristics, he was in a good pre-operative condition with a BNP for 122, creatinine for 1.1, and hematocrit for 37%. And now we can proceed with the echo imaging analysis. Dr. Drakopoulou.
Thank you so much. Very nice presentation. So as we can see from this image, there is the LV size at the upper normal limits. Of course, the diastolic diameter is 48 and the systolic diameter is 32. So it is not a very severely dilated LV, but however, it's at the upper normal limits. And if we go to the next slide. So we can see that the LV function is preserved. However, we should take into consideration whether there is a severe valvular disease, as we may see further on. This is the LV systolic function, very nice images with 3D volumes. As we may see, the calculated ejection fraction is 58%. So it's a good systolic function. But if we see further on, the RV volume and systolic function is preserved, and it is good. However, we see here that there is a flail of the mitral valve at the posterior leaflet, and as we may see, this is a 3D image showing the level of the A2P2 at the right side of the image. It is a severe flail. So if we consider that there is severe mitral regurgitation, taking into consideration that there is severe MR, then the ejection fraction is also lower than it's measured by the 3D. So the systolic function should be further reduced. And if we go further on, we see that there is a big jet, eccentric jet, going to the anterior wall of the atrial septum, severe malcoaptation of the anterior and posterior leaflets at the level of the A2P2. And we can see here the mitral valve measurements. If we see, based on the measurements, there is a MR radius 1.3. I'm sure that the ERO is over 0.20 centimeter per square, and the regurgitant volume is over 60, shows it is a severe MR. And if we go further on, we can see with this very nice image that there is a flail at the level of the P2. Maybe it's better shown at the second image. And if we want to measure the flail width and flail gap, we see that there is adequate flail width and gap to proceed to maybe an intervention in the mitral valve. So based on this measurement, if I see well, it is 1.3 and the gap is 0.6. So based on the measurements, it's quite adequate for edge-to-edge repair. If we go further on, we can see with these very nice 3D images that at the level of the P2, we have a high mobility of the mitral annulus. We can see here the dynamic changes throughout the cycle of the mitral valve. and very nice sophisticated images. And if we go further on, we see the motion of the annulus throughout the cardiac cycle, and of course at the level of the P2 there is high mobility that we can see with highlighted in red color with this graph. So concerning the aortic valve, we see that the aortic valve is mildly, I would say, calcified with mobility that is quite good. We can see at the first image that it opens quite well. However, we see also the measurements of the area, so I would not consider this aortic valve of significant stenosis. Probably it's a moderate or even less. So I don't think that this aortic valve is in consideration for intervention or anything at this point with a severe MR and flail of the P2 posterior leaflet of the mitral valve. This is the tricuspid regurgitation. It's at least moderate, and I see that there is pulmonary hypertension. However, the patient seems stabilized because with this acute MR and flail of the mitral valve, one would expect maybe the pulmonary hypertension to be more higher. However, it's, I think the patient is balanced, and he can wait and decide in the heart team what would be the next step.
So before we move to the case, I would ask Dr. Eftichiou to explain us his strategy, how to treat this particular case.
Can I have my slides, please? Thank you. So just a couple of things before moving to the mitral valve. There is moderate aortic stenosis. I think it will need to be reassessed after the edge-to-edge repair of the mitral valve. And also for these moderate TR and the higher right ventricular systolic pressures, it would be probably better if we had some measurements from a right heart catheterization. Now, from the echo images of the outflow in the commissural view, we can see these obvious flail posterior leaflet affecting the P2 and probably the P3 as well. You can see an eccentric jet towards the anterior wall, which is confirmed here in the 3D images. It's obviously the P2 scallop, but I have the impression that the P3 scallop is also prolapsing as well. So we have a broad medial jet with an anterior direction. And if we gather up all the measurements and into this table and summarize the MR analysis, we have a severe MR of degenerative etiology with P2 and probably P3 prolapse segments. No indentations or cleft were clearly seen. There's one prominent jet with a broad jet with an anterior direction. No significant calcification. The flail segment is P2 and P3 probably, with a flail width of up to 13 millimeters and a flail gap of 6. No restriction of the leaflet motion, long enough leaflets both on the anterior and the posterior leaflet. Mitral valve mean gradient of only 2, and a mitral valve area large enough, 5.35 as well. Unfortunately, we don't have any measurements for the possible transeptal puncture height and the LA diameter. However, if we see this table as well, it's probably a green case, and also no thrombus, no tethered leaflets are seen. It's not a very complicated case. Challenging, yes, but I think it's a doable. And my planning and tools would be, of course, a transeptal puncture at least at 4 centimeters, if possible. It's a degenerative MR. I would use a Pascal ACE with the first attempt in a medial position, grasping the A2, P2 scallops, and in a 12 to 6 clocking, assess the result, and if after optimizations of the length of the leaflets that are captured, we don't have a good result, then I would probably move towards more commissural, towards 8.3 P3 scallops. And at the second Pascal ace, grasping again the A2, P2 in a medial position in a 12 to 6 clocking. Thank you.
Thank you, Christos. Before Dr. Chrysoheris will guide us throughout the case, I would ask Dr. Nignos to comment on the case, to share with us his experience and how to deal.
Thank you, George. I think it's a no-brainer. I mean, if you don't do a case like that here, what case will you do? I mean, it's high risk for an open heart surgery, isolated P2 prolapse. I think whatever device you use, I'm not against Pascal. MitraClip can also do the job, but both devices are eligible, and you should have a good result with this. I think it's a straightforward case.
So we're moving on to the case, and right now we have access, and we're proceeding with the introduction for transeptal puncture. Actually, we see the tenting on the septum, and we're measuring a height, and we'd like to be at least 4.5. It's a prolapse case, so we'd like to take into account the prolapsing of the posterior leaflet into the left atrium in our height considerations.
So here you see the safe sept, the wire we use for transeptal, and the SLO. 8 Transcatheter, we are cross. So once we cross, we give full heparin. And now you see Pascal device. Michael, remember what type of Pascal device we used?
The Pascal ACE.
ACE. So we followed your advice, Christos. So you see here how we de-air the guide catheter, so there's no air in the guide. And here we advance the device outside of the guide catheter, so the delivery catheter with the device is now out. There is a lot of space in front to move from the elongated to the default closed position that you see now. And now we are ready to go down by flexing the device. As you can see here, the delivery catheter.
You can also look at the hemodynamics. We have prominent V waves indicating severe.
Very important. You can see in the hemodynamics a V wave that is like 45 to 50 from this DMR. And now you see the device just above the valve, and here we try to get coaxiality on both planes. This is the X-plane. So on the right hand, we could see the LVOT view where we can see what is anterior leaflet, what is posterior leaflet, or this is the grasping view. And on the left side, you see the intercommissural view where we see where we are in relation to medial lateral center of the mitral valve. So now the device is below, is clocked correctly, and this is for the falling of the anterior clasp and now the posterior clasp. So this is independent clasping that we did in this case. As you can see, we're not in the middle of the prolapse of the pathology, we're a little medial to the middle. So the result here after this attempt is not bad. If you see the hemodynamics, you see how the V wave went down to 30, so this is significant reduction. And our clocking is almost 12.6, and we're a little medial to the center. And we had some small lateral Z, that's why we reattempt, so we're not very happy with this attempt. And here we open again the device, we release the valve. You saw the anterior clasp falling down, although we're
too medial, I would say. And you see how the posterior, the prolapsed leaflet moves quite back into the atrium. And this is a challenge to do the timing of the folding of the clasp to get it down correctly. So here, I don't think it was very successful because you can see it's moving above the clasp, the posterior leaflet. So the clasp is up again. And down, again, not successful. Seeing now just an independent observer, on the left side, you see the our coaxiality is not perfect. We're coming a little bit from medial to lateral, and we're too medial. But like Christos said, there was tendency of the prolapse to be towards P3. So that's why I think we are going a little medial from the beginning. This is our targeting. So this device is quite traumatic, so you can, it's very gentle to the leaflet, so you can do many attempts because it closes with this elasticity, so it doesn't really cause any problems in the leaflet. So multiple attempts are allowed. And now I think we moved a little bit more central. It's my impression, yes. So now you can see on the left side where the coaxiality is better and we're more central to the pathology. So we got the anterior leaflet, and now we're moving high as possible to get independently the posterior leaflet. And you can see the challenges of DMR, tear in DMR. You don't have a control of the prolapsing leaflet. If it falls very backwards into the left atrium, you have to time the falling. And this timing was correct, as you've noticed, so the entire posterior leaflet sat within the device, and now the device is closed.
The hemodynamics also, how they...
Correct. The hemodynamics are even better now, are normal, as you can see. So this is immediately, from the hemodynamics, a very satisfactory result. You remember the V wave was like 45 or 50, and now it's 20. And Michael, if you want to comment on the echo results, leaflet insertion, and all the checks we're doing.
Yeah, so this is now 3D from above, looking at the clocking of the device on the valve. It is a little bit counterclocked, but it didn't seem to affect the result. So I think maybe this is
the editing is not very successful, so now you see something from the past, because you see on the left side we're not doing something. So we're reviewing the echo images from earlier.
Okay. This is NPR of our final position of the device. Just want to. Yeah, so this is, we're scanning the valve from medial to lateral to see the leaflet insertion. Moving back to 2D imaging here.
There is a residual cord, a little bit lateral, isn't it? What do you think? You see something flickering?
This is not cord, this is the suture of the Pascal, of the clasps.
Oh, okay.
Yeah, this is something we always see. You see it's both on the right and the left side of the device. So when the clasps fall down, there is this redundancy of the sutures that are removed when we release the device.
At that stage, would you considering putting a second device next to it because there's a little bit of residual prolapse? It's just for the sake of discussion. I mean, the result as it is wonderful, but you know, because it's a redundant tissue, would you consider just getting a second device for the tissue, or you're happy with? Because Pascal is quite a sizable device; it's bigger than the XTW from the clip. So what? I'm just interested in your opinion.
Well, we had this discussion yesterday that here we have almost a perfect result. You see very tiny whiff of residual regurgitation that is away from our device. Actually, we're releasing the device now, you see on the fluoroscopy. And also we have an excellent hemodynamic result. So,
great result, there's no doubt about that.
And if you see the pathology, you have now some difficulty to see the prolapse. I mean, I don't see the prolapsing part now after release. So this is something we quite often see after release of Pascal. What we get is even better from what we had before release of the Pascal. So I think that was the end of the case. So we said yesterday, Vlasis, that if we have like more than mild MR, or if we see a lot of prolapsing pathology, even with 0 MR, then I would personally like to stabilize it with a second device. But in this case, we had 0 MR, and at the end, we had no pathology redundancy. So I think with this, you can go on with not the second case.
Okay. Then I would ask Dr. Alpin Musa to join us. He's here.
Dr. Arvadinos will present the case, and Dr. Habinusa is online. He will be doing our imaging analysis.
All right.
Thanks. Good afternoon. Our next case is a patient, is a 76-year-old female, obese, with a BMI of 32.5, who complains for dyspnea and mild exertion, NIHA 3, for the past few months. 6 years ago, she had surgery for ascending aortic aneurysm with a 34-millimeter graft, and then she underwent coronary angiography with and she had normal coronary arteries. Last month, she has multiple hospitalizations for congestive heart failure requiring intravenous diuretics. Here is a first CT scan a few months ago with bilateral pleural effusion and pulmonary congestion, and then she was admitted to the hospital. And this is the last CT scan. At the time, a few days before she admitted again to our hospital with a right pleural effusion and also pulmonary congestion. This is the first transthoracic echo at the emergency department that had moderate to severe MR and severe tricuspid regurgitation with an RVSP at about 55 to 60. Also, she had other comorbidities. She had a paroxysmal atrial fibrillation, chronic kidney disease, chronic obstructive lung disease, and hyperthyroidism, and always elevated BNP levels. Last BNP levels were 2,084. Here is the chest X-ray that shows the pulmonary congestion, and she was on optimal, maximum tolerated medical treatment with apixaban, 5 milligrams twice daily, furosemide, 80 milligrams twice daily, dapagliflozin, eplerenone, bisoprolol, ramipril, and inhalers. The EKG showed she was on a sinus rhythm with a left band block, and she had elevated, here we can see the elevated BNP levels last 3 months and the impaired renal function. From the transthoracic echo, she had left ventricular dilatation with an end-systolic diameter of 59 and systolic diameter of 51, calculated there. From the dynamic heart model, we can see an ejection fraction of 43, impaired left ventricle. and global strain of minus 55.5. Here we can see the mitral regurgitation from mainly central jet, mainly from the annular dilation, and also 3D image of the valve that had no prolapse and large annulus. Also, we can see the dilated right ventricle and severe tricuspid regurgitation. And the patient also had moderate aortic regurgitation. So finally, we have a patient with a Euroscore of Euroscore 2 of 24.2 and an STS mortality score of 6.65%. And now I welcome Mr. Albin Musa for the imaging analysis.
So we'll have Dr. Zakaria Albin Musa, who is an interventional cardiologist, interventional echocardiologist from Saudi Arabia, Prince Sultan Cardiac Center in Riyadh. We've worked a few times together in the past, and he's an excellent echocardiographer, and we will welcome his comments on the images. I'm not sure if you, Zakaria, if you're going to be using your own slide deck or you want to comment on our images, whatever is convenient for you.
Hi, Michael. How are you? Thank you for inviting me. Can you hear me?
Yes, we can hear you well.
Yeah. Okay, so I'm using my own slides, if you can see them.
Yes, we can.
Yeah. So from the images provided, I can see that the left ventricle end diastolic dimension is dilated. It's 5.9, which is in the category of mild dilatation, but the end systolic dimension, it's 5.1, which is severely dilated, put this patient into severely dilated, category. Now, the ejection fraction from the automated measurement, it is around 43%, which put the patient into mildly reduced systolic function. And now the strain is mildly reduced with 15.5, it looks for me global. Now, what I noticed that the LA is dilated, significantly dilated, although I don't have the exact measurement for the LA, but from this image, I can see that the LA is significantly dilated, which goes with the functional atrial MR. Because the patient has already paroxysmal atrial fibrillation. Now, from the transthoracic, you can see that there is a restriction here of the posterior leaflet and the eccentric posteriorly directed MR, which is, for me, it looks significant. It's in the category of moderate to severe. The calculation of the BISA is, it gives a mild, but remember that BISA, an eccentric jet, it loses its accuracy and it will underestimate the quantification of the MR. From the transesophageal echo, you can see that there is 2 jets of MR, medial and lateral, and there is probably an A2, yeah, it's an A2 relative prolapse, which goes again with with functional mitral regurgitation. This is more clear in the 3D. You can see here in the A2 a relative prolapse, which indicate again, a functional MR. The quantification of the diameters, it shows that it is dilated annulus, especially in the posteromedial anterolateral diameter. And the other thing is the posterior leaflet auto measurement is 2 centimeter, but you have to be careful with this because you need to measure the posterior leaflet at the site of the grasping, not at a different site. Now, regarding the tricuspid valve, you can see it's significant. It is in the category of torrential TR, with the PSP is, the TR signal is 54 here, but what you can see from this tracing, it is in the atrial fibrillation, so you have to take the average of this of these measurement, not a single beat measurement. Again, for the transvisual for the TR, you see it is a central jet. I'll go back, please. You can see here from the 2D, there is a restriction of the septal leaflet with a central jet of tricuspid regurgitation. Now, again, you can see in the measurement dilated annulus, and from the transgastric view, you can it's important to assess the anatomy of the tricuspid valve. It is 3 leaflets and a central gap with mainly, a central jet, mainly anteroseptal TR. And finally, you have to assess the ejection fraction and assess the function of the right ventricle, which gives you a normal RV function from the auto measurement. And from the tissue Doppler, it is in the range of 10, so it is the normal is up to 11, so it's almost like the normal. Finally, finally here you can see that there is a mild AR, and you can also notice the graft of the previous surgery, Dacron graft from the ischemic aorta surgery. That's my analysis. Thank you.
Thank you very much, Zacharia, for this comprehensive analysis. How would you approach this case? What would be sort of your
yeah, thank you.
inclination to do?
I did already some slides I will show it to you, but then I thought I will leave it for the next speaker, but
we can
yeah,
you can
I will
share
show you
if you
again. So for the regarding the mitral valve, I will I will start with central device, whether it is a B10 Pascal or XTW, and reassess. If it didn't work, then I will go for, if there is a residual medial jet, I will move the device medially and put another device laterally. Regarding the tricuspid valve, I will start with the Pascal ACE between the septal and anterior leaflet and reassess. If no anterior jet, I'm done. If there is residual, I would move and more anterior and put another device beside that device. That's my suggested strategy. Thank you.
Thank you very much for your comments, and we'll proceed with Dr. Niños, who will provide us also with his insight.
So it's a great case. To start with, there are 2 valves with functional regurgitation, mitral and tricuspid. So this combined case is always are very interesting from the pathophysiological perspective too. Clearly, the patient is well treated. He is on the best possible medical therapy. Ejection fraction is around 40 to 45% with most analysis. The QRS is wide, but it's, the ejection fraction is above the zone that a CRT device would be an option, at least not for now. I would like to have seen a right heart catheter. I think particularly in these combined cases, the right heart catheterization is a very important tool because first we can accurately assess the pulmonary pressure, find out if it's pre or post capillary, what's the pulmonary vascular resistance, particularly as we're looking into the coupling of the RV with a PA, and assess the cardiac output, the cardiac index, and perhaps allow us to pre-treat the patient accordingly. So that's something that I would do personally. The plan, as mentioned before, is to go for both valves simultaneous, either with MitraClip or TriClip or Pascal. That's up to the operator. One word of caution is to always keep in mind the ASD. Dr. Drakopoulou mentioned that, particularly after fixing the mitral valve and withdrawing the sheath, because the LA pressure would drop and potentially the RA pressure may be elevated due to the residual TR, and that could create a right to left shunt and cause some desaturation. Sometimes that can be quite profound, so that is something that we need to be cautious. And as previous speaker said, we're going to put a device in the A2P2 region of the mitral valve and a septal anterior leaflet one way or the other. So that's my plan, and I'm looking forward to look at the case.
So this is, we're starting the case. We're at the level at the time of transeptal puncture. And here we have the safe septa entering the left atrium with the left upper pulmonary vein.
We did the right heart cath at the beginning of the procedure, but we don't have the numbers here. There was nothing strange there. So here you see the Pascal guide catheter. We're starting with the mitral valve, as our both discussions suggested. And let's see what device we're going to use. I don't remember. Was it the P10?
It was a regular Pascal.
All right, so this is the regular Pascal, which means the big Pascal. So it's 10 millimeters width. And again, you see how we go from the elongated to the default position. There is enough space in front of us.
Kostas, can you explain for our benefit why big on this device, which is functional, versus the P10? Is there a rationale behind it?
Yeah, there was a large, one is inventory availability. We usually have them both, but now we're in transition to the precision. So we started using the precision now. So we had some devices, P10 and ACE of the second generation that we had to use. So, but in this particular case, because the width of the MR was quite large, as Zacharia showed earlier, and Dionysus, we selected to go with the larger, the wider device first, hoping that that will be enough to finish the procedure in the mitral valve with just one device. So here you see how the device is tackling this rim between the LAO and the pulmonary veins origin. And now it's below that rim, and now it's directing towards the mitral valve. You see again how we try to achieve coaxiality of our delivery catheter here, so to be like perpendicular to the annulus of the mitral valve on both planes, the anterolateral and the anterior posterior and the medial lateral plane. So here, Michael, if you want to.
Sure, here we check the clasps of the device, and now we're closing the device in order to enter the left ventricle.
Not always necessary to cross with the device closed, so there are different approaches. Some operators, especially with the first device, they cross with the device open, some others with the device elongated, and then come to the default when they're below the valve. And I think the majority cross the valve with the device like not fully closed, but closed. So this is a simultaneous clasping. As you can see, sometimes we're lucky and everything is quick. So once you're below the leaflets are sitting very nicely and stable on the paddles of the device, and then you do the simultaneous grasping. So that was a simultaneous grasping.
We're a bit clockwise on the device. That's why we opened to reposition, and I didn't show you the color, but so now we're counterclocking it a little bit to come to 12.6.
If you are not clocked correctly, then when you close the device, you distort the valve. And this is something we don't like, because it's usually connected with the residual MR, but even if it's not connected with the residual MR, if it's too much, then we don't want to distort the valve with our device. we want to be symmetrical. So here, if you notice, we got first the anterior leaflet, and then we moved towards the posterior, so that was an independent grasping, but I don't think it was very helpful in the reduction of the MR. That sometimes you get a very good grasp with almost zero MR, but you want to somehow to be perfect, and then you move away from that, and you say, oh, I should have stayed there. And you immediately see why, because when we closed the device and we rotated the device, the anterior leaflet went out immediately. So fortunately, and that was the reason that the MR reduction was not very good, because we had just a small part of the anterior leaflet out, so you better have this SLDA before you release the device than after releasing the device. So this is another attempt. As you notice, we're always in the middle of the valve, an area that is completely chordae-free, and that was another simultaneous grasping. And you see how important is the imaging. When the imaging is very clear, like in this case, and you can see the leaflets going down, how much leaflet you have inside, everything becomes much easier. So here we are symmetrical.
It's interesting that the LA pressure doesn't change, and sometimes in the functional patients you see that, whereas in the previous case the V wave was totally truncated, but here there's no. That's good for the potential right to left shunt, so that is protective.
This is typical, like the very good observation glasses. Usually we have high V waves in DMR cases, but sometimes we also have high. The minority of the cases, in FMR cases, we have high pressure when especially it's connected with diastolic dysfunction, and you have still the sinus rhythm, so when you have the A wave, you see that when you have the systolic contraction of the atria, this takes the pressure even higher. So, are you happy with this result, glasses? Would you
That's an
release the
excellent
device?
result. I wouldn't move it. I would leave it as it is.
Let's see
I
what
think if
we
you release
did.
it, it will get better because this is Pascal, right?
Let's see what we did.
Let's see.
I don't remember.
So if you allow me, I think also even in functional MR, you go to the pathology. You don't follow the color. Do you agree with me, the panel? Do you hear me?
Absolutely, Zachary,
Yeah.
yes, we're here. Yeah, for some reason, we're still not happy.
Is that Michalis' fault? He's perfectionist, or is it you? I think it's Michalis, isn't it?
Because we had this fall of the anterior leaflet earlier out, we're much more higher alert, so to be sure that we have good leaflet insertion here.
That's a great practice, actually, because you know that you have enough leaflet in. I mean, the last thing you need with a big device like that is to have an SLD,
Yeah.
and then it's becoming difficult.
So sometimes with this device, we just have to, this is an optimization, if you notice, of the posterior leaflet. We did optimization of the anterior earlier. Sometimes we just want to open and to check if we're not sure how much of the leaflet we have inside. So I think after this optimization in both leaflets, you can see the tension of both leaflets going into the device. It's much higher. So I think we have more inside, but the color is not better. Interesting, huh? So here is where you think, am I distorting the valve?
Usually when you have distortion, you get an eccentric jet on the commissural plane, so you get something going obliquely, which you don't. This is a central jet coming at the side of the clip somehow. There is a little bit of distortion. There is a little bit.
Like I said yesterday many times, I want just to stress that the cases we're showing here are not selected cases. There are 4 days in our cath lab with the crew of live media with us recording cases. So they're like everyday cases, not selected cases. So clearly, as I said, I'm happy that I repeat myself, and I have the same opinion. We're not happy with this residual MR, and we're slightly clockwise rotated, if you noticed earlier. So we open again the device and we correct. And as you see, we go counterclock, and here we're coming again. So the plan when we want to do both valves, VLASs, is that to concentrate, of course, hierarchically to the mitral valve to get a good result in the mitral valve. And then depending how long that took us, to proceed with the tricuspid valve. So if you have a very difficult mitral valve and you're spending like 3 or 4 hours to get a good result in the mitral valve, then I think it will be extravagant to go ahead and do the tricuspid and get another.
I totally agree. Because these are frail patients. The more you spend in general anesthesia and fiddling with the valves, it gets troublesome.
So this looks better. The pressure here is not very helpful because it was low, it's still low. And you see we have a lot of leaflets inside. You can see that movement of the Pascal here. You see that it moves with systole and diastole a little bit, especially towards the posterior leaflet. Still not happy. And this is when you get a good result with the first clasp with 0 MR, and then you want to replicate this.
That's why I asked who is the perfectionist here.
I think both.
Yeah, but I mean, it's worth spending. And from what I see, it's a pretty traumatic device. I mean,
it is.
Normally opening in and out with an XCW, I would be nervous third, fourth time. But
that's the big advantage, yes. The other thing with the P10, when we use the P10, the difference between P10 and ACE is that the P10 has a large spacer, which is like a sphere in the center of the device. So if you don't have the leaflets completely down to the bottom of the device, but they're like in the middle of the sphere, of this sphere, of the spacer, you may actually leave some gap from below and get residual MR from within the device. That's why when you use the P10, you must get the leaflets completely down to the tip of the device to have a good result.
That's why you see this color coming from the device, which is very unusual for me. I mean, I haven't...
Yeah. So also our clocking was off here. We were counterclocked on the device. So that's why we opened now, and I'm going to try to correct that. If you see here now that we're very counterclocked on the device, on the valve, so we're going to clock it to come more 12/6.
And you see now the device is open, there is no big difference in the pressure, in the LA pressure.
It's very interesting that unlike TAVI, TEER, there's an element of art to it. Certainly you have to be very meticulous with your clocking and your millimeter of entry. And you know, we have heard a wonderful lecture by Professor Kofidis before about surgical repair, but if you see, that's also quite meticulous, and you have to be very, very careful. Now that's better. Still not as good as the first one, though.
True, and you see that the posterior leaflet is out. So opening again, and now it looks very promising. It's similar to the first clasping, where in the middle you see everything to the tip of our device, everything is sitting in. And because we had this change in perpendicularity every time in every clasp earlier, that's why before we close the device, we check perpendicularity again to make sure that this is the correct perpendicularity. Simultaneous clasping. when we do simultaneous clasping glasses, I think you are happy with the leaflet insertion, how the leaflets are sitting. If you're not happy with that, you don't do simultaneous clasping. Do you agree, Zachariah? With the simultaneous clasping, it's an indication that you are happy.
Yeah. I thought the second grasp was the best, but unfortunately, you lose it. You lost it. But,
the tear leaflet, yeah.
This one is good. It looks for me, still.
We're still not happy, as you can see.
Go a bit more
Sometimes functional is becoming very challenging, more than even the primary, because the primary you target the flail segment or the prolapsing segment, but here you just try to get the sweet spot.
And for the audience, you realize what a good relationship the interventional cardiologist and the echocardiographer should have in order to perform these procedures. You know, if you're interventionalist, you say, come on, show me the pictures, then that's it, you're losing it. So now that's a perfect result, I think, here. What do you think?
Yeah. I think this is the first time after many attempts that we replicate the initial good result.
Even better, maybe.
Yeah. Looks great.
And Michael was happy, which is very important.
There's no gradient,
Here
right?
we're scanning the valve medial to lateral to see the leaflet insertion, and with MPRs we do the same thing to assess. And
now we're releasing
of the device.
So we rotate that knob, and you will see in a moment. First we cut the sutures that you noticed earlier, Vlasis, and you thought it was a rupture cordae. So the sutures are removed, and now we rotate that knob at the end, the blue one, and the device is released. And this is our final result with 1P10.
That's a great result.
A lot of tension on both leaflets inside, very stable, and a very good result.
And actually, we had an improvement of the hemodynamics as well. The V waves, which are 31 beginning the case, dropped to 17 at the end of the case.
So now the easy valve, the tricuspid, right?
Yes, we proceeded to the tricuspid because although there are many attempts, all these were quick. It didn't take a lot of time.
So here we're looking at the transgastric views again. Anteroseptal jet. You see in the middle of the septal leaflet, there's two lines which indicate like cords, septal cords on the septal leaflet.
So the same guide catheter, an ACE this time, ACE that we always use in tricuspid valve. And you see how we avoid the septum and the aorta by flexing the various knobs on the device. If you're using LAO, you can very clearly see if you go towards the septum or away from the septum. So sometimes we use this fluoroscopy in LAO to see when we're getting down to the tricuspid valve. You see now we are flexing and we're approaching the tricuspid valve. So imagine if you don't have to do the mitral valve, just the tricuspid, you avoid all the transeptal and crossing to the left atrium. So now we're down to the tricuspid. We rotate the C-arm to the RAO like 30 degrees.
Saturation looks pretty stable. There's no any obvious right to left shunt, I suppose.
That's a good
observation. And now again, we try to get coaxiality, to attain coaxiality on the tricuspid annulus. So this is the X-plane on the tricuspid valve, midesophageal, and we want to be perpendicular. On the left side, you see the anterior, medially, and laterally the posterior leaflets, and on the right side, you see the septal and the lateral. Whatever the lateral is depends on where you put your cancer sensor on the like an X-plane, tricuspid X-plane. So if you put it towards the anterior, on the other side you see the anterior as the lateral leaflet. If you put it towards the posterior side, then what you see on the lateral is the posterior leaflet. And here we have, I think, good coaxiality on both planes, but we are a little deep in the tricuspid. And there are maneuvers you can do to gain height with Pascal, and I think we use these maneuvers to get away from the tricuspid valve, to do the opening of the device, to check the clasps, all the usual things we're doing, because we need to know when we drop one clasp, which it's which, the septal or the lateral here, if we use the independent clasping. And you see how we manage to get our device higher into the right atrium. And here, you have a combination of movements to do to go septal or lateral by rotating the delivery catheter, to go septal or lateral by flexing the guide catheter, and also to go anterior or posterior by pushing the entire device in or out. So you can go anywhere you want by using a combination of those three maneuvers, possibilities, and observing the echo. There are no rules about knobs that you have to turn this knob 90 degrees, the other knob 120 degrees. You just follow what you see by using a combination of these three maneuvers. So here you see the device is open. This is transgastric, and we try to clock it to get it perpendicular to the septal and the anterior leaflets.
That's the most important view when you do tricuspid by far, and it's quite difficult to obtain, so congratulations to the imaging here.
So here you try to be in the middle of the collar when you cross, so we close the device to cross. We don't want to hit the leaflets and move away from the intended area. And once you cross, then you open the device and you go to transgastric again to check your perpendicularity. Some operators, again, they prefer to cross the valve with the device elongated in the tricuspid valve, and we use this sometimes also. So perpendicularity looks good. And here you see the anterior leaflet on the lateral side and the septal leaflet on the inside. And in tricuspid, we almost always go for independent clasping. So I suspect we're going to get the lateral first, which is lower, and then move towards the septal. So you see the lateral is sitting on the arm of on the paddle, and it's immobilized. One last check. So here you see first the perpendicularity and second the positioning. So you see here if you're too commissural, deep in the commissure, or if you're towards the center of the valve. Our practice is to target to be more centrally in the valve, so we don't put numerous clips without any difference in the final result. So if we get one close to the center and we have a good result, I think a second clip, more commissural, is not necessary. So here we got the lateral lift. You see the sudden movement up to scoop the septal leaflet, and the septal leaflet is also inside, and the device is closed. But it's too commissural. You see it's very deep into the commissure, so the effect on the collar was tiny, and if you leave the device there, you don't affect the color significantly, and you have to go with a second clip that probably is not necessary. So we move more, as you can see, centrally towards the posterior lift here, and we try again. So this is another independent clasping. I this is not so successful because you see more of the septal leaflet is outside of the device this time. So I'm sure we're trying. Yes, so the clasp is up. And you see the tethering, there's a relative tethering, and this is another attempt, closing of the device. You see we have some effect on the color, but still you have color more medially, more centrally, because we are still in the commissure, as you can see here. And we're below those two chordae in the septal leaflet, if you notice, but there is a space that we could go a little more centrally.
What the arrow is showing is those chords in the septal leaflet.
So this procedure has no comparison with TAVI. In TAVI, you have to be quick. There is no time for discussions, for suggestions, for many attempts, because you're in the arterial system and you have to be quick and with a perfect result quickly. Here, you're in the venous system and you can take your time to make decisions, to try different things, to be as successful as possible.
It's good to move central, but sometimes when what we found is that if you go too central at the edge of the anterior leaflet, you may affect the commissure between the anterior and the posterior leaflet. And sometimes that can open a new jet between the two leaflets. So you know, there's an exchange to the position. So it's interesting to see.
So we're a little more towards the center here. You agree?
Yeah, clearly it's more central position.
And here you can see how the septal and how the anterior leaflets are going in. So obviously we're not happy with the result. So we open again, we do a recapture or optimization. Still in the same position. So this is when you do independent clasping. You think you're in the center, you get one leaflet in that position, but then when you torque the device to get the other leaflet, you don't only move septal lateral, but you also move more commissural.
Yeah, you move in all directions, basically.
It's a 3D movement. So that's why, although we start from more central in the valve, went up to be more commissural because we do this independent clasping, and when we move to get the septal, this takes us more into the commissure. And this is something you can check at the beginning by doing this maneuver and see how the device moves. So you can expect it from the beginning. It's not something that you cannot find out from before starting moving your device. So here you can say in the transgastric that you have sufficient anterior leaflet going in because you see it goes to the center of the device and also sufficient septal. This is how you judge your leaflet insertion. But I think our discussion here is how to move more centrally.
These images show how much we moved on as a community to the imaging of the tricuspid valve. I mean, this would be unreal 5 years ago, and here you go, you can see details, you can appreciate millimeter by millimeter the leaflets. Tricuspid imaging is now almost 90% of the cases you can get images like that one way or the other.
So here we're opening the device. And And then we are now into the septal anterior commissure, deep in the commissure, and
the device is a little stuck there. So we're trying to get it away from there, and you elongate it. You'll see in a, yes. So you see on fluoroscopy that we elongate the device.
and something happens.
And something happens on the ECG. Did you notice that?
A heart block.
Yep.
It's a heart block.
So somebody is getting anxious. We start some compressions.
So the first thing to do is pull back on the system
Yes,
out
and
into
now
the
it's back.
right atrium. And shortly after, we regained good rhythm.
And we put a pacemaker.
If you get too commissural, you may hit his bundle. In the first generation of these devices, at least the clip, because Pascal always had independent grasping, we were trying to go commissural to zip the valve, and we had it quite frequently. Now that we go centrally, luckily we don't have this as frequently.
So clearly we hit the his bundle. We were very deep into the commissure. And this is the first time we had this in tricuspid clipping. We had it in the mitral valve, curiously. A similar event, yes.
In a patient with the right bundle.
Yeah. So we had some discussion whether we should abort the case after this event, but because it lasted, it was very short, and the rhythm came back very quickly, and we put a pacemaker, we felt that we're safe to proceed. So here we see a temporary wire there, and you see the effect of the inotropes that the anesthesiologist gave to the patient during the complete heart block now, the
And now
tachycardia.
he made it impossible for you to grasp the leaflets because it's going 150.
So we decided to go ahead. So you see we're more central now to the valve.
Obviously, the imaging now is the movie's playing at double speed. Obviously,
This happened as we were discussing that TAVI cases are much more adrenaline generating, and now here you go on the tricuspid.
Yes.
But things can happen.
The other thing I noticed is that if you don't have any perfusion, any flow, it's very difficult to find the vein and to put a pacemaker acutely in a case like this. So we discussed whether we should put like a 4 French venous on the contralateral vein every time we do tricuspid after this event. And I think we did it in another few cases of tricuspid we've done since, but I'm not sure that we'll keep doing that in the long term.
It's going to be difficult to assess the result now because the patient is also with tachycardia, and clearly you may have distension. Have you ever tried maneuvering with anti-Tredelleburg position to get the coarctation of the leaflet?
Almost in all cases we put anti-Tredelleburg.
Because that's what
yeah, and in some cases also we try to compress the sternum if we have difficulties to raise the septa.
Yesterday, a comment was made for the left femoral vein in order to deal with the angulation between the inferior vena cava and the right atrium. Do you have any experience with that? Is it possible to be helpful?
No, we haven't done it, but I think it's a great idea. Who was the one who suggested? I don't remember. Was it Fabienne? No, Makar. Makar. So he suggested when you have a lot of septal tethering in the tricuspid valve, or when the anatomy is small and your septal hanger, to go from the left side, because this gives the curving and the flexion of the entire system. It takes you higher in the right atrium.
Never tried it.
Sorry, we missed the final result.
It was a good grasp, I can tell you.
It
but
was a good grasp.
I haven't seen color.
It was a very acceptable result.
If you want to go in the last seconds of our video again, is it possible? Just to review the last few seconds. Okay, so the device is released here, but a little more back to see the color. Sorry, we're asking.
What is also interesting is that you're grasping and you have a temporary wire in place.
Yes.
So that makes it even more interesting.
Yeah, but it's a small 5 French that usually goes in the posterior septal commissure. So it's a very good grasping, and where is the color?
If you go back a little bit on the video.
But I think the color will be misleading in that. I think that
Sure,
when the patient
sure.
settles, the color will improve.
Yeah. This is exactly what we noticed. So we had like a good reduction, more than 50% reduction at that time, but on the transthoracic echo, do we have it, of the following day, it was much, much better. So it was an excellent result.
Congratulations. It was a very difficult case, very challenging, and thank you for sharing all these details with us. It shows how complex these procedures are, and that the team effort is very, very important. Congratulations.
And thank you. I'm afraid we spent most of the break here. So let's say 15 minutes break. Till we there is a question from Dr. Killis. Yes, please go ahead.
Congratulations for these very interesting cases. And I want to make a comment for the last case. Sometimes during our valve tricuspid interventions, we put a temporary pacemaker into the arterial system by a left ventricular pacing. So this can be maybe alternative, do you think, that for tricuspid clip implantations, because sometimes you push the system and there is a pacemaker in the right ventricle, and this can connect your maneuvers also. And my second question is also, did you try jugular approach for triclip?
From the jugular vein, you mean? We already had a jugular line, the anesthesiologist, but we needed to change it to a line that accepts a pacemaker. That will take time, whereas the other leg was already exposed to us, and it was much quicker to get an electrode from there.
Theo is asking whether you've done a tri-clip or a Pascal TR from the jugular.
Oh, from the jugular. No, we don't have that experience, but I think Vlasis did one. So.
Yeah, but that was a crazy case. It was a tricuspid valve on the left from the jugular because the IVC was interrupted, so that was an exceptional case. But that's a great comment that Theo, hello Theo, by the way, he's a good friend of mine, he made, because one alternative would be to put a pigtail into the LV and thread a coronary wire and sometimes pace it over the wire. And, you know, I've seen that happening in one center for another reason. So you get the wire, the coronary, through the pigtail looping into the LV, and then pace outside like you do with Fortavi. But I don't know how reliable it is to do it all the time. But it's a great thought. Yeah.
It's a great point if you can't find the vein. It's easier to find the.
There's another question.
It's not actually a question. I would like to comment on our repositioning of the TR devices. Maybe it's not only a matter of perfectionism, although sometimes we are very happy about the hemodynamic and the imaging outcome. We are not 100% sure about the insertion of the leaflets, and that's the reason that we reposition. That underlines, as you said before, the significance of the good echo imaging.
Thank you, and let's wrap up and have a break for 15 minutes, and then we resume. Thank you.
Edwards was founded in 1958, and our focus has always been on the patient. For the last 60 years, we have been attempting to improve the quality of life of every patient that our valves treat. In 1981, Edwards introduced the first tissue valves based on technology that was developed by Dr. Carpentier. Since then, we've enhanced that technology and the performance and the designs of our valves to meet our customers' expectations. Our transcatheter valves have built on the technology we developed in our surgical valves. We've been using those known proven technologies to further enhance the development of the transcatheter products. Our processes and leaflet selection have been engineered to enhance the long-term performance of our valves.
With SAPIEN 3, we've leveraged our experiences with our earlier generations of balloon expandable platforms and combined that with new technology and new learnings from our team. SAPIEN 3 was designed for circularity, which is important because it helps lower stresses on the valve and also helps to reduce the risk of calcification. SAPIEN 3's cobalt chromium frame was built to resist fatigue. In product design, we utilized a lot of different tools to analyze and develop the right frame structure. One of these tools was FEA, or finite element analysis, which was used to analyze the stresses all around the valve frame and to ultimately strengthen it even more.
When we have a new concept, we have to take that from the drawing board into a prototype. And that prototype has to meet the same requirements that our finished products will have.
Once we're ready to commercialize a valve concept, we do a lot of feasibility and iterative design testing. We then can move forward with the design verification testing. Edwards must achieve 100% pass rate on every test we perform. And not only do we require that we pass our own standards, but we are also required to pass the rigorous ISO standards, which include tests for hydrodynamic performance, effective orifice area, pressure gradient, regurgitation.
We are testing valves that are under-deployed, valves that are over-deployed, and valves that are even in oval shapes.
In addition, we also perform accelerated wear testing, which simulates the aggressive environment of the valve inside the body. When we place the valve in the tester, we are running these valves at about 1,000 RPM. Every Edwards valve is cycled up to 200 million cycles, which is equivalent to 5 years of in vivo testing. And we've even tested our SAPIEN 3 valves up to 1 billion cycles, which is equivalent to 25 years, and we've seen no evidence of valve degradation.
Here at Edwards, our product development really depends on a close relationship with our customers. And we are very confident that the technology and testing performed here leads to products that meet the performance expectations of both our clinicians and our patients.
So good afternoon. We will move on with our next session. And our next session will be on transcatheter mitral valve replacement and transcatheter tricuspid valve replacement. Finally, we will be moderating this discussion with Dr. Moni Shuvi, who will be online, with Blasis Niños, and personally. So is Dr. Shuvi online? Is Dr. Shuvi online as well? Dr. Shuvi, our co-anchor?
Yes. Can you hear me?
Yes, we can hear you, Moni. Very good.
Hi, Moni.
Good afternoon. How are you?
Very well. Thank you for joining us. Our first speaker will be Samir Kapadia, who is an interventional cardiologist and professor of medicine, chairman of the Department of Cardiovascular Medicine at Cleveland Clinic, Ohio. And he will be addressing tricuspid valve-in-valve and valve-in-ring updates.
Thank you very much for the invitation. I wish I could be there in person, but I see that it's an exciting audience and presentation, so I'm very excited to be with you guys. I have to update on the valve-in-valve and valve-in-ring. So what I want to show you, this is the first ever tricuspid valve replacement percutaneously. Of course, this was with the Navigate valve. This is an older valve. This was in 17, so a long time ago. And at that time, it was a 40 French sheath in the jugular. So it was done transjugularly. And it turns out that this particular patient had a tricuspid valve ring in place. So this is done as a valve-in ring. So as you can see here, so this is a patient and there is a ring there, and this is the tricuspid valve. Of course, this is the right coronary artery. And patient did very well. This was the first ever valve replacement. But again, you can see that the valve is not circular, it is oblong. And this is a typical thing with the valve-in ring cases. We published that to say that how many different patients we did. And at that time, remember that this valve is available as 36, 40, 44, 48, and 52 millimeters, very large. So the current tricuspid valve that is available that we use is an S3 valve, as you all know. So this is only a 29 millimeter valve. So this is something to keep in mind, that when the valve is 29 millimeters, it is difficult sometimes if the annulus is very dilated to put a valve-in ring, because the valve may not touch the septal side of the leaflet. Navigate had good results, but the valve is not currently being used. If you look at the EFS side of the tricuspid valve repair, of course, that is mostly related to the clip. And I know that you are going to discuss the clip in detail, so I'm not going to. But Pascal and TriClip are the most important things. And of course, there is some information on CAVI. So I just want to share some cases. So first we'll, since I have to talk about the valve-in-valve also. So valve-in-valve for the tricuspid is, to be honest, extremely easy. So this is a patient who has a tricuspid valve, 33 BioCore. And as you can see, the patient has renal failure and already has a mitral valve-in-valve placed percutaneously. And so this is the patient with the mitral valve-in-valve in place. And now the tricuspid valve has, and since it's a BioCore valve, you cannot see the BioCore valve very easily. So this is an LAO view, but I know it is difficult to see, but you can see potentially a small ring there. Of course, this is a loop recorder. And you can see after the mitral valve we did, we had to close the septum because the tricuspid valve was also problematic. So there was some right to left shunt. Placement of the valve is typically easy. So if you can see it here, the placement of the valve, we normally put a confida wire in the right ventricle. We pace it from the confida wire. Some people do not pace it. Some pace from the coronary, some from the left side. All of these are options. But I think the easiest one is to pace from the wire in the right ventricle. And then we do it with conscious sedation. There's no need for TEE. And we can study the patients after the valve replacement with just transthoracic echo. So this is the most common way that we have done the tricuspid valve in valve. And as I said, the procedure is fairly simple and easy. When it comes to the tricuspid valve ring, it is slightly more complicated because the rings are not typically circular and not complete. So this is a patient with an annuloplasty ring. Here you can see that the annuloplasty ring is not circular, it's oblong. And now we are trying to put the valve, and the valve will enlarge accordingly, but there will be a space left. So either the space is left on this anterolateral septal commissure or on the septal side. So these are the most common two sides where you will not have apposition of the valve. And how you size it is also a little bit tricky, because on one side the long axis of the valve can be 33, 35 millimeters. The other side will be 21. So there will be a huge difference in the diameters of the ring. And if you put a very large valve, so sometimes if you put a 29 valve inside, you can have pinwheeling of the leaflet. And so you want to align the commissures appropriately such that in the open side, there is one leaflet. So if you are in the commissure on the inside, then sometimes, so you can try this outside. So if you take the ring the patient has, then put the valve inside the ring, and then you will be able to see what I mean, that how the valve leaflet will sit inside depending on the rotation of the valve. So this is something very important and easy to do, is to put the valve before you plan inside. You can try to post.
Good afternoon, everybody. Thank you very much for the invitation again.
I'm sorry. So this is you can post dilate the valve, and once you post dilate the valve, you can see that still there is an opening. So then you can cross the opening with a simple wire, and then depending on the size of the opening, you can use different sizes of plugs to plug it. This is just a 8 millimeter AVP4, but you can put a 12 millimeter AVP2 also, depending on the leak. So many times you have to put plugs in the tricuspid valve in ring patients. And here you can see that there was a leak before on the side, and then here, this is the after, and you can see that there's very little leak left. This is a 3D transthoracic echo. If the patient has a pacer wire, this is another important thing to keep in mind, that if you have a pacer wire, how tight is the pacer wire? If the pacer wire has some slack, it is easier. If the pacer wire does not have slack, on which side of the pacer wire you will put the valve is something important to consider. So many times, if the pacer wire is tight, you would do a CT scan and try to understand how the pacer wire is laying inside of the valve, and at what place the pacer wire is, and what is the trajectory of the pacer wire. Again, as you can see that we put a virtual valve inside, and you can see the space as well as how the leaflet will go on the side. You can also try to study it with the 3D. So this is just a video to show that how the pacer wire is tight on one side. And so when you put it, the valve, you want to do it in the LAO view such that you're crossing on the other side of the pacer wire, because we determined that this pacer valve will be better if we push it on this side rather than staying on that side. So you could have this pacer wire on that side of the valve or on the lateral side of the valve. And we decided that by all the analysis that it would better to be putting it this side. So using an edgeless catheter, we would go on this side of the pacer wire. We'll make sure that we have in the right place the pacer wire. And as you can see in the RAO view, the wire is not distorted much when you place it. You can imagine that this valve on this side, and then it can potentially dislodge the pacer wire. Also important is to try to understand where, and we try very hard to put these two commissures on the side where its opening is there so that it does not touch the valve. Again, this is another patient where there is a pacer wire, but if the pacer wire is slacky like that, it doesn't really matter how you put the valve. So this is an important thing to keep in mind, that if the pacer wire has this much of slack, then it is not so relevant that how you put the valve. And many times we do if the creatinine is good, we would do a right ventriculogram to see how the results are. And of course, we can do transthoracic echo. There are a lot of challenges to this. So, they're too large, the leaflets, very large annuli. And so one of the other things that I know that you are going to also discuss, but is to put a bicaval system. So with a trick valve, this has really improved our options in the patients. We have done some compassionate use trick valve cases because still in the United States it's not approved, again, done with conscious sedation, as you know probably, that there is a valve in this SVC, IVC, and fairly simple procedure to do. We are planning a randomized trial in the United States, probably starting in July, to have trick valve versus optimal medical therapy. So I just want to end there to say that it is a tricuspid valve treatment is a large unmet need. It is evolving fast. Patient selection is key to success, and patients should be treated early. Comparative data are limited. The dedicated tricuspid valves are currently not allowing people to put the valves in the valve-in ring at this particular point in time. So thank you for your attention.
Thank you so much, Professor Kapadia. Congratulations. Sorry, Moni, do you have a comment?
No, I want to thank Professor Kapadia and maybe ask him a question. What about your experience with tear in the ring, in the tricuspid valve? Because most of the patients we see are patients they have ring in the tricuspid valve, and we had some nice results with tear in the ring in the tricuspid
Very
position.
good, yeah, no, and that's what I didn't put there because I see that there are so many tear talks. But you're right that the first approach could be a tear in the tricuspid ring. Many times, if you can put a septal anterior clip, it can work. The challenge, obviously, is the imaging. So we use a 3D ICE for all the patients when we have a ring in the tricuspid position, because sometimes it's very difficult to see the leaflets. The other challenge, other option is we have also done that first put a ring, because sometimes there's a lot of space on the septal side of the ring because the annulus is very dilated. So you can put a clip on the medial side and then put a ring, put a valve on the other side. So you can have a clip and a valve, both also possible. So these are unusual treatments for this kind of situation, but the clip in itself is a great idea.
How much do you oversize for the valve-in ring cases, and have you had any experience with embolization of the balloon expandable prosthesis?
No, we have not had any, no. But the oversizing is, to be honest, not necessary. So this is what I'm saying, that because the rings are so non-circular, that we would like to put the ring, the anterior posterior diameter, we oversize by 3 millimeters. So let's say if it's 21, I would put a 26, so 5 millimeters. But laterally, many, many times, it is impossible to size it like that. So it is 33, 34. So what I suggest is, because rings are super rigid, so it is good to put a valve in a ring outside and put it in the water to see how the leaflet will close or not if you put a very large, because if you put a very large valve, like 29 sometimes, it will not close properly. So 26 sometimes is better for this kind of very oblong rings.
And have you had any experience with pacemaker lead malfunction after trapping it, either in a valve-in-ring or a valve-in-valve situation?
Yeah, not immediately, but later on, we have encountered in one patient, but again, it's very unclear that what we could have done differently. Most of the patients that we have done exceedingly well and no issues. And we have placed then the coronary sinus lead or a bundle branch placing in these patients rather than crossing the valve.
This is fantastic. Thank you so much for your help. If you don't have any questions, we can move on to our next speaker, who is Dr. Kornowski, and he will be addressing the valve-in-valve and valve-in-ring on the mitral side. So, Dr. Kornowski.
Thank you very much. I'm delighted to be again at your wonderful meeting. And we are going to move from the right side of the heart to the left side. And I'm going to discuss a catheter-based mitral valve-in-valve, valve-in-ring implantation. So I'm going to touch base on background, important considerations specific for mitral valve-in-valve or mitral valve-in-ring, the procedural details, some of the outcome data, and some thoughts for the future. So it's been a long way since the first transatrial septal puncture was described for hemodynamic measurements, followed by the percutaneous balloon valvuloplasty up to nowadays when we implant mitral valves, whether it's native valves or using the need to treat mitral valve bioprosthetic degeneration or valve in rings, which is the topic of the current talk. So as you all know, the structural valve deterioration or degeneration occurred in patients with bioprosthetic valve over the year. There are several pieces of data to indicate it's about 1/3 of patients with mitral bioprosthetic who need another valve within a matter of 10 years. These are the statistics. You see here what happens when we start by 7, 8, 10 years and so on. And also, please note that over the years, the age of the patients, the average and median age of the patients tend to be around between 60 and 70 years old, which means the likelihood to need another valve is very, very high. We also have to remember that according to the ESC guideline, the indication to implant a bioprosthetic valve is beyond the age of 70 years or 65 years. So there is this gray zone of 65 and 70 years, and the longevity of this patient far exceeds the longevity of the valve in many patients. So there is a clear need to perform mitral valve-in-valve procedures. I think the pioneers were the group from Vancouver, John Webb and David Wood, who by 2010 already described their initial experience, and among cohort of patients with valve-in-valve, 7 underwent mitral valve-in-valve, mostly at this time using the transapical approach. And you see here from the US, these are administrative data to indicate that over the years there are more mitral valve-in-valve procedures to replace redo surgery. This is a clear trend, and overall these procedures are associated with better mortality outcome, even by adjusted for the other risk scores. The adjusted mortality for mitral redo mitral valve replacement is 7.6% as compared to 2.8% for valve-in-valve. And these are the list of overall complications, which are less overall with the percutaneous procedure. So let's move on and make a clear distinction, as was mentioned by Samir in his previous talk, when we talk about mitral valve in valve versus mitral valve in ring, because the rings are far more problematic, associated with more paravalvular leaks. They are not circular. There is not good anchoring, more embolization. There are many types of ring, and there is fluoroscopic imaging is not always trivial. And there is also the problem that I'm going to discuss, the LVOT obstruction. I'm not going to start to discuss in this talk the valve in MAC, which is another problem. So the first thing that we have to know is the valve, the type of the valve, the dimension, the external and the internal dimension, the angiographic and fluoroscopic signature. And these are very, very important in order to match the needed valve, which is the vast majority of valves are sapien, according to our experience. And you need to know the characteristics and dimension of the valves you are going to treat. Now it's becoming more complicated with valve in rings. There are many, many rings, complete rings, incomplete rings, rigids and semi-rigids. And it's also known that the rigid rings, complete or incomplete, will result in suboptimal results due to non-circular expansion of the transcatheter heart valve, and likely paravalvular leak will occur in both commissure. And also semi-rigid complete rings will provide much better anchor and can become circular or near circular, making them ideal or better for valve in ring procedure. So this is very important information to know upfront and to plan ahead. In valve in ring, we also have the hazard of LVOT obstruction. This concept of neo-LVOT in the valve in ring procedure is very, very important. And also, by the way, in implantation of mitral bioprosthetic implantation percutaneously. So following valve in ring, the anterior mitral leaflet covered the THV and it's pushed towards the LVOT. And following the valve in valve, the surgical bioprosthetic leaflet cover the THV and can cause varying degree of obstruction to LVOT. And on the right side of the slide, you see the variable associated is more risk to have an LVOT obstruction, depending on the depth of the implantation, the degree of flaring, the angulation between the valve and the LVOT trajectory, and obviously if there is a septal bulge. And in this case, there is a need to really make a very thorough analysis of the CT scan and to have a simulation of the valve. And this would allow the operator to know upfront whether the risk of LVOT obstruction is indeed detected. The LVOT, neo-LVOT area is less than 1.9 centimeters square, then the risk reduction strategies such as alcohol septal ablation in thickened septum, basal septum, or lampoon procedure should be considered. And if we have mentioned the lampoon, this is the lampoon, the laceration of the anterior mitral leaflet, prevent outflow obstruction, which is a transcatheter electrosurgical technique to split the anterior mitral leaflet prior to TMVR in order to prevent LVOT obstruction. So let's go through some of the stages of the procedure. The first and very important, as I mentioned, is the need for a very careful procedural planning, identification of the manufacturer, the model, the size of the valve, mechanism of failure, and very good imaging using echo and CT. And when we start the procedure, the transeptal location is also important. We usually aim at the mid-fossa on the posterior aspect of the septum. We don't want to be too high certainly not too low and not too anterior. So transseptal is the first stage, and following transseptal, we have to navigate through several very useful equipment, such as the Agilis catheter, obviously the balloon for septostomy, and pre-shaped wire, whether it's a Safari or Confida, each site has its own preferences. In order to know upfront which valve size, we have the app, very useful app that was developed and really upgraded by Vinny Bapat. And we usually use the app to make sure that we use the right sizing. We can place one or two guide wire. Sometimes it's useful to have another wire. This is a pre-balloon transseptal, usually with 12. Sometimes we need 14 French. And this is the procedure. And we try to position the valve at the tip of the bioprosthetic valve, not to position it too deep in order to avoid LVOT obstruction and to have a decent anchoring. And we usually don't need post dilatation for this type of procedure. This is, for example, the case we did last week with the Sapien 3 29 millimeter within a Hancock 2 of 31 millimeter with very satisfying results. And this is how it looked by the echo. Sometimes there is a residual right to left shunt in patient with excessive pulmonary hypertension. We have to deal with that, and we have to prepare if there is a need for transseptal occlusion. In this case, we use the Occlutech device in order to treat the residual shunt with right to left shunt that cause saturation, desaturation of the patient. This is the final result after the transseptal occlusion. This would occur in less than 10% of treated patients. What are the clinical outcomes? So we have a lot of data and good data from the VIVID registry, for example, some 1,000 patients, mean age of 73. The STS from score is 8.6%. This is a project that was led by Danny DeVere. You see here that in about 1/3, this was transseptal, 1/3 transseptal, 2/3 transapical, and the primary endpoints here are survival and functional characteristics of the valve. What you can see here that the prognosis is better with valve in valve compared to valve in ring. The 4-year survival is 62% versus 40, almost 50%. The survival depends on the baseline STS score and also depends on the post-procedural MR. So post-procedural MR, significant MR, more than moderate would be associated with excessive mortality and not much difference according to mitral stenosis. The hemodynamics seems to be durable for at least 1 to 3 years, even more than that. And these are the echo characteristics of the patient. Again, when we distinguish between mitral valve in valve and mitral valve in ring, much better results with valve in valve. Survival is better, less mitral regurgitation, functional aspect is better, and independent correlate with significant residual mitral stenosis is obviously a valve in ring. The hazard ratio is about 8. The independent correlates of mortality are, except for age, valve in ring, worse prognosis, NIA class 4, worse prognosis, chronic lung disease, and chronic kidney disease are also associated with increased mortality. And independent correlates with repeat mitral replacement are mean gradients of more than 10 millimeter mercury and post-MR more than moderate. Obviously, this will need to replace the valve in higher likelihood. Recent data from the VIVID also indicate the valve asymmetry post-implantation is is associated with more excessive gradient, and also probably the need to replace the valve later on. And these are another predictors for LVOT obstruction, which is mainly the depth of implantation, and predictor for residual stenosis is the diameter of the THV and asymmetry following the implantation. There is a lot of work that was done by Maria Guerrero from Mayo Clinic, and this is a small but very important study that she did comparing the outcome of mitral valve in valve versus valve in ring and valve in MAC. And you see the prognosis in carefully selected patients, 30 patients with valve in valve are excellent. The functional aspects, the quality of life, everything looks very, very good. But we have problem with patients with valve in ring and certainly in valve in MAC, and this leads a lot of learning curve and also very careful selection of the patient. You see head-to-head comparison here, the two studies, the valve in valve on the left, the 30-day mortality 3.3%, 1-year mortality remains the same. And on the right side, the 30-day mortality of valve in ring is 6.7% and 1-year mortality 23%, with again, more MR, residual MR, and more need for repeat valve replacement. These are the results from the TVT registry, some 1,500 patients. Again, the paper that described the results up to 1 year and beyond 1 year. The transseptal access was associated with lower 1-year all-cause mortality versus transapical. It was almost 16% versus 22%. And this is the default preferred access in patients that can treat them percutaneously rather than doing a transapical, but it's not feasible in 100% of the patients. Our group have published last year our cohort of 50 patients with mitral valve in valve. We were able to show the prognosis of the patient up to 5 years. One third of the patient died after 5 years. Overall functional improvement was excellent, as well as valve hemodynamics. The future remains to be seen. We don't have a lot of data about the durability of the valve, but we have data about the durability of the native valve. And we also know from registries that over the years, we tend to treat younger patients with mitral valve degeneration. Then all these questions that have been raised with the aortic valve-in-valve procedures are becoming relevant to mitral valve-in-valve procedure. What should be the first valve? At what age? What is going to be the durability of the mitral valve and the second valve, and whether we can plan upfront mitral valve-in-valve percutaneous strategy patients at younger age. I think it's very clear that at the old age, the durability of the valve exceeds the lifespan of the patient. But in younger age, and especially in the gray zone of 65 to 70 years old, it remains to be seen whether the first recommendation would become bioprosthetic valve, followed by mitral valve and valve versus a mechanical valve. We also know that the valves are not alike. So if we implant, for example, an epic valve, we should expect for worse hemodynamic characteristics compared to mosaic or mitris valve. So the first selection, the first choice of the valve by the surgeon is very, very important. So in conclusion, I think the transmitral valve-in-valve is an emerging treatment option for structural valve degeneration in the mitral position for patients at high surgical risk. That seems to be better for mitral valve-in-valve compared to mitral valve in ring, as I showed you. Mitral bioprosthetic valve type, dimension, and procedural factors may impact the results on prognosis of the patient and the long-term valve durability of of the mitral valve in valve and mitral valve in ring procedure remain to be studied and established. Thank you very much for your attention.
Thank you very much, Dr. Kornowski, for the beautiful presentation. Interestingly, once and time again, the transeptal approach trumps the transapical approach in terms of better outcomes for the patient. Do we have any questions from the audience? Any comments? So it seems that the valve-in-valve approach with the use of the Edwards valve, the sapien valve, is the mainstay with the transeptal approach. The management of the transeptal iatrogenic ASD in these patients may be interesting. How often do you have to resort to closing this transeptal, this iatrogenic septal defect?
So we have to differentiate between iatrogenic ASD that cause left to right shunt without any hemodynamic or any hypoxemic consequences and a real need to close it. According to most series, and there are not too many data, we are talking about need to close of less than 10%. I can tell you that in our first initial 50 cases that we did, we had to close the ASD in three cases. So in our hand, it was 6%. And I think that most of the sites are reporting single-digit number. Having said that, you have to take into account that some of the patients would remain with a small hole. And, you know, for some cardiologists, it might even be a good thing in order to unload the left atrium. You know, the whole concept of left atrial shunting nowadays is becoming popular and certainly investigated in all kinds of strategies. So in conclusion, I would say it's not very common, but certainly you have to prepare for it in case of need, in case of desaturation, in case of prominent right to left shunt, and you need to know what to do if you need to close these ASDs or iatrogenic ASDs.
Thank you very much.
Just a short comment about it, if I can. We had several cases that we didn't need to close it immediately due to right to left shunt, but chronically, some patient developed right ventricular failure due to the left to right shunt that was accompanied in those specific patients with severe tricuspid regurgitation. And we need to follow up those patients carefully. I think that sometimes this shunt, especially with patients with reduced RV function, NTR, may cause additional volume overload of the right ventricle, and those patients sometimes develop right heart failure.
Costas, I think it's a good comment because it's obvious that all these patients need a very careful follow-up. Among the three patients that I mentioned that we needed to close, one was at a few weeks after the intervention. So certainly this patient needs a careful follow-up. You need to monitor left and right shunts and loading conditions, and sometimes to perform a very good hemodynamic studies. So I think it was a very good, important comment.
Hi, Mani. Hi, Ran. Thank you for being with us again this year. I just concur with your observation, Moni. I agree. We also had two cases that we had to close, but not immediately. So we had right heart failure symptoms developing over the next week. So one was like 1-2 months after, and the other was 2 weeks after. And Ran, from your experience, do you think there is any difference in heart and ham development in the sapien valve in the mitral position? Do you have any observations on this, how thrombosis behaves on the mitral side?
It's a very good question, and we had again, I can tell you that we studied very systematically our first 50 patients. We had 2 patients, one with a very, very scary heart that did not cause any clinical consequence, but we obviously put the patient on anticoagulation. And one had harm that we needed to put the patient on continuous heparinization for a relatively prolonged time. And we tend to treat nowadays this patient with anticoagulation because of the fear of more thrombotic milieu in the left mitral position rather than compared to the aortic position. But I'm not aware of comparative analysis between these 2 positions, very systematic or detailed analysis using CT. I think it would be worthwhile doing it. So it's a fear, it's a threat, something that we are aware of, and this is the reason we tend to treat most patients nowadays. Unlike our initial days with mitral valve, more than 10 years ago, we tend to treat these patients with anticoagulation for at least 6 months, but it is an open question to me and to our group.
So, Rand, Michael Reardon from Houston, a couple comments and a question. One, you mentioned lampoon, which can be somewhat technically complex, but with a valve or a full ring, you can do a reverse lampoon, tip to base rather than base to tip. It's a lot simpler. From years of surgical data, we know the mitral is a much more hostile environment. Mitral valves, surgical bioprosthetic mitral valves clot more often than aortic mitral bioprosthetic valves. TAVR valves are going to behave the same. And then lastly, we're in the Intrepid trial where I run the screening with Scott Lim. We're starting to see people come to us with septal occluders and trying to find out, can we get a transseptal mitral valve in there? And it becomes problematic to get enough space between the edge and the end of the fossa. When you have to close these, do you think about what septal occluder you're going to use and whether that one will be easier, Gore versus Amplats, and for future closing, or does it not make any difference to you?
Well, in our practice, we use either the Occlutech or the Amplats. We don't have experience with the Gore, although I know it's a valid option. And just start to use a suturing device, so we don't know about that. So in our practice, as I mentioned, it's either the Occlutech, which becomes the more popular device, or the Amplatzer. And the site of the puncture, as I mentioned, is important, and it leaves us, in the majority of cases, a good rim to place the device. So we have not had many patients that we needed to close, but in those patients that we needed to close, it was not a significant problem for us.
Regarding the comment that lampoon technique base to tip and tip to base, I fully agree. And base to tip is not very easy procedure and takes a lot of times. But tip to base lampoon is appropriate patients with complete ring. But without complete ring, it can be harmful for the aortic valve, and concomitant transcatheter aortic valve implantation may be required. And my question is about especially how you, for example, what is the cutoff value for predicted neo-LVOT in these patients? Because there are some discrepancies in the literature. So how do you calculate exactly the predicted neo-LVOT? And what is the most important cutoff value for you?
As I mentioned, we are very minded to the LVOT in our procedural planning. We aimed at obtaining an LVOT which is more than 2. Some would be more aggressive and say less than 1.9 is the red zone, 1.8. But for us, it's usually the 2 is the value that we start to be worried about. Honestly, we didn't have much problem with LVOT in valve. I think it's mostly with valve in ring, but with valve in valve, you have to make sure that you are not sliding too deep into the LVOT, because if you are going to place the valve within the frame, I think the likelihood of LVOT is relatively low. But so the cutoff for us is 2. And as I mentioned, more concerned with valve in ring compared to valve in valve.
So very well, we will proceed now with our next speaker, who is Dr. Balgith, an interventional cardiologist from Riyadh, who will be addressing the topic of transcatheter mitral valve replacement and transcatheter tricuspid valve replacement. What is the current landscape of the clinical trials? Very good. Okay, so we'll then discuss with Dr. Fabien Praz, who is from Switzerland, from the University Hospital of Bern, who will be addressing MR treatments options in complex anatomy. It's a videotaped discussion.
Good afternoon, everybody. Thank you very much for the invitation again to speak about the treatment of mitral regurgitation in complex anatomy, very timely topic, because we have an increasing number of options for treating this patient. We treat them better, but we also have different options we need to choose among, and we have 2 systems now, as you know, for the treatment of, for edge-to-edge treatment of the mitral valve. One of them is Pascal, the other one is a mitral clip with 4 different device sizes, allowing for an individualized approach of patients with complex anatomy. And then, since 2021, we also have an option for transcatheter mitral valve implantation via the transapical access, the 10-9 valve, which is approved in Europe for the treatment of patients that may not be eligible for edge-to-edge repair. I will focus my talk mainly on primary mitral regurgitation because these are the patients with a more complex anatomy. What did we learn from the surgeon? We learned something I think is very important. We learned that we have to have good result. And you see, even the patient having mild residual mitral regurgitation under anesthesiology condition in the OR, these patients have a worse prognosis and also higher recurrence rates of MR during long-term follow-up, 15 years in that particular study. And this apply also to transcatheter edge-to-edge repair. In the TVT registry, including more than almost 3,000 patients, you see that having mitral regurgitation grade 0 or 1 was a predictor of good prognosis and longer survival in this population of patients. So what do we need to achieve? And that's a difficult goal, in particular in the patient with complex mitral anatomy, but that should be the goal we aim to. We need to achieve mitral regurgitation grade 0 or 1. We need to have a mean grading that is less than 5 millimeter of mercury to avoid severe mitral stenosis. We need to have a low left atrial mean pressure that has been linked to mortality in one study. We need to avoid having significant mitral stenosis, meaning mitral valve area of more than 1.5 square centimeter, very important. And finally, we need to have a durable result. Are we able to do this in all patients with using edge-to-edge repair? The answer is no. And that's why we need to select appropriately this patient. But what we have to say that we are getting better and better at treating this patient due, on one hand, to technological device improvement with different sizes, with better technical characteristic of this device, but also, and that's very important, to increasing experience, not only from the interventional cardiologist, but from the whole team, in particular the imaging team, in selecting the patient, in guiding the procedure. So very positive result, actually, that may not apply to all kind of anatomy, and that's why patient selection is absolutely key. What about surgery again? And the surgeon, we see this on this slide. Surgeon also struggle to achieve perfect result in patients with Barlow disease. You can see that in the comparison with classical fibroelastic disease, flay leaflet, for example, that they achieve a lower repair rate. Most of these valves, or more of these valves, need to be replaced, and in long term, the recurrence rate of mitral regurgitation is higher. So also surgery has its own limitation in the repair of the valve, but of course surgery is able to replace the valve in the same situation if repair is not successful. If you look at edge-to-edge repair, then we and the expand data with the third generation of the MitraClip, we see that a large proportion, about 1/3 of the patient, have complex anatomy. And these anatomical criteria are well accepted for defining patients that are more difficult to treat with edge-to-edge repair. These are patients with jet outside A2P2, commissural jet, calcification, low mitral valve area, very short posterior leaflet, or the patient you know that will bring you into a challenging procedure. In this patient, we see differences. We see that about 15% of the patient or less the patient are able to achieve MR grade 0 or 1, 15% less compared to non-complex anatomy. This is an important finding and has consequences on the long-term follow-up of this patient. Part of this patient are the Barlow patient, and similarly to surgery, you see that we are struggling also a little bit. We can achieve an immediate result that is quite acceptable, quite good in that patient, but over long term, up to 3 years in that study, you see that the recurrence rate of mitral regurgitation is higher compared to non-Barlow patient, and that this may also have an impact of clinical endpoint like heart failure hospitalization. Looking at both systems, Pascal versus MitraClip, no big difference here in the treatment of complex anatomy. You see that this study found a little bit more effectiveness of Pascal in treated Barlow patient, but definitely something that needs to be further investigated. Just wanted to show you a case to illustrate this talk. So this is a patient that is high risk for surgery, mainly due to age. You see the patient is 85. Heart failure, a valve that is complex, bileaflet prolapse, severe mitral regurgitation composed of several jets and involving the majority of the coaptation line. So this patient has clearly an indication to do something, is high risk for surgery. The surgeon will tell you in that situation that he will probably need to replace the valve with a high probability, and then edge-to-edge repair is certainly a good option in that situation. Our strategy was to aim the two main different jets of this diseased valve. You see one jet on the lateral side with the implantation of an ECW clip, and a second implantation on the medial side with a good result at the end of the procedure. So definitely, this patient can be treated if the surgical risk is high with edge-to-edge repair and with a quite good result. What is very important to understand, and I want to illustrate this on this slide, is also that beside anatomical complexity, which is a spectrum of complexity going from patients that are ideal for repair towards patients that are very difficult for repair and may be better treated with replacement, the experience of the center plays a very important role and need to be taken into consideration. While some centers with low experience will struggle, treating a patient with complex anatomy can be done in more experienced center with excellent results. And this defines also individually in the center the threshold for going and evaluating patient towards valve replacement. What are the criteria for replacement? In primary MR, these are very much the one I mentioned before regarding anatomical complexity. So commissural MR, low mitral valve area linked to calcification, maybe MAC, short posterior leaflet, perforation, multiple jet. These kind of patients should be evaluated for replacement. And in secondary MR, there is, in my opinion, not so much room for at least for transapical system in a patient with reduced left ventricular function, but patient with atrial secondary MR less advanced ventricular failure may be a candidate. And finally, an emerging indication as well are patients with failed surgical repair, so patient having already a ring or patient having already a clip that you will be able to separate from the anterior leaflet and implant a valve, are also in a very selective situation candidate for this therapy. This is a clear-cut patient, so it's an older patient pre-operated with a MAC, mitral valve stenosis as well, not a candidate for edge-to-edge repair. And this patient can be very easily treated using the 10-9 valve from transapical access. We'll typically predilate the valve and then implant the 10-9 valve with a very good result. If we compare now 10-9, for example, versus mitral clip, then you see some differences in terms, of course, of mitral regurgitation reduction, but also on the consequences of this good reduction, probably, because you will have the tendency to see more remodeling of the left ventricle, but also some positive effect on the right side with improvement of the right ventricle. You know, one of the important questions, what do we do with the patients that are complex but refused for transcatheter mitral valve implantation? That's a common situation. In that situation, the choice registry helps us a little bit to have some information. Of course, not a randomized comparison here, but a comparison between different treatment strategy of the patient ineligible for transcatheter mitral valve implantation. And you see here that the best prognosis is actually achieved using a complex edge-to-edge repair to reduce mitral regurgitation compared to high-risk surgery or to only medical treatment. So let me conclude by saying that in complex anatomy, edge-to-edge repair is a reasonable treatment option in experienced center, but that replacement should be considered as well and should be evaluated rather than going into an unsuccessful edge-to-edge procedure. And finally, in patients ineligible for transcatheter mitral valve implantation, complex edge-to-edge repair is probably the better option rather than going for very high-risk surgery or conservative treatment. So thank you very much for your attention.
So do we have any, obviously we can't do any questions, but if there's any discussion from the audience or any...
If I can make a comment, it's Dimitris Mikas from Ioanna University Hospital. I'm not so experienced in this kind of complex procedures. I'm very fascinated about all these procedures presented and all these techniques presented during this time. But Michalis, I have a question that nobody can answer me up to now. I mean, it's not a technical one, but should we start, as many and many devices are coming up now to treat the mitral regurgitation, should we start and standardize this regurgitation post-procedure? I mean, is it, I would say that it is rather unacceptable to have this plus grade of the mitral regurgitation. And as many devices will come, and I suppose most of them will be fine to treat severe regurgitation. I think we should start to look more in detail which regurgitation is severe one, how much severe it is, and how can we treat them in the next time, probably.
I agree with you that this grading system that we have now, 0, 1, 3, 2, 3, 4 plus, it's certainly a very gross in a sense. It's not very detailed, and especially after interventions, it's sometimes difficult to really quantify the degree of mitral regurgitation. So definitely there's an unmet need to be more accurate in grading mitral regurgitation.
It's good for any interventions, but I don't know whether it's good for our patients. I mean, in the long term, especially, because for the next 10 years, I think that details will make the difference, and details started to matter here.
Yeah, I agree with you that this is something that we've been using for years now, but it's something that we should adapt to the new conditions. And now we have new technologies, modify mitral valve. They change the way the blood flows through the mitral valve and during systole and diastole. So we have to adjust to this new reality. So I think we should move on to being more accurate and measure degrees of regurgitation in a different way.
Well, I think Becky Hahn's 7 grades are going to work for people who are running trials. But I think for the average cardiologist that I deal with, it's hard enough to get them in their offices to give me a 0, 1, 2, 3, and 4. So I think in our trials, it's going to be important. Watching this as a cardiac surgeon, I'm fascinated because not only are we treating complex stuff now, but as you know, we now are going to start trials of surgery versus TEER in low risk TEER cases that you think as an operator you can get 1+ or less. And to think how far we've come from the original Everest trials, to me as a cardiac surgeon, that TEER is now going to challenge low risk primary mitral valve repair, basically P2s, is just fascinating.
So we're going to be proceeding with Dr. Balgith, who is going to be addressing the clinical trial landscape for transcatheter replacement in the mitral and tricuspid space. Dr. Balgith, thank you very much for being with us. We can't hear you. Can you unmute your microphone? Yeah.
Do you hear me now?
Yes, absolutely.
Excellent.
Thank you very much for
You
being
see my
with us.
slide?
Yes. Yes,
You
we
see
can.
my slide?
Yeah, yeah, you can put it in presentation mode.
Right.
Very, very good.
That's good. Thank you very much, all of you, and for the organizing committee to have me from Saudi Arabia with you guys. And special thanks to our friends who's visiting us for the last few months, Dr. Spargis. And I hope we will invite you to Riyadh Structural Heart Disease in January, at least good number of you guys. It's a difficult subject to talk about transcatheter mitral and tricuspid valve replacement. As we know, mitral valve disease is a messy. It's a very difficult anatomy when we talk about mitral valve disease. And the previous speaker already, they touched on some of the difficulties. When we have a good experience, to be honest with you, all of us now with the TEER, and we saw a lot of cases today, both mitral and tricuspid, but still in spite of good experience and good learning curve, many years we have experience, but still we see the patient in the outpatient clinic with some mitral regurgitation, although some of the clinical studies improved a lot. You think about the replacement, and when you think about it, it's more durable and it's able to treat small valves, MAC, and multiple jets. Some devices able to treat mitral stenosis, which is very common in our area in the Middle East, especially in Saudi Arabia, Egypt, with the rheumatic heart disease. And in spite of TEER screening, still we are losing some of the patient we screen them because they are not fit for the mitral clip or Pascal. And there is encouraging data with regards to feasibility and safety with a variety of devices, as we know. The typical mitral or transcatheter mitral valve replacement, it's for those high-risk patients, like high surgical risk for open mitral valve replacement, the MAC, rheumatic heart disease, and the recurrence after surgical repair, for example. There is a technical and delay in the randomizing or including those people in the trial. And those trials for the replacement, both mainly in the mitral replacement and even in the tricuspid, it's delayed and more slow growing in comparison, at least with the TAVI. And we know it's for many reasons, including the technical, anatomical, and technological design, which attributes to the devices and the anatomy of the patient. And what we are using for those trials, it's the same with the researcher using for the TEER suitability criteria. And those prohibited from the TEER, they include them in the TMVR trials. And as you can see here, a lot of patients, we know they are rejected from the screening for many reasons, either for the anatomy, including the LVT obstruction, annulus size, the MAC, leaflet morphology, or the LV function, or the other comorbidity, in addition to the transcatheter delivery system. Again, there is too many trials. They screened too many patients, and they ended by accepting only small number, to be honest with you. And we know not all the technology will fit all the real world anatomy. You have the D shape and you have the circular, and that's why if we compare it with the TAVR, unlike TAVR, the development of universal device tool, one design fit all may be challenging in those patients. Most of the devices available are transapical, but at the same time, they are large in the sheath. And there is, other problems we have to keep an eye on them. And especially when we started here in Saudi Arabia, the tendine, it's mainly driven by surgical, although we are with them in the cath lab. Transseptal, again, it's still the devices available are very large in size, but they are coming to a better sizing now. Up to 2022, still there is current problem with the devices. As we mentioned, some of the devices, they are purely transapical, and it's a large French size, as we said, but still there is the problem with the persistent prevalvular leaks, valve leaflet thrombosis, and adequate opposition will be difficult to be achieved in all the cases, and the large anatomy, you have to keep it in mind. Too many devices available for transmitral valve replacement, and as we can see here, the most common use, at least in our country, is the tendine, at least in 3 of our hospitals, and I think there's more than 70 cases implanted now in our country, in Saudi. Do we have good trials? Yes. I mean, this is one of the good trials published in 2021 by David Moller and Suraja. It's a 2 years outcome of a tendine in those high-risk patients. And as we can see, there was a good impact on the mitral regurgitation and severity after implanting the tendine valve here. It's a good number of patients, about 100, and the follow-up up to 2 years in 40, almost 50%. And you can see a significant B-value with a beautiful result up to 2 years, maintaining a good result of a none to trivial MR, which is excellent. Again, here, what you can see, the recurrent or heart failure hospitalization is dramatically improved in those patients who underwent a transcatheter mitral valve replacement. Also, both in the 6 minutes walk and in the quality of life and the shortness of breath. Again, tendine, it's very well known now. The SUMMIT trial is going on now, almost about 400 up to last September included. Now they're including the other arm, which is the MAC arm. There is a lot of evolution and movement in those valve replacement. And the tendine, there's already more than 1,500 patients treated worldwide. And that tell you it's a very promising, easier to use. I can see the impression of our surgeon and our colleagues in the cath lab and the hybrid lab, so happy. Even the follow-up is very promising, at least in our patient. Again, the movement of the SUMMIT trial, the big ones, is going on. Those are some of the cases you can see. And SUMMIT is the only TMVR device currently being studied in randomized controlled trial. That's why the FDA has approved continued access to SUMMIT MAC arm. From Medtronic coming is the Apollo. And as you can see from the trial, there's 2 arms, the primary cohort and the MAC cohort. And started previously as transapical, now moving to transfemoral. The sheet available is very big, 35, and now they are moving to a smaller sheet, I think around 26. And the first 30 patients with the result, it's very, very good. As we mentioned, this is the size of the French size, 35. And as you can see here, this is 1 year results for about 30 patients. It is promising, although it's not complete 100%, but it's very promising. This is Dr. Zahar, Firas Zahar, again, up to 1 year. You can see both the echo results and the New York Heart Association class. It's very excellent result by end of 1 year, 91% they have no or only trace MR, and the NEHA classification is very good in comparison with the baseline. The movement to the Interbed 29, as we mentioned, and the Apollo global expansion going to Canada and Europe. And the M3, as Samir, we asked him, they have it in Cleveland Clinic. I think they are doing cases in trial, in Circle trial already going on. And in conclusion for the mitral, as we can see here, early TMVR experience is encouraging in highly selected patients. Pre and peri-procedural imaging is a key. The runway success of TAVI may be difficult to emulate in these cases. Regarding the tricuspid or transcatheter tricuspid valve replacement, it's the same, the success, the failure, the imaging, and the technical consideration. And again, even the tricuspid, we know from the TIRA, and we saw the case done by Dr. Spargius, even with the the TIRA itself, either Pascal or CLIP, it is challenging, and you have to be very patient. And in case of replacement, we have the main difference between us and the surgeon is the age. There's too many valves available now, and one of the most famous nowadays, it's the Evoque and the LOX valve. The trick valve we started here in the country. Treatment efficacy, safety, and patient selection, this is the key. The new result from the Evoque, which is excellent valve, it's very, very promising, both in the severity of TR and the NEHA class and the quality of life, plus the 6 minutes walk distance. And you can see from the TRISCEND first trial, the right femoral axis was 100% succeeded, and the device success up to 98%. This is excellent. The procedural success 94, and the device timing and the implantation for the procedure 70 plus minus 30 minutes, average of 56. This is very good. And this is a LOX valve, both of them promising. The Evoque more familiar. This is the TRISCEND done by Kudali, presented. It's a very familiar valve, and they showed their data. Very high risk patient they included from state with excellent results. And as we can see here, the severity of TR at discharge and at 6 months, and the major adverse effect at 6 months, the heart failure, hospitalization less, and the NEHA class, all those things in favor of this new technology. And in conclusion, for the TR replacement, the 6-month result demonstrated 96% survival and 94% freedom from heart failure. And the randomized pivotal trial, TRISCEND 2, it's underway. Thank you very much.
Thank you very much, Dr. Balgith, for this is a very comprehensive overview. Do you have any questions from the audience?
I just want to make a comment. I mean, thank you, Dr. Makid. It was a really amazing information. It was tremendous information. I suppose that this is an ever changing and evolving territory. What if you have been an engineer in a company? I mean, which 2 or 3 basic characteristics would you suggest that we have to pursue for in order to achieve the best valve for either the mitral or the tricuspid valve?
You want me to answer or somebody else? Is this question for me?
Yes. Yes, it's for you.
Yes, I think mainly it's the patient anatomy. And they are having a lot of difficulties. All the designer to get the best, they have 16 devices for the mitral valve available in the market. And you know the anatomy is different. And the D shape, one of the major obstacles they have already. And I think with the Tendyne experience, at least in our country, about 80 cases done, I think they have multiple sizes. That's why I think if they expand on the sizes of the valve, this will make their life easy. It is difficult to choose, at least in the mitral, one device per se. But if you have same like the TAVI, at least 3 different with different criteria, where if this one will not fit for that patient, the other one will fit. Same like self-expandable and balloon expandable. The TAVI, I have 5 companies in the cath lab, which can fit for most of the cases. But again, it's not to be different and the patient difference.
Somebody spends a lot of time with engineers on this. I can tell you that the biggest issue right now is the fact that 70 to 80% of people that we screen are screen failed. And even if the trials are positive, if 80% of the people screen fail, you do not have a commercially viable device. And we also have to get transeptal, because transapical is never the end. So they're going to have to get down to 29 French or smaller, and they're going to have to work out the LVOT, which unfortunately for many of the valves means that the valves are going to have to be re-engineered. Some of the newer valves that we're starting to do EFS on, like Cepheid, were designed from the get-go to be transeptal, but Intrepid was designed like Tendyne to be transapical, and it's just being repurposed to being transeptal. So I think there's some real challenges, from an engineering standpoint going forward, because even if these trials turn out positive, if 80% of your people can't have it, that's a real problem. And I think that's an engineering problem. I think for the young doctors that are working with you, that's a real challenge for them to go forward. This is something they need to fix. The other thing they need to fix is, we know in surgery, repairs are always better than replacements. So why is that? It's because as long as you maintain your normal anterior mitral leaflet, it directs the blood into the ventricle so that you get a counterclockwise vortex, which lets the ventricle fill easier and empty easier. As soon as you put in any artificial valve, you lose that. The blood goes into the septum, you get chaotic flow and energy loss. So we need the engineers to design a valve for us that mimics an anterior mitral leaflet. So there's some really fun challenges. I wish I was younger so I could see these come about.
Very well.
Yes, I share the frustration in enrolling patients for those devices. We might have 100 devices, but when they're not accepting many patients, I must say that from our experience, less than 10% of the patients that are suggested for those therapies are eventually getting the valves. And until there'll be better solution, especially for the LVOT obstruction, which is a major reason for excluding patients, I think that the therapy will not grow.
Okay, thank you all for your contribution. And now we have the daring task to show one case live in the box within 10 minutes. So I'll ask my colleague, Dr. Stathioyannis, to present the clinical history and the imaging analysis of this case. And immediately after that, while the video, the pre-recorded video will be playing, Dimitris, and I don't know if Dr.
Right, great, thank you. So very quickly, this is a 78-year-old male.
Dr. Agheli, yep. Sorry.
NIH class 3 symptoms. He's been volume overloaded for the past few months with ascites, and during the recent hospitalization for IV diuretics, he almost lost 12 kilos. He has a permanent dual chamber pacemaker at age 62. Almost 15 years ago, he had a bypass with 3 grafts. He had a recent myocardial scintigraphy test that showed no ischemia. A right heart cath showed a raised high mean right atrial pressure and systolic PA pressure of 43 millimeters mercury. Other prominent medical histories, there's end-stage dialysis, end-stage renal disease under dialysis, paroxysmal atrial fibrillation, and anemia. We have the echo that shows severe TR, dilated RV, and good function, and an LVF of 65%. Let's jump scintigraphy with no ischemia. Chest X-ray. So let's just jump over to the TT images where we see dilated right chamber, both right atrium and right ventricle, huge torrential tricuspid regurgitation, And as we said, based on TAPSE and STDI, very good function of the right ventricle. And we see here how dilated the tricuspid valve annulus is, good GLS and a dilated IVC. And these are very nice images from our lab that shows right ventricular 3D volume and systolic function. And I think is for imaging analysis, would Dr. Angeli, is she here with us? We'd be more than happy for her to comment.
Of course, thank you. So we proceed to the transthoracic echo. You see the transgastric view, and you see that there is a lead near the septal leaflet of the tricuspid, and we can see clearly using live color compare the tricuspid regurgitation. Next slide, please. So using the esophageal echocardiography, we can see that the left ventricle again is has a good function, and as Dr. Stathogiannis said, the patient has a normal left ventricular function. Next slide, please. You see that the mitral valve regurgitation. Next slide, please. We can see using 3D and 3D photorealistic views, we can see that there is a cleft at the P2 area, and the mitral valve regurgitation evaluated as moderate. Next slide, please. And concerning aortic valve, we can see that has degenerative changes. Next slide. Let's see tricuspid valve again, transgastric view, using color compare, and we can see that there is a large tricuspid regurgitation, a very severe tricuspid regurgitation from the anterior to the posterior part, and we can see also that the lead of the pacemaker lead here, okay, and the tricuspid regurgitation in this area may be more larger. The next slide, please. Again, the tricuspid valve, and you see maybe at the area of the lead there is a moving part, maybe is a flay part at this area. Next slide, please. Using again mid-esophageal 3D photorealistic view, we can see the lead of the pacemaker lead at the at this. We can see this area. Okay, again. So deep esophageal biplane view of the tricuspid valve. We use in every patient just to see the tricuspid regurgitation better, and we sweep the line across from the anterior to the posterior portion. Next slide, please. Again, we sweep all the time from the anterior to the posterior to see how the leaflets are looking. Next slide, please. And we can see using color compare that there is a large tricuspid regurgitation jet, more proximal to the posterior part of the leaflet. And if we can measure, maybe it's more than 10 millimeter. And next slide, please. Again, low esophageal plane, central area, we can see again a large tricuspid regurgitation jet. So you can see that at the posterior septal area, we can see the larger regurgitant volume. And we have to discuss, is this the treatable area in concerning the tricuspid, it concerning the TriClip procedure. So we can discuss it. Okay.
Okay, thank you, Kostadina. So if we can start the pre-recorded video, and Dimitris will tell us here if he has any suggestion, and Konstantin, of course, and Moni, how you would proceed in this case. There are some specific characteristics. One is the Eustachian valve. As you can see, there is a big one, but I don't think this will create any problem. The other is the pacemaker lead that is compressing, not impinging. I think it's movable, but it's compressing the posterior, the upper part of the septal leaflet. Despite the lead being there, the major tricuspid regurgitation is coming from the anteroseptal lead, which is like a good feature for tricuspid TEER therapy. And that's why, despite the large gap, we accepted this case. What was the gap in this case? It appeared to be quite big in one imaging.
It was over 10 millimeters.
Yeah. So, Dimitris, please go ahead.
So, first of all, I would like to thank the organization committee and personally Kostas Spaghias. Thank you very much for having me here. It's really an honor and lucky to be here and learn from you, the world experts. I'm not experienced very much in the tricuspid regurgitation, but I'll give you a short presentation, 5 minutes. Just consider this presentation, my presentation, a short break to relax from this previous fascinating presentation that you had. So if I have a couple of slides, I will be really quick. Can I advance this one? So as we always know, and despite the tricuspid valve being one of the most important valves in our heart, being the largest one and the most apical one, unfortunately it's the forgotten one. And unfortunately, again, this forgotten valve affects severely the prognosis of our patient. As you can see here, this is a really old study which demonstrated that the prognosis of our patient with severe tricuspid regurgitation is really worst. And this is irrespective of whether the patient has a severe or non-severe pulmonary artery systolic pressure, doesn't have pulmonary hypertension, and again, irrespective of whether the patient has a left ventricular ejection fraction, good or bad. So if our patient have a severe tricuspid regurgitation, regardless of whether this patient has a pulmonary hypertension or even good or bad ejection fraction, the prognosis is really bad. And I want you to remind you all these causes that all of us are aware about, the causes of tricuspid regurgitation. Just to remind you that 75% of them may cause secondary regurgitation, being the main problem in the ventricle rather than the tricuspid itself, and only 25% is a primary regurgitation. I would like here to point your attention in this pacemaker ICD leads, which nowadays is getting a more severe problem. So this is, up to now, we had only this surgical repair, which was really, I would say, a bad solution. You can appreciate here that in a lifespan of, let's say, 10 years, the prognosis of those patients wasn't good, 12% of mortality. This is really bad. And unfortunately, even those patients with isolated tricuspid regurgitation had surgery, the prognosis again was really bad as well. I mean, even 10, 15, or 20 years after the surgery, the prognosis was not better comparing to the patient that he had medical treatment. Several tools we have today, I think most of them you have heard about those tools in previous presentation, fascinating ones. I think the most convenient one, the most used one is the TriClip and the Pascal. We don't have experience with Pascal device. I suppose Kostas has the biggest experience here in Greece. And even the TriClip is the old fashioned mitral clip, which is a little bit modified in order to offer better access to the tricuspid valve. The data are few, I would say. This is one of the only randomized trial which compared medical therapy with the tricuspid TriClip procedure. And you can see here very good treatment of the tricuspid regurgitation. However, no sufficient improvement in terms of mortality, surgery, or the need for rehospitalization. This is really a disappointing result. However, we don't need to forget that those patients had significantly improved the quality of life, and this is something that we need to pursue in those patients. As as those patients are getting more and more and getting more older and older, I think this is something we need to pursue for. The same results come from also the BRIGHT study, which is another study which demonstrated also good treatment of and success in the treatment of the tricuspid regurgitation and very much good improvement in the NIHA class association of those patients. As regards the strategy, I think most of you are more experienced than I am. We know that the bicuspidization of the valve is the primary target in order to clip either the septal with the anterior or the posterior leaflet. Some of them offer the Clover technique, which is the clipping of and the proximization of all three leaflets. The only thing, at least we have to be careful about, is not to clip the anterior and posterior leaflets in order sometimes to avoid the destruction of the valve and the worsening of the regurgitation. This is one thing that I need to draw your attention in, is the cardiac implanted electronic devices, tricuspid regurgitation. As you can see here, this is a phenomenon and a problem that is getting more and more common. We are a center for pacemaking and implantable defibrillator devices. So we are starting, as many of those patients getting more and more of those devices, we start to see more and more patients having this problem, as the one that you saw previously. Several algorithms are proposed in order how to treat this disease according to the interaction of the lead with the tricuspid leaflets. I mean, all of those algorithms propose the first thing to remove the lead. However, this is not possible, especially in patients that have these leads implanted several years ago. So in conclusion, I would say, rather than the suggestions, I would say that tricuspid regurgitation regards an important, forgotten problem, but up to now, nowadays we have several, as you have seen in previous presentation, several solutions to deal with this problem. The edge-to-edge repair offers a very attractive treatment, and the cardiac implanted electronic devices associated tricuspid regurgitation is a problem that needs to be addressed and is going to be a more common problem in the future. And I suppose that edge-to-edge repair, Kostas will tell us afterwards, would be a great solution for selected patients. Thank you very much.
Thank you, Dimitris. And if we can go back to the video case, the video presentation. So the dire task is becoming now direst. We have to finish. So this is the case. Moni, are you with us? Professor Balgith, are you with us? What would you choose for this case?
So
what your strategy would be?
Yes, thank you very much. I think that, as you spoke before, most of the jet is anteroseptal, and I think that the lead, although it's there, it won't make the procedure impossible because she's moving and she's not really impinging the septal leaflet. I think that it's highly important to come with a good angle to the ventricle. I think that this is a good angle. You're not a septal hugger. Sometimes it could be a very troubling issue when you come a septal hugger and you don't have the ability to fix it. With the true clip and the Pascal, we have now the ability to do it. I think that the orientation of the device now is nice. It's between the anterior and septal leaflet. And I think that I would start there and then evaluate the residual regurgitation after grasping the leaflets there.
Oh, sorry. Professor Balgith, are you with us? Okay, so this is a Pascal ACE. Going down was, as you saw, relatively easy. We got around the eustachian valve without problems, and then we check the perpendicularity and the coaxiality. We want to be perpendicular on two planes to the tricuspid valve. We aim to the anteroseptal area with this device where the majority of the color was coming from. There was a little color from the posteroseptal area close to the lead, the pacemaker lead, that was compressing the upper part of the septal leaflet. So here we are below the leaflet with the Pascal ACE, which I remind you, it has a spanning of 26 millimeters. So from the side to side, the total spanning is 26 millimeters. So here we're aiming for independent clasping and we're aiming at the anterior leaflet. So we're in the collar, within the collar, torrential TR, and we check our perpendicularity. So we aim to an orientation like 2 o'clock and 8 o'clock. We want to get the septal leaflet as high as possible, and the anterior leaflet in the longest segment of it, so to maximize the reduction of the TR with just one device. And if the strategy is, if we are successful with one device, as it was in our previous case, we saw it in the tricuspid, close to the center of the valve, then to finish with one device in the dorseptal area. And then we would check and see if another device would be needed in the posteroseptal. So, Dimitris, your suggestion was very close to our strategy. Can we put the video fast forward somehow, just to save some time?
Kostas, if I may ask, is there any reason in this case to remove the lead first? Because I was thinking, if this is a typical syndrome of lead interaction between the septal leaflet and the lead itself, is there a reason to remove it and put a micro, let's say, pacemaker in this patient and do the job more, I would say, more easily or even more successfully, more sufficiently?
This is a very, very interesting point, very interesting question. If the lead is not, doesn't have any impact on the imaging, it doesn't deteriorate your imaging, it doesn't has any shadowing on the leaflets, like in this case, then it's not necessary to modify something. But if the lead, it's a defibrillator lead, for example, with a sticker, and has a lot of shadowing, so you don't see the leaflets at the area you want to go, then one suggestion is to try to move the leaflet by using a deflectable catheter like an Agilis, go there and flex the Agilis and try to get the lead away from the septal, like in our case, so get it posterior, lateral, and see if that improves the imaging, and then you're more successful. This is just one suggestion that has been tried by some people successfully, and we could think about it in cases of difficulty. But the lead here was not, sorry?
We did it twice. We used the EP guys to come to the cath lab, and they hold one of the leads, the lead, and then we were able to see better the grasping area, and then we implanted the clip. In that case, it was. So it's definitely doable, especially if the lead is not very old, which is sometimes there's some issues with very old leads that it is very difficult to move, and it might cause some harm to the leaflet. So we need to be very careful in this.
I'm happy to hear that, because I also have this experience with Dr. Samagardi in Riyadh just a week ago, that we had a defibrillator lead that was having a lot of shadowing, and we used this trick with Agilis catheter, and we had a perfect imaging after that, and we're able to complete the case very successfully. So it's good to change this experience, and this is a trick we can use in the future.
Another question, maybe?
There is a question, yes, please.
Yes, about the Agilis, actually, a comment and a question at the same time. So, of course, it's possible, and we know it's possible to remove a little bit the lead, but we know, all of us who make tricuspid regurgitation tears, that there is also the late detachment problem, especially if we have a lead cable over there. What about, in order to combine that also with the next presentation or the next session, what about in heterotopic valve implantation in patients, especially who have a big gap and the lead over there?
The measurement of our gap, thank you for this question, was not forbidding.
10 millimeters, yes.
Yeah, so that's why we decided to have a go first with TEER, and in case we're unsuccessful, then to think about heterotopic valve implantation. I think from our end result, we're not disappointed. So here you see clasping within the commissure, the interseptal commissure. Is there higher speed on the video? Okay. So you see both leaflets are going in.
Transthoracic also to evaluate leaflet insertion.
And this is the release of the clip. So this is 1 Pascal ACE. If we can go slower now to assess the result. Apparently we're happy with the result.
This is the second device coming in now.
So if I understand quite well, one device went to the septal anterior commissure or leaflet towards the commissure. Did I got it right?
Yes.
Negative,
the first
right?
device is released in the anteroseptal. And now we're going to a second device, but we missed because of the fast speed the result of, we're going to see it soon now, hopefully. It was a good result with that clip. It was in the middle of the collar. So this is the second. We're trying to attain perpendicularity with the second to go next to the first. Opening of the second clip just above the valve. And here our aim was to go again anteroseptal next to the other clip and to get a better result. Apparently we had residual color and regurgitation towards the middle of the first clip. So MPR again is helpful.
I think that whenever you plan for 2 clips, the first one should be the more anterior and then add another one because of the imaging issues, as you did here.
Yeah. So here, if I remember correctly, we tried many times to get the anteroseptal again, close to the other clip, but if you see here, you will see that the anterior probably has 2 scallops, and the largest scallop that was easier to get into a device was a little more central than what we wanted to be. So we're not really touching the other device. And if we can go fast forward now again. And the independent clasping again, this is the lateral, and then moving of the device, closing the device. So you see we got that scallop that I don't know what name I should give to that, if that is part of the anterior. I don't see the papillary muscle. Michael, can you help?
Yeah, I think we're posterior to the papillary muscle, so it would be septal posterior in my eyes.
So we're away from the pacemaker lead, and I think we should go to the final result. If we can play the video towards the end to see the final result. Yes, here. So releasing the second one.
It's a clover technique.
Silly question, can I make one? Yes, because there are no silly questions, there are no silly answers. So do we need transthoracic echo here? And why we need transthoracic?
It's complementary. If we want to take another look at the leaflet insertion and verify, because sometimes the tricuspid you have perfect imaging from transthoracic. So it's complementary to the transesophageal.
Okay, this is the final result. I'm not happy with the imaging. If we can go slightly earlier than this. Yes, here. Can you let it play from here on? Just to see the final result. So the positioning is very good. We have color behind, more posterior to our second clip. But all the anteroseptal regurgitation we had is gone. And now what is left, it is the part of the posterior that we had close to the leaflet. I don't think we're opening something new.
I think it's the pacemaker wire that will always keep that septal leaflet tethered. So some degree of regurgitation will occur from the posterior septal area. And you can see here the...
Okay, I think we have to stop here and to proceed to the next session. Thank you very much.
Okay, slightly late, but not discouraged, because looks like we're going to have a very interesting topic about hot details of mitral and tricuspid tear topics. We have some changes. Our liaison, Gregory, told us that Dr. Babbitt, Professor Babbitt in Minneapolis has been, as usually in surgery, been called back for a case that is in a stress. We all know what means surgical stress, and he's not going to be able to give us that topic. On the other hand, Nia Sardari is in a rush because we delayed the presentation, and he needs to give his presentation before, because he has some other obligations. So please give us the opportunity to introduce Nia Sardari. Is a good friend and esteemed colleague. We have a close cooperation at the Yale Hospital, a well-known surgeon in mitral and tricuspid valve repair, and where he's in Holland, in Maastricht, and he's going to give us the advantages and limitations of thoracoscopic mitral and tricuspid repair. Nia Peyman, very nice seeing you, and we're eagerly expecting your presentation.
Good afternoon. Thank you, Dr. Patakos, for the kind invitation and introduction. Unfortunately, I couldn't be here in person, but I will be soon visiting IKEA Hospital, where we have a very good collaboration with you and the cardiologist there. So after talking to the organizers and also the content of the session, so I'm going to present different phases of mitral valve disease from the perspective of a surgeon, and also, which is also important for the interventional cardiologists involved in the field. These are my disclosures. So I think everybody knows there are more than 70 different devices are being developed in the field of mitral valve disease and intervention. And what is very important to recognize is none of these is going to be effective in all patients, probably in some, and nobody is going to be an expert in all of them. Now, with regard to the surgery, obviously the advantage of the surgery is you can address any pathology, but obviously surgery is not suitable for every patient because of the related invasiveness and possible comorbidity. So the main message of my presentation is what is very important is to address these different heterogeneities and try to provide the patient with the best solution. And that's only possible if you work together. Whether you work together in a concept of the heart team, or whether you work together as a colleagues, you really need a good surgeon, you really need a good imaging cardiologist, and you really need a good interventional cardiologist. Now, in Maastricht, we have different tools to address mitral valve pathology. I'm myself very well involved in transcatheter technologies as well. Some of these devices I'm also the official trainer for. But how we have set up our program is obviously you look at the mitral and with the question whether you need any intervention. But what follows is much more important is whether the patient is for which intervention is the patient suitable, and this is with regard to the anatomical suitability, and much more importantly, from which therapies the patient will benefit. You can have a P2 prolapse patient being 40 years old. You can have a P2 prolapse patient being 80 years old. This is a big difference, and you can only address these questions in a fair manner towards the patient if you work together in a team. So this is the way we have set up our program in Maastricht. We will work with dedicated heart team, which takes the lifetime management of mitral valve disease through the whole process of care. We discuss all comers together, decide together, and most of the procedures, especially the transcatheter, is also done together. And we have also shown that if you are treated by a dedicated team, dedicated cardiologist, interventionist, an imager, and surgeon focus on mitral valve pathology, irrespective of what you undergo with a transcatheter or whether it is through surgery or even medical therapy, you have a survival benefit. So, for example, this is a patient, let me go back. So this is a patient, 72 years old, and with severe mitral valve regurgitation, but very comorbid patient with recurrent melanoma, renal failure. This is a patient that, for example, was anatomically less favorable for TEER, but we managed this patient with a Tendyne. So it's about 2 years ago, and the patient doing well. This is another patient that relatively young patient, around 55 years old, a P2 prolapse, a simple pathology which you can address with different approaches. But this patient had severely reduced the right and left ventricle, but the perfect anatomy for transapical neocord replacement. So this patient, we decided to do a transapical neocord repair, and you have a perfect result. And then obviously in this patient, you avoid the use of heart-lung machine, arresting the heart. And what miraculously was that after 3 months, the ventricle right and left improved significantly. This is another patient, 82 years old, with a P2 prolapse. And in principle, also a patient that you could operate, but in that age, we are inclined to give a patient a therapy that will be more beneficial with regard to the quality of life. And this patient we treated actually with the MitraClip, which is, you can see, is actually a very good results. There is a subset of patients that I would say they are really patients for surgical treatment, and that is a patient with Barlow valve disease. There is a very clear distinction between Barlow syndrome, which is described in 1963, and Barlow valve, which is a bit of ill-defined phenotypical characterization of the Barlow valve, which is actually characterized by marked billowing of the leaflet, thickening excessive tissue, B-leaflet involvement, and various field degrees of calcification. What is important, and I just want to show you this image. So this is two patients with Barlow disease. If you look at the echo, you see a B-leaflet prolapse. But if you look intraoperatively, you see a different kind of pathology. On the right side, you see a significant multi-segmental prolapse of all the segments, and the left side, you see only a PT prolapse. And that is because of the fact that in Barlow disease, you have some sort of functional prolapse because of disjunction of the mitral annulus. And that is something that you cannot distinguish on the echo. And these patients are really should be referred to reference mitral valve surgeon to be operated. And I have two examples. For example, this is a patient of 44 years old. And most of these patients are also asymptomatic. And you have to understand, these patients, if you give these patients a durable repair, the patients have the same quality of life and life expectancy as general population. So this is a patient with a Barlow valve, and you see a B-leaflet prolapse. But if you look at the intraoperative image, you see actually only a P2 prolapse. This is very prominent. Now, that is a patient that you do a resection, and after resection, you will have a very nice repair of the mitral. This is actually the result on the echo. And that is also the difficulty in these kind of operations, because in the same kind of patients, you can have patients which have a significant leaflet prolapse, which you need to do a different techniques to repair the valve. I don't know, is something happening here? Yeah. I'm sorry, I cannot advance my slides. Yeah. Can you see my slides? Yeah. This is a second case. I just wanted to show you. There's also Barlow disease. There's a very the multi-segmental prolapse. The same thing, but if you look at the intraoperative image, this is a case that you have to do. You see it on the left side, multiple techniques you have to do to repair this kind of valve. And that is also my message. In Barlow disease, it's not something that you only decide based on the echo, whether you are going to be able to do it only with a ring or a P2 prolapse of a very complex repair, but that is something that you really see during the intraoperative assessment. And that's why this kind of valve should be referred to the mitral valve surgeon. And this is the valve, the same valve that the patient will repaired, and that is actually a result after 4 years. So in conclusion, I think the team approach is needed for mitral valve disease. You need to consider interventions, transcatheter surgery, minimal invasive endoscopic as a tool in the toolbox. Barlow disease is a very ill-defined heterogeneous phenotypical entity because of the fact that it's complex, and intraoperative assessment just guides you what to do. And for addressing those valves, you need so many tools and techniques. Experience and dedication is assessment, especially because those patients are referred in earlier stage. They are young, asymptomatic, and that's why you need to really consider referring those patients to a reference mitral valve surgeon. Thank you.
Thank you very much, Payman. We didn't expect anything less from somebody like you, whose your experience is so well known to us, and we've seen. Actually, I do remember, and I will never forget the Barlow disease, that the annulus was so dilated that we had, the first time I've seen it, to put 2 rings. There we extended the sizes up to 38, 40, and then he needed something like 60, so we put 2 rings together just to cover the story. I will never forget that a patient had come from England to do his repair. Since you are in a hurry to leave, we're going to have the questions at the end, but since you are in a hurry to leave, Dr. Economidis has a question for you.
Hello, excellent presentation. I would like to ask, in your opinion, who is the most appropriate patient for a tendine valve?
So that's a very good question. I think if you cannot do it with the mitral clip, so the anatomically non-suitable for mitral clip and not suitable for surgery, and most of these patients are patients with a functional mitral regurgitation. Additional to that, obviously, once you decide clinically you want to provide the patient probably for tendine, these patients get an anatomical assessment and full preoperative planning. And those patients who pass, and the most important step is whether if you put a tendine, you would induce outflow obstruction.
Okay, thank you.
Any other questions from our friends? So, Payman, thank you very much for your excellent presentation. Looking forward to see you soon in Athens. Have a good afternoon. Bye-bye.
Thank you so much.
Thank you.
Ο κύριος Οικονομίδης.
We carry on. We are with our next presenter. How to deal with residual TR now from Dr. Pizzis, and I'm sure he has a lot to tell us about that.
Dr. Pizzis, you hear us?
Just open your microphone. Your microphone, please.
Βλέπουμε δουλεύεις και τα Σάββατα. Σε αντίθεση προς το ρητό που λέει 6 μέρες εργά και ποιήσεις πάντα τα έργα σου, τη δε 7η Σάββατα Κυρίω το Θεό σου. Ούτε Σάββατο.
You have to unmute.
Am I still muted?
You are okay.
No, you're okay now.
You're okay.
We are here with my friend Asen Kelchev. Asen is a very great endoscopic cardiac surgeon from Sofia, and also Veselina Yantsova, who is another female cardiac surgeon of Asen's team. And we're doing some cases, endoscopic mitral cases, but obviously the topic of today's talk is tricuspid, so I'm going to start sharing my screen and sound. And I hope you are able to see my screen.
Yes, we are.
So the question, Strati, is how to treat recurrent TR in TEER and endoscopic tricuspid repair patients. And I have to say that, first of all, I would like to thank Kostas and the organizing committee of the Congress for the kind invitation. So this is the declaration of my interest, and as you can notice, Strati, this guy here is a very good friend of both of us, Patrick Perrier, and Patrick obviously is also the president of the Endoscopic Cardiac Surgeons Club. We were very, very lucky last September, to host the first meeting of the Endoscopic Cardiac Surgeons Club in Thessaloniki. This year's meeting is in Milano for anyone who is interested. So there is no question that in recent times the catheter has disrupted the show, and but we have the question whether the endoscope can fight back. And certainly endoscopic cardiac surgery is minimally invasive surgery, and Payman just delivered to us a nice lecture about this. More or less, the endoscopic tricuspid setup is the same with the mitral setup. So we do a periareolar approach, so for men or for women. And we usually use the third or the fourth intercostal space. In the old days, we used to use the fourth intercostal space. Now we have moved slightly upwards to the third intercostal space because I think we are better angled to the mitral and tricuspid annulus from the third intercostal space. And the setup, apart from the periareolar incision, is two ports, one 10-millimeter port for the endoscope and one 5-millimeter port, which is a utility port. Usually we use it for the Samsaker or for right-hand instruments. And this guy here is a robot, and this is called Solo, and Solo is a voice-controlled robot that we use it to hold the camera. So the surgeon doesn't have to leave the instruments from his hands, and he can voice control the robot, and the robot can move the camera up, down, left, right, in, out, whatever. So this is the full-blown, let's say, setup of a mitral and also tricuspid case. And this is the robot, and now we have also Bluetooth. Here I'm not wearing the Bluetooth. This is the first version of the robot. Now we have also Bluetooth voice controlled. So going back to the endoscopic tricuspid repair, I made here a list of the cases of the different types of procedures that we do. And I have to say that we do annuloplasty to most of the cases, but not all of the cases. Why? Because sometimes we don't have a dilated annulus. And if you don't have a dilated annulus, I can't see much point doing an annuloplasty. So annuloplasty is not for everyone, it's for most of the cases, but not for every case. And we have different types of leaflet repairs. We have closure of the anteroposterior commissure, as you can see in this photograph. We have an edge-to-edge between the anterior and posterior. We have a triple edge-to-edge, the Glover technique, which is anterior-posterior septal leaflet. We can do leaflet extensions with pericardial patches, as you can see here in this photograph. And also we can use the neocords the same way we use them for the mitrals. And we use obviously the loop technique with pre-measured cords, because this is the easiest way of doing it. And I'm going to show some clinical examples. This first patient is a 70-year-old man, previously operated with a Bjork-Siley mechanical prosthesis, and you can appreciate that he's got severe TR with a dilated annulus of 45 millimeters. This is the CT scan without dye. You can see the huge enlargement of the left atrium, but also the right atrium is enlarged, and also the right ventricle is enlarged. And as you can see, in redo tricuspid surgery, we don't dissect the heart. We open and block the right atrial wall with the pericardium without any dissection, intrapericardial dissection, and we use one cannula from the leg. We don't need two cannulae. We don't create an airlock because we have vacuum assist in the heart-lung machine. Here is the tricuspid. As you can see, there is some fibrosis in the anterior and posterior leaflet. So in this particular case, we elected to do a tricuspid valve to transform it to bicuspid by closing the anteroposterior commissure. And the next thing to do is to put the annular sutures, obviously, because the patient had some annular enlargement, and this is the ring. As you can see now, the valve has become a bicuspid valve, and this is a quite useful procedure in the cases that obviously there is fibrosis in the free edge of the anterior and posterior leaflet. And this is the result, and you can see we have downsized quite a lot the annulus, and there is no tricuspid rigors. Next case I'm going to demonstrate is this case with a P2 flail, as you can appreciate in the mitral valve, but also, and this is the flail P2, this is the broken cords, but also, and here we can measure the optimal length of the cords preoperatively on echo. This is the tricuspid annulus, which is also enlarged, 42 if I manage to see. And there is also some tethering of the tricuspid leaflets due to right ventricular dilation. So in this case, apart from the tricuspid annulus, which is enlarged, we have to address the tethering of the leaflets. Here we dissect the SVC. This is the SVC. This is the aorta, which is cross-clamped. This is a left atriotomy, right atrium, left atrium. And first of all, we deal with the issue in the mitral. And here you can see the loop technique in the P2 area. So we place 4 or 5 loops, 4 I think in this particular case, in the mitral to fix the P2. And this is the ring in the tricuspid with the core knot device. This is the single cannula that comes from the femoral vein, foramen ovale. This is the osmium secundum. But after that, after we have placed the annuloplasty ring, we place a triple edged wedge in this particular patient because if you remember, there was tethering of all the tricuspid leaflets due to right ventricular dilation, and therefore we elected to do something more. We thought that an annuloplasty on its own won't be enough. So for that reason, we put a Teflon buttressed, horizontal buttressed suture at the free edge, the middle of the free edge of each of the 3 tricuspid leaflets. So this anterior, posterior, septal, and finally, now we are passing through the septal, and finally, all these 6 bits of cords, we are going to get them through the same core knot and secure them with a titanium clip with the same core knot. So just one core knot. This suture, as you can appreciate, it is a PTFE suture that we use for leaflet repairs. Leaflet repairs, we try to use PTFE sutures, not Crollen. So this is the single core knot. And that's it. This is a triple edged wedge repair together with annuloplasty. So I think this is really a procedure that in a setting like that is future-proof. You can get small leaks, but the leaks will be tiny, less than 1+. So this is the closure of the left atriotomy. This is the closure of the right atriotomy for the tricuspid in this particular case. And following that, we're going to check, obviously, the echo to check of the outcome. Quite often, if we are not happy with the tricuspid annuloplasty, we go back and we put an edge-to-edge repair, either a double-edged wedge. Double-edged wedge usually is between left and right, or a triple-edged wedge. And as you can see, there is a small leak in the mitral, 1+, but there is a tiny leak of the tricuspid. So overall, a very good result. And I'm going to move to the next case, which is an endocarditis patient, 60-year-old man, class 2 symptoms due to endocarditis of the tricuspid from streptococcus. And you can see huge vegetations, huge TR, lots of holes, lots of jets, a tricuspid annulus of 41 millimeter, dilated as well. And these are the vegetations, obviously, and the holes in the tricuspid leaflets. So obviously, this is a case that we have to do a lot more work. So initially, we started on a beating heart. Tricuspid, as we said, it can be operated on the beating heart, but if you have to do a lot of work in the leaflet, then you'd rather arrest the heart. So here we have elected to arrest the heart, put the cross clamp, the heart now is stopped. And now we have started with the debridement. We have to debride quite a lot of tissue from the anterior leaflet and the posterior leaflet. The septal leaflet is unaffected from the endocarditis. And this is something that is very good because at least we have one good leaflet. So in this particular case, we thought of debriding a lot of the vegetations and the infected tissue, and then to use a large patch to fix the leaflet issue that we're going to create, obviously, because we're going to be left with a huge hole in the tricuspid, and somehow we have to fix this hole. So we have elected to create a bicuspid valve instead of tricuspid. So instead of...
If we can speed up a little bit, because we have only 1 minute left.
1 minute, yes, more than enough, cost. Yes, absolutely. So as you can see now, we are fixing this pericardial patch, and then obviously we have a patch which is unsupported by cords, so we have to use also neocords in order to support these parts. So we measure the optimal length of these neocords. Usually it is something like 20, 22, something like that. But we have to measure with the measurement tool that we have, which is this one. So we know exactly this length, and then we're going to anchor the cords in the tip of the anterior papillary muscle of the tricuspid, and then the free edges, obviously, we're going to suture them on the free edge of the pericardium. And I'm going to show the conclusions as soon as this video is ended, somewhere here. Here is the annuloplasty ring. There was also dilation of the annulus here, so we used a ring as well, and the cord knot device to secure the annuloplasty sutures.
So what is the secret to reduce the residual or recurrent TR in these cases?
Well, I think it is the edge-to-edge approach, and I quite agree with you that the edge-to-edge approach is a very useful approach. Obviously, in surgery, we do it in a different way. You can appreciate an excellent result in this particular case. I mean, you can appreciate that in surgery, we see exactly the areas of fibrosis, and we see exactly where we're going to place the sutures. And sometimes we close the whole conusure, sometimes we do just a simple double edge-to-edge, anterior-posterior. Sometimes we go triple with anterior-posterior septal leaflet. But I think we should be versatile, and we should be guided by the pathological findings that we see greatly with the endoscope rather than with the echo images. So I think this is what I think is the secret. I have to say still that surgery is different than transcatheter approaches, but more or less we are doing the same job with different imaging techniques and imaging tools. Thank you very much for your attention.
Thank you very much for the excellent presentation. And for the sake of time, we have to move on to the next presentation. I think Professor Aguirre.
Thank you very much, Adoni.
And
Regards
Dr.
to Sofia.
Avramidis is also linked. So, Dr. Avramidis, could you present the next case, and Professor Aguirre, the one after after Dr. Panos?
Good afternoon, everyone. Hello from Nicosia in Cyprus. Now, first, I would like to thank Dr. Sparias and the organizing committee for this wonderful meeting. And I invite Dr. Panos to speak. He will give us his extensive experience on surgery on the mitral and tricuspid valves. Dr. Panos.
Dear colleagues, thank you for your invitation and for being here this warm Saturday afternoon. As is a cardiological essentially meeting, I will try to be more clinical than surgical. And I have asked the question of comparing the sternotomy towards the thoracoscopic approach, which is my most favorite since 15 years, because now is 15 years we are practicing this kind of surgery here in Greece. This is are my disclosures. And essentially, the surgical indication for mitral and tricuspid valve regurgitation are the same as in the open surgery, and this is now in the guidelines of the American Heart Association. The sternotomy is an optimal exposure, gives fast operation, surgery is effective. We know it since long time, well established, and through it we can treat almost all the pathologies of the heart. So why changing a winning team? Because it's better to always change in order to reinvent the techniques. The ideal surgery would be the one that provides less trauma, shorter hospital stay, earlier back to activities, less transfusions, less infections, and an excellent aesthetic result. and with no compromise to the surgical result, which is the most essential. A good technique has to be at the same time effective, simple, reproducible, very basic, safe, giving good results, and be implemented in the minimally invasive valve surgery. Since 25 years that we are in this method between the colleagues, the thoracoscopy is established as a new standard for mitral valve surgery. But the surgical community is far from the learning curve with these minimally invasive techniques. The proponents are arguing its utility for treating even the most complex mitral valve disease and tricuspid, as Dr. Pizzi showed before, without any additional risk of the potential complication, despite the prolonged operation times. This was the intuitive part. Now we have to prove if these methods are nice also and better from the sternotomy. We have selected some studies till 2010 because before all the instruments and the techniques were different and we cannot compare them accurately. So with the total patients in the sternotomy part of around 6,500 and the same patients in the thoracoscopic group through 10 studies. This is the early mortality. As you can see, there is any difference. And without any heterogeneity of the population we have. Here is the odds ratio, and we can see that there is a very well distributed homogeneity of the studies. So the midterm mortality now, at 3 years follow-up, is in favor of minimally invasive surgery. And the opposite, the midterm reoperation rate, there is any difference, which is interesting. The complication now, stroke rate, the same. Bleeding rate, the same as in the sternotomy. Prolonged ventilation time, the same. New renal failures is in favor of thoracoscopy. AFib presentation favors thoracoscopy. The blood transfusion clearly less in the thoracoscopy group, and the wound infection also in favor of thoracoscopy. Some time-related complications which are have the reputation of being the drawback of the thoracoscopy. The cross-clamp time, only 20 minutes more in this thoracoscopic group. Cardiopulmonary bypass time, also 1 hour, almost 1 hour more in thoracoscopy. Total operative times, as we can wait, 37 minutes. Now, ventilation time, there is no difference, and the ICU stay is less in the thoracoscopic group, the hospital stay also less, and the total cost, this is for United States, also less in the thoracoscopy group. So we can say that thoracoscopy at least is not inferior to sternotomy. What is in our experience in Greece now? We have to adapt the techniques and standardize the techniques since the beginning, and actually we are more with triangular, quadrangular resections and techniques which were developed for the minimally invasive setting, which is the haircut, artificial chordae, loops technique, as we saw before with Dr. Pizzi, and a mix of the above. Here are our collective of patients with almost 1,200 patients with a mix of mitral and tricuspid valve repairs, with the aortic clamping times in the beginning much higher, and the second period, the aortic clamp times are almost compatible with the open sternotomy. And which is very interesting is that the conversion rate is very low, the bleeding is very low, the transfusion rate is the same as in the meta-analysis we had shown before, and the strokes also very low. This is also the trend in the in all the newer studies. The actuarial survival at 10 years, 87%, and the freedom from reoperation, which is very interesting, 98%. And this, in our team, all the patients are suitable for endoscopic mitral valve repair, which made this approach a routine approach. Finally, this is an interesting method, which is, I think, better than the sternotomy in the redos, in the reoperation, where we have decreased mortality, less transfusion, less pain, are possible in the artery, possible on the beating heart for mitral prosthesis paravalvular leaks without arrest the heart, and the isolated tricuspid valve repair, as we saw before. These are some extreme patients which are benefiting from this kind of surgery. We do not have to pass through the sternum, but only through minimally access points. Or patients with mammal prosthesis for different reasons, which can be excised and again implanted again in the same place and at the same time. As a conclusion, the sternotomy still remains the essential approach for the cardiac surgery, but the thoracoscopic approach is feasible in the everyday surgery. The patients do not want anymore the sternotomy, and this is the major atout of this method for the moment. It gives excellent and reproducible surgical results. The surgical mortality is the same as in the sternotomy, and we have a less mid-term mortality in the thoracoscopic group. If this trend persists in the mid to longer term, this will be a major atout for the thoracoscopic surgery. The transfusion rate is smaller, already proved, and the hospital and ICU stay also proved shorter in the thoracoscopic group. The cosmetic result is superior, no any doubt, and the learning curve remains steep. But this method remains our preferred method for mitral and tricuspid valve surgery. Thank you very much.
Dr. Panos, thank you very much for this very interesting talk. Now, in interventional cardiology, when a new technique comes out, it takes off rapidly. I'm just wondering why this method, which you have personally convinced me that it's actually a very useful weapon to have for a cardiac surgeon, why has it not taken off in the same way? Why have not cardiac surgeons generally adopted this? Are they more conservative than interventional cardiologists? What is your opinion?
A very good question. Thank you for answering it. I think this is the problem is the steep learning curve at the base. Then many surgeons were not convinced at the beginning that this surgery could be overdraw the sternotomy or even treat some of the most acute pathologies of the mitral valve and tricuspid valve repair. But I think with the time and and many studies that are out already, they will be convinced. I'm sure in this room there are many that were not convinced at the beginning, and now they're completely convinced. Rati?
I think I belong to Aris's group. I'm convinced that patients need smaller incisions. They're asking for thoracoscopic approach, so I totally agree with you. But also I agree with you, and I want to be, in these conferences, we have to be honest. The first 2-3 years of each and everybody, anybody who starts thoracoscopic approach, the first 2-3 years are disheartening, are depressing. So we have to be able to pass these 2-3 years and start in having better results. So that answers The other thing is that even the patients, I remember I had the slides. 4 years ago, we had 2 patients the night before, and we both offered them the thoracoscopic and the sternotomy approach. The patient who preferred the sternotomy was chief neurosurgeon. So, and yes, and I want to be with the standard. So next morning, we had both on the floor, and we had side to side, and we took a picture of both of them. One had a small incision, and the other had the sternotomy. I have that picture if somebody wants to see it. And both were smiling, both were okay. So the neurosurgeon preferred the incision. So both, it's obvious. The cardiac surgery goes to smaller incisions, to catheter, no incisions at all. So there is no question that the thoracoscopic approach is the way to go. So, and the other thing, closing, because the time is a little bit stretching, is that you showed that it's less expensive. As you know, though, internationally, given the technology, the hospital charges more to the patient who is going through the thoracoscopic versus the, and I don't know why, probably a couple of instruments, a couple of this, a couple of that. The patient who is going to come to IGEA and be operated thoracoscopically is a little bit more expensive, and this is because of the technology. Yes?
So as somebody who learned cardiac surgery in the early 1980s with Dr. Cooley, there was no minimally invasive surgery. I still do sternotomies, but all my mid-level and younger faculty do minimally invasive surgery. And all my fellows are learning minimally invasive surgery, and they will all do it, and they're learning their learning curve during their residency. So I agree with everybody, all my patients want little incisions. Now that being said, I would put out one word of caution. This midterm survival has nothing to do with the incision. It has to do with the patients that you choose.
Exactly.
Once you survive your procedure, your longer-term survival is your intrinsic risk. Once you survive, once you subtract out the operative. So really, these are non-randomized. All the randomized studies have shown no difference. So be careful about putting out this midterm. That's only in non-randomized patients. And that's because the healthier patients, particularly in younger surgeons groups, were chosen for minimally invasive. It's really not the incision, it's the patient that makes you live longer.
Yeah, I agree with
is
you.
Exactly the same once you survive.
Thank you, Dr. Reardon. Really very serious remark. Aris, thank you very much because the time is a little bit pressing. Thank you for your enlightening presentation. We'll give, is Dr. Angeli with us, who is going to present the next speaker. Thank you, Dr. Angeli.
Again. We have realized that the multiple less invasive non-surgical percutaneous treatment options are under evaluation. So Dr. Dimitriadis is going to present new data concerning orthotopic or heterotopic TTVR. When the tricuspid TER is not an option, Dr. Dimitriadis.
Introducing words and for the invitation. I have been told that I have only 5 minutes, so I have to skip some slides, but I will do my best. So, when the TEER is not an option, what can we do as interventional cardiologists? And all of us know that the tricuspid valve is actually a very complex valve and a very complex anatomy. That's why the options we have are not a lot of them and a really challenging situation. So I have to focus on this part actually because I want to say that we don't have a comparison between surgical and interventional method, but we try to solve the problem. And what I mean actually is that this is data from America. 1.6 million patients in America, they have moderate or severe tricuspid regurgitation, but only 0.6% are treated surgically. So that means the 99.4% in America, at least, are still undertreated according to this data and according to the tricuspid regurgitation. And I have to mention that the majority of the tricuspid regurgitation is a secondary. And this is important because in the guidelines, of course, the primary tricuspid regurgitation has the surgical option as the first choice, but in the secondary tricuspid regurgitation, we are still there as cardiologists, as interventional cardiologists. The surgical option remains still the first option for that patient, especially if they have to get operated due to another problem on the heart. But if their are unsurgical inoperated patients, then we remain there as a 2B recommendation according to the guidelines. And what we have as options in the interventional cardiology? Of course, we have the leaflet repair with Pascal or clip option device. We have also annulus repair option with cardioband or trial line. And we have surgical chordal repair. This is an experimental status, actually. But we have also valves for the tricuspid regurgitation. We have the orthotopic valves, the first 3 valves, the gate one, the evoke, and the lux valve. And we have also the heterotopic valves, the sapien, the sapien, the trick valve, and the trisento. And to do the right choice, we have to take some aspects into consideration. First of all, the coaptation gap. So the bigger the gap it is, the most unsuccessful is actually the TEER option, also the annuloplasty. That's why we go to the orthotopic valve implantation, and if we have a huge gap, and especially a big dilatation of the diameter of the tricuspid valve, then we have to choose a caval device, a trisento or a trick valve, because in such cases, we don't matter anymore of the gap, we don't matter anymore of the diameter of the tricuspid valve, we just put the valve in the vena cava inferior and vena cava superior, and we try to solve the problem, or at least to minimize the problem. And this is a good summary of the recommendation according to the right choice between the different options we have in interventional cardiology. I will focus only on the orthotopic valve replacement and heterotopic valve replacement, and especially in 3 important aspects. First of all, the gap and the diameter, the gap of the leaflets and the diameter of the annulus. As a second very important point is the presence of a pacemaker lead. Both options, orthotopic and heterotopic valve replacement, are suitable if we have a pacemaker lead. But I have to say, from my small experience also with orthotopic valve replacements, only 3 evoke implantation in the time I was in Mainz University, it's a really challenging method, and the lead leads to a not optimal, suboptimal, let's say, implantation, especially in the posterior part of the evoke valve. That means in the presence of a pacemaker lead, the heterotopic valve replacement is much better and easier to perform. Another very important issue is the RV dysfunction. So if we have RV dysfunction, both methods are possible, but in the presence of a very severe RV dysfunction, the heterotopic valve replacement, it's much more suitable. Why that? Because we use the right atrium as a reservoir. If we seal directly a huge or really massive regurgitation of the tricuspid valve, especially if we have dysfunction of the right ventricle, the burden of the right ventricle becomes really huge in a very small time. That leads to a very negative effect, especially due to the hemodynamic changes in a very short period. But if we use still the reservoir of the right atrium, we don't burden anymore the right ventricle, or not at least such important. So that means we minimize the problem, we minimize the regurgitation from the vena cava superior and inferior. The problem remains there in the tricuspid level. The burden of the right ventricle is not so high, and that leads, especially in patients with a very severe right ventricle dysfunction, in better results. Here, a comparison between the orthotopic and the heterotopic valves, at least the majority of them. I will focus only on the procedural success and the complication. As we can see, all of them had a very high procedural success, and 0% embolization or malposition almost, except of the Edwards-Sapien valve. We have to say this is not a valve dedicated for this purpose. It's an actually aortic valve device that we used in the very former time for tricuspid regurgitation cases. The mortality was really low in all of these cases. I will skip this evoke tricuspid valve implantation in order to gain a little bit of time, And I will focus on the most important study for the EVOQUE valve. This is, in my opinion, the most promising valve according to the orthotopic implantation. The TRISCEND study, a single-arm study with 56 patients and follow-up of at least 30 days. I will not analyze the whole baseline criteria, but I will focus on the pacemaker lead. 1/3 of the patients had a pacemaker lead. The results, really good. The severity of the regurgitation minimized almost in the 80% of the patients. We had only mild or moderate tricuspid regurgitation. And regarding these results, we have to say the new classification became really better. Almost 77% of the patients had NUHA 1 or 2 dyspnea, and a very good development of the 6-minute walking distance. The complication level really low, except of the severe bleeding. Almost 22% of the patients had a severe bleeding. Don't forget that we have to do with a 28 French system. And the trick valve, it's actually a very simple method, putting one valve in the vena cava superior and one other valve in the vena cava inferior. So if we accept some limits according to the anatomy of the patient, it's a very gentle method. The most important study for that valve is the TRICUS Euro study, showing that we have 97% technical success, 0% mortality after 6 months, and the results according to the functional status of this valve and the quality of life of these patients was really good. According to the baseline characteristics, again, I focus on the pacemaker presence. We had also in that cohort 22.8% of patients with pacemaker. That means every 4th patient had a pacemaker lead. That shows that also in that population, this method is really possible, suitable. The results according to the dyspnea, also amazing. Almost 80% of the patients had, after 6 months, NUHA 1 till 2 status. And the, sorry for that, and the complication level also very low, 0% embolization in that collective, 2.8% in hospital mortality, showing that this procedure is also suitable for this high-risk collective. I will skip the video of the implantation we performed in Cyprus in order to gain some time. So thank you very much for your attention.
Thank you. Excellent and very comprehensive presentation. I would like to ask you a short question. We have realized that these patients have liver congestion and kidney congestion. Do you think that the anesthetic management of a patient with torrential TR during the procedure could be challenging?
Of course, these patients are from the beginning very challenging because they are high-risk patients. So according to our anesthesiologists, they have to take care, they have to consider the whole situation and to plan the whole situation from the beginning, but it's possible. Also from my small personal experience, 11 procedures in Frankfurt and 4 in Cyprus, I have to say the anesthesiologic process was not a problem.
Okay.
Okay, so you want to join us here?
Of course.
Because we're going to, again, quick video presentation of one case. And I would like to also ask Dr. Sebata, who's with us, to join us. And Dr. Stafogiannis will present the case. Quick clinical summary. And then we'll have Dr. Papadopoulos and Dr. Iakovou for the comments, and then we saw the video case.
Thank you. So this is a 70-year-old male, BMI within normal limits. No. I think it's the wrong PowerPoint. Should be 11.
Okay. Kostas, do you have your own presentation? No, I mean Papadopoulos. Dr. Papadopoulos?
Hi,
No.
Dr. I have it, but the one I have has a low frame rate of the videos, but I can share it if you want. Dr. Spargas, can you hear me?
Yes, we can hear you.
Do you want me to share the video and Dr. Stathogiannis?
Hi, Dr. Papadopoulos. I think we're okay now.
Okay.
Thanks for that. I think we're going to have the slides in a second.
Do you want me to comment during the presentation or right after finishing?
I'll just show the first TTE, and then it's going to be only you.
You can invite us, both of us, to make our comments. Okay, thank you.
All right, great. So this is a 79-year-old female, BMI of 22. She's been having dizzy spells and dyspnea during rest, and class function of 4. Just to get a perspective, almost 7 years ago, she was diagnosed with a right breast cancer. So she underwent chemo, radio, and mastectomy in 2016. At that time, 2016, she was initially diagnosed with a dilated cardiomyopathy and an EF of 35% with some diffuse hypokinesis. And this EF of 35% gradually started to decrease. Other pertinent history would be chronic kidney disease, atrial fibrillation, first diagnosed as paroxysmal episodes in 2004, but eventually she had to undergo pacemaker implantation 5 years ago. So very basic focused images. This is a zoom image, apical for the mitral valve. I guess you can appreciate it's almost like a moderate mitral regurgitation. And this is the tricuspid valve, dilated RV and RA, huge torrential TR. And there's no color here, so you can see there's almost a gap in the tricuspid valve annulus. So there was this first question. I'm not sure if we want to discuss. It's just the very initial part. So what we would do first would treat the mitral valve or the tricuspid valve. Just medication. If we decide to treat, would it be surgery or another transcatheter procedure? Or maybe just put a CRT initially. Okay, so obviously we did a mitral valve tear, and Dr. Papadopoulos, if you want to jump in.
Before going to the TE, first of all, I would like to thank the Dr. Spargas and the whole organizing committee for inviting me. It's too bad that I'm not with you. I've been to the EuroEcho conference since yesterday, but I hope I see you soon. So from transthoracic echo, we can clearly see that there is a significant MR and torrential tricuspid regurgitation. A severely compromised left ventricle, maybe due to cardiotoxicity, and maybe the leaflets of the tricuspid valve, there's a gap due to the annulus dilatation, and maybe a kind of restriction of the leaflets due to the radiation. So from this four-chamber view of TE, we can see that there is a significant functional mitral regurgitation and depressed ejection fraction of the left ventricle. As you said, obviously, you proceeded to managing the mitral valve first, and this is the correct thing to do. As we all know, when we have a combined mitral and tricuspid regurgitation, we have first to deal with the mitral. So we can see here in this commissional view, one clip at the central part of mitral valve towards kind of lateral, and a mild remaining mitral regurgitation, a very good result. This is an fast view of the 3D with color for the perpendicularity maybe and the bridging between the anterior and posterior leaflet. Very nice result as well. A 3D and fast view of the valve. We have minimized the gains, I guess, for showing the device between the A2 and P2 scallops, and a photorealistic view of this mild remaining MR. Overall, a very nice result of this mitral tear. And an iatrogenic ASD. Dr. Stafilianis, if you can show us again the previous video. With the ASD. Yes, this one, if you, the next, if you can leave it for a moment to play, you will see that there's bidirectional shunt of this iatrogenic defect of the setting. And you see here that there's flow from the right side to the left side. This is due to the torrential tricuspid regurgitation, and this is an issue when we have patients with severe TR when we manage the mitral regurgitation. Okay. Okay, this is the transthoracic echo after post-implantation. Very nice result of the MR. And dilatation of the right cavities with torrential. You can see here biplane views of the TR. There is no coaptation at all. It's a free tricuspid regurgitation. You cannot even measure the regurgitant orifice area in this case. It looks like more than 2 centimeters square, so it's torrential. And we should check the contractility of the right ventricle. With TDI, the systolic component looks like it is a 7. And as I can see, you did a stress echo with dobutamine in order to show that there is inotropic response of the right ventricle, and the GLS from the beginning, it was -6 of the free wall, and it went up to -19, which is a very good response, to be honest. This is an off-label technique. Okay, we don't use stress echo for the right ventricle, but if you have to give an answer about the contractility of this chamber, then you have nothing else to do. And again, views of the tricuspid valve with free flow from the right ventricle to the atrium. And this 3D and-fast view of the tricuspid valve, you can see that there is a huge gap between the septal and the anterior leaflet. On top, at 12 hours, you have the anterior leaflet, and towards the septum, you have the septal. This is huge TR again, demonstrated by 3D. Right heart catheterization showing huge V waves in the right ventricle, severe TR, and increased pulmonary artery pressures, wedge pressures as well, a low stroke volume of the patient. Cardiac CT for annulus assessment looks like a very huge valve, dimensions of 57 to 47, and an area of 20 centimeters square. Just remember that the normal annulus area for the tricuspid valve is around 10. So it is double the normal size, this valve. And we can also see measurements of the superior and inferior vena cava, 48 and 36 millimeters, respectively.
So, Kostas, before you continue, just to fill up some gaps in the story, the mitral valve was done last summer with 1 Pascal ACE device and a good result, and the patient who did initially felt better. So for approximately 3 months, we had very good news. and we're happy. And because of her age and all the other comorbidities, we're not thinking of directly going to treat the tricuspid valve. But then after 3 months, the patient came back with more symptoms, and we're at square zero again, where she was before the mitral valve correction, and needed more diuretics. And then we started thinking about the tricuspid valve. That's why we did this stress echo to check for the reserves in contractility of the right ventricle, and also the CT scan to check the dimension. So what would be, after all this information, your suggestion for treatment? This is a question for both you, Kostas, and Dr. Iakovou, who is kindly asked to take the podium.
Can I make a first comment? As an image.
Thank you, Kostas, and thank you for the invitation. This is interesting. So I have 15 minutes to talk about strategy, Kostas. 15 or 20?
How many? 20 minutes. Okay.
I just make it in three. So actually, because I have, most of my presentation has been overlapped. So can I have my presentation, please? Yeah. So yeah. So this is a 79-year-old female. So just to remind you, because we cardiologists and maybe more than cardiac surgeons tend to forget the history, and so the large MR, torrential TR. So I have maybe another proposition. Maybe some of these patients need to be treated at the same time, and we know we have learned the lessons from surgical approach that a lot of these patients, approximately 40 to 50%, they have tricuspid annular dilatation, patients treated with severe MR. And this is the annular dilatation carries prognostically important information, is a predictor of later TR. So there is a logic in trying to take together two birds at once. So that's why we have 2A class recommendation in ESC and ACC guidelines to treat the annular dilatation beyond the given size. So initially, mitral clip was used in these procedures after treating the mitral valve to treat the tricuspid. As you can see here, one case. Yes, I'll go very, very quickly in less than 5 minutes. So we have a tric valve, the TRAMI, and the tri-valve registry. The sole predictor of survival is the procedural success, which is moderate at 72% in this case, and the greater coaptation depth is independent predictor of failed device. So we need to pay attention to the coaptation gap and the TR-Z. So I'm coming back to the patients, who is a huge TR. The decision was made, as Kostas said, to treat first the mitral valve, which I think has a very good result with mild to moderate residual MR. So this is another issue that Kostas Papadopoulos before discussed. We have a bidirectional shunt, maybe right to left, and this is something that is not benign. Sometimes we need to have a strategy in dealing with this situation, as in this case that we have experienced recently in our hospital. We had to place an ambulator when the patient was with pulmonary hypertension, had a drop of pressure and desaturated. So we need to have this in strategy as well. Patient, of course, the current patient treated in EIA hospital had good hemodynamics in terms of pulmonary hypertension and vascular resistance, but the output is very low. And still you have the problem of TR. The heart team needs to find the point, the sweet spot to treat this patient. Is the treatment of this patient futile or not? And we have this algorithm. So if the gap is high, more than 8.5, and you have moderate to severe tethering of the tricuspid valve, maybe TTVR might be the answer. So we are dealing with 48% mortality, which is very big, of course. And maybe we need to investigate if it's futile or not. That's why I think very correctly they did the stress test and they find the systolic reserve, as you can see here. So they need not abandon this case, but maybe if you see in the TOE, maybe the echocardiographers would tell us that maybe there are some degenerative changes as well in this case. So we are dealing with a patient that shouldn't be treated with TEER, but maybe there are new devices right now like valves or heterotopic valves like the trick valve or the Tricendo. We always have this algorithm in mind. If it's technical, feasibly the case with the valve, we need to investigate the CT and, of course, to investigate the etiologic mechanism, treat accordingly. So if it's secondary TR, the orthotopic replacement in this situation might be an answer. Of course, you see that the valve is huge. And also, they're very large, also the dimensions of the superior vena cava and inferior vena cava. So maybe, according to IFU, I wouldn't go and place a trick valve, maybe a Tricendo if we didn't have the systolic reserve. But since it's some viability, I would go with a TTVR, but maybe, I don't know, we can do it in Greece. Probably not, but maybe an Evoque 52, which is in an active clinical US trial, would be a good bet with, of course, with the optimization of the pharmacological therapy and the plus-minus CRT. Thank you very much.
So, Yannis, what would your suggestion, your strategy will be? What is your therapy you are proposing here, finally?
As I said, I think since there is, we see the increase in systolic reserve after stress test, I think it's not futile to treat this valve. I wouldn't do a Tricendo, maybe a custom-made heterotopic valve. The trick valve, I think it's outside the IFU. Maybe if we had if we will talk this kind of case, maybe next year or
great.
Maybe we'll add a Evoque or whatever.
Okay, great. So let's start the video and. Obviously, the decision was to proceed with a trick valve, and the reason was that the gap was huge, 2 centimeters. It was unmeasurable, huge, so there was no option for TEER. And secondly, the diameter of the annulus, of the tricuspid annulus, was 57, so there's no experimental tricuspid valve for this annulus. So the only option for now, but also for the future, would be heterotopic tricuspid valve implantation. So we are very lucky to have Dr. Sabato with us with a huge experience, and I would like to ask him to comment on the video and the procedure anytime he wants. So please go ahead.
Sure, it will be a pleasure. So if they just let us know a bit more about the patient and what they've done yet, I'll be pleased to comment.
So as you can see, firstly, the hemodynamics there, the V wave in the right atrium was at the baseline. We get the measurements there, but the baseline was 27. So this I think is something important to know before, that we have a V wave in the right atrium that is at least 25, right?
Yeah, I mean, you need a proper V wave for the valve to function properly after the implant. I mean, we, in the last year, we've been performing this procedure in patients with V wave a bit lower, maybe about 20, but I mean, you should have a proper V wave. If not, the V wave, sorry, the IVC valve, it's not gonna function properly. And also another thing we usually commend to the teams that perform these procedures, just to avoid increasing diuretic therapy before the procedure, just in the opposite side of TER procedures, that you need to reduce the gap before going in. Mm-hmm. In these patients, you don't really need that. It's better to go with the RA volume full and good V waves, and not to stop diuretics also immediately after the procedure. It's better just to leave the patient at least for 10 days or 2 weeks before going down with the diuretics. I mean, just to make sure that the valves functions well.
Right, so here is the procedure, venous access, and apparently we've checked all the CT scan measurements, and the patient was approved for a TWIG valve. The sizes for the IVC and the SVC were within the sizing charts of the upper and the lower valves. We start with prog lights for closure of the vein, pre-closure. And I think you've done a few cases, so you can tell us your experience.
Yes, actually it's a very elegant method, very easily, especially for operators who already perform TAVI. So to say, you have to put two Medtronic, two evolute over there in the vena cava superior and vena cava inferior. We don't use prog light in our patients, and indeed we put a lot of attention on the V wave. We routinely gave them 1 liter in prior in order to have a high V level. V wave level, in order to be sure that the new valves will have good function and will open the leaflets. That's the main point, the key point, to open the leaflets, not to have implanted new valve there. We cannot open the leaflets. But as I see this standard, perform a standard procedure here, and the only difference till now with us is the prog light system.
And as you can see here, the pacemaker leads, 2 of them. But as you told us earlier in your presentation, this is not an impedance, any problem to use this therapy.
Indeed, you trapped actually the leads between the new implanted valve and the vena cava wall. That's why I leave this method actually.
Can I ask, does the right to left shunt influences the success of the procedure?
The right to left shunt here was small and never caused any problem with desaturation in this patient. And it was mostly related to the massive torrential tricuspid regurgitation. Mm-hmm. So at this point, we're targeting the tricuspid regurgitation.
I mean, if it lowers the pressure, does it affect the function of the valves in the K-valve position?
Yes, but the V wave here was satisfactory, so that's why we decided to proceed. And it wasn't a big shunt.
Okay. You can have some problems if you've got a big ASD and a big shunt and you implant these heterothopic valves, just because you can increase the right to left shunting. I mean, if the patient has got high left pressures, the shunting may not be that big. If you've got any doubts, you can close the ASD, or even you can do it afterwards, because you can cross the valve with any system you usually use for closing atrial septal defects. So, I mean, if you think it's not going to be a problem, you just can wait and see, and you can do it afterwards. I don't think that should be a contraindication for the procedure.
So you like to come closer to the procedure and tell us about your tips and tricks about the positioning of the SVC valve here and the IVC valve later.
Well, I mean, obviously, like all of these procedures, you've got to review the CT scan first. One of the important measures you need to know is the length between the innominate vein and the SVC to RA junction, just to check there's enough room, enough distance to deploy the valve. The most common landmark in the fluoro is just to start releasing the valve in the collarbone, more or less. If you've got a very short distance between the innominate vein and the right atrium and you are a bit concerned about occluding that vein, we've done it sometimes. I've got a leaf case, a recorded case that I can present afterwards. You can get access through the left jugular vein and you can do some injections just to make sure.
We just did that. We have a pigtail there.
Yeah.
So we're doing injections while releasing and expanding to make sure that we keep that open.
Also.
Because the skirt of this valve goes about in the middle.
Sure.
Of the frame.
And also the radial force of the SVC valve is not that huge. You can leave the pigtail until it's completely deployed and just release the pigtail after all the valve is released, so that should not be a problem, and you can just recapture and release the valve again if you're not happy with the height of the valve. The other thing, another thing you must keep an eye on is just the upper crown of the SVC. Sometimes the jugular vein or the brachiocephalic vein is not that large, and so the upper crown does not enlarge that much or is not wide enough. So you must keep an eye when you release the system, the nose of the system, not to bring everything back. But I mean, you've presented before the Trichocerebral registry. I think this is a very, very safe implantation in terms of embolization. If you just keep an eye on the belly of the valve, the belly is the part of the valve that prevents embolization distally, and you just need to know that the belly is at least half of the belly is above the right pulmonary artery. So the right pulmonary artery is the one that prevents the valve going down. So
maybe comment here. Actually, routinely we put a pigtail also in the pulmonary vein on the right side to be sure that the belly is above this part, above the pulmonary artery, in order to be sure that we don't have any risk of embolization. Did you make it that with CT prior, or how do you?
No, the proctor we had, we discussed this, and he was very comfortable with the imaging from this pigtail in the nominal vein, so we just proceeded with that. So the upper valve is now released, the cone is retracted back carefully, and as you've seen, there is good flow in the innominate vein, so we didn't obstruct that with the skirt of this valve, which is very important. And on the other side, you can see the echo, although I understand that you can't really get a lot of information about the function of the upper valve with echo, right?
It's difficult to see the SVC valve in the echo. We started doing transesophageal echo for these procedures, and just after 3 or 4 procedures we just do transthoracic because it's easier. You don't need GA, general anesthesia, for the patient. And I think for the SVC deployment you must rely mainly on the fluoro. And as you said, what you really need to know is where the right pulmonary artery is, and that's why if you've got concerns about the innominate vein, I prefer just to keep a catheter in the right pulmonary vein and put another one in the innominate vein, just to make sure that everything is being deployed in place. If you've got very, very good fluoro references in terms of vertebra or some residual material from a previous surgery or whatever, you may avoid that. But I prefer just to keep a catheter in the right pulmonary artery, well, not all the procedure, but for all the SVC.
Superior part, yeah.
So now we're with a pigtail in the hepatic vein, and this is the vein we don't want to close and obstruct with the IVC valve. And If we can put it fast forward, please.
This IVC valve is the one that it's more difficult to decide the height of the implantation only based on the fluoro. I think here is where the echo can help you more in terms of deciding just to go a bit higher or a bit lower, because the skirt of the IVC valve is much shorter, trying to avoid occluding the hepatic veins, and you don't want the valve too in and just have a residual leak, or too low. So I think here's where the echo can help. And I think probably with just suprahepatic echo, it's usually because these patients usually have a large lever, you've got a good acoustic window, and it's usually enough.
So I think you can see in fluoroscopy here the skirted part of this valve. There is a gap between that skirted part and the lower part. Am I right?
Yeah, yeah. I mean, there's a bit of a radiolucent line,
radiolucent line.
Where you can have an idea of where the... Thank you. Keep that. As you were saying, you've got a radiolucent line, just to let you know where the skirt is. And in the initial procedures, we usually spoke about having at least 10 millimeters between the suprahepatic vein and the IVC2RA junction. Usually it's enough if you've got 7 or 8 millimeters, because the hepatic veins are very large in these kind of patients, and it's not a problem if you leave parts of the skirt in the hepatic veins.
You can nicely see that the valve is functioning already. One leaflet is kept open by the wire that is still there. And the hepatic vein is open, and the entrance at the floor is sealed by the skirt of this valve. And now the cone is removed carefully. And I can say that after the implantation, we noticed an increase in the LA pressure and a lowering in the RA pressure, and the lowering of the SVC pressure and the IVC pressures, the mean and the V waves, which was a sign that physiologically this implantation made an alteration on the hemodynamics and prevented the V wave of the right atrium to go back into the IVC or the SVC.
You're more or less treating the consequences of the TR, the organic kidney and liver consequences of the TR, but you're ventricularizing the right atrium, and I think that's also why, for example, NVP levels probably won't go down as if you treat the mitral regurgitation with another technique, because the right atrium remains large. Also, we've got a small registry of CT scan follow-up of these kind of patients, and what we've seen is that the right ventricle volumes go down, but the right atrium volumes stay the same or even a bit higher, because obviously the TR remains the same.
And tell us about your experience with the clinical follow-up of these patients. You have much bigger experience than we are very happy. We are now almost 3 months, 2.5 months, and the patient immediately felt better, and she's feeling very well. So it was a huge improvement in her clinical status. Do you see that in all the patients? Is it typical?
We are very happy with the results, with the clinical results. I think this is obviously not the ideal treatment if you can treat the valve itself. This technique should be for patients when you cannot repair the tricuspid valve. But the clinical response is very good unless the patient has got really depressed RV function. Once the RV function is really depressed, or the other scenario where we've seen improvement is much less, is when the kidney function is really depressed. Yeah, impaired. Thank you. So what we usually keep an eye is on the RV function before the indication, and also that the patient kidney function is not very bad. It's usually filtration is above 30. If that's the case, probably you can do the procedure, but the patient is not going to do that. Good.
Thank you very much. I think we are running out of time, and we already spent all the break time here, so we'll have to stop here and go for the next session. I would like to ask the panel of the next session to come here and start immediately. So if somebody wants to grab some coffee or water, please do individually. Let's continue, because we have people that need to connect from the US and people that they're still here waiting for the lectures. Thank you. I guess they are somewhere outside getting their coffee. And we'll start with the first videotape presentation. This session has a title, TAVI Challenges and Unmet Needs. And the presentation is by the world-famous Dr. Tsetse from France, and he's going to talk us about TAVI in bicuspid anatomy, all we should know or all we must know. Is this pre-recorded, or did you are with us live? Okay. Thank you for being with us, and we're all ears for you.
Okay, so I'm going to share my screen now. Three, two, one. So TAVI in bicuspid anatomy, all you must know. So I would like just to start by saying thank you for inviting me to be part of this meeting, even if it's only virtually. It's a real pleasure and honor to share my thoughts about TAVI in bicuspid aortic valves with you. There are a couple of pieces of knowledge that we need to describe before deep diving into the sizing and the procedural aspects of taking care of the bicuspid patients. Key messages about bicuspid aortic valves. The first one is that it's quite a frequent disease in the general population and in the TAVI population in particular, 5 to 8% in Western countries and up to 40% in China. We also know that clinical outcomes when we compare tricuspid aortic valve patients and bicuspid ones who underwent TAVI are quite similar, particularly when we utilize second-generation TAVI devices. And there are some signals in favor of a potentially higher stroke rate for bicuspid aortic valves when we do TAVI. That needs confirmation. And at last, sizing is currently quite intuitive, but that intuitive sizing correlates with good clinical outcomes. So it's all about understanding what we do and putting everything into numbers. We know that there are differences in terms of anatomical features between tricuspid and bicuspid valves. First, we have a larger annulus in bicuspid aortic valve patients. We have a most frequent dilation of the ascending aorta, more calcium, extensive calcification, uneven leaflet length, and potentially abnormal origin of the coronary artery. So all these features provide an extremely heterogeneous group of disease. You can see that there is no single bicuspid. Every bicuspid is different in terms of phenotype, calcium, number of leaflets, everything is different. And this has been studied in that within that collaborative registry, and we could understand that in that registry that first of all, the combination of a raphy and extensive calcification of the leaflet is quite frequent. Close to 25% of the bicuspid aortic valves exert this type of phenotype, and this is going to lead to almost a threefold increase in mortality up to 2 years post-procedure, as well as an increased stroke rate and hypervalvular regurgitation. So that combination has to be identified because it impacts the outcome of the patient. In more contemporary registries or even trials, what we could see is that mortality is quite low, 1.3% in that registry when we use second-generation TAVI devices with contemporary techniques. But there is still that issue of stroke. So potentially, bicuspid aortic valves could be a perfect subgroup of patients in whom a cerebral protection device could be systematically utilized. What do we know about sizing for bicuspid aortic valves? The first thing that we have to agree upon is the fact that the CT sizing is the method of choice. It's a gold standard, using that CT scroll technique, moving from the aortic annulus to upwards to better understand the number of the distribution of the leaflets, the extent of the calcium, the dimension of the ascending aorta. And we also know that annular base sizing seems to work in close to 90% of the patient, type 0, type 1. We also know that supraannular sizing is really important, and it is recommended to better understand the configuration of the landing zone, because we have to be cautious in tapered configuration into which there is a higher likelihood of aortic root injury. So the second method, we're going to come to that afterwards. It's more intuitively utilized for balloon expandable platforms. And the general idea is that we have to avoid excessive oversizing to prevent complications. I had the real privilege to lead the Bavard registry, collaborative registry, that provided us with some better understanding of the sizing, what could be a way of sizing for bicuspid aortic valves. And we understood a couple of things. The first thing, when we compare the pre and post CT scans of the patient, is that there is a quite constant underexpansion of the stent frame, 10 to 15%, in regards to the aortic annulus diameter, and that is quite systematic. Whatever the platform that was studied, it was the same pattern that we observed. Second, 3 to 5% oversizing in regards to the aortic root, the aortic annulus dimension makes sense, and is going to lead us in terms of into what could be an appropriate oversizing ratio for bicuspid aortic valves. In tricuspid, it's close to 10 to 15%, depending on the platform that is used. Appropriate circularity can be achieved. It tells us about the importance of the procedural aspects that we're going to describe afterwards in bicuspid aortic valves, but circularity, a decent circularity, can be obtained with new generation TAVI devices, and overall it's key to understand the configuration of the landing zone. And that comes from the Bavard registry, and when you match the annular diameter and the supraannular diameter, the commissure to commissure distance to the mean perimeter derived diameter of the annulus, you get a landing zone configuration. When both diameters are more or less in the same range, you get a tubular configuration. When the commissure to commissure distance is bigger, more than 10%, you get a flared, and when it's the opposite, you get a tapered configuration. And in close to 90% of the cases, when it's tubular or flared, we can size based on the annulus. It's only on tapered configuration into which the supraannular sizing is going to be the reference for the metrics for valve type and size selection. Another piece of information that was provided by our pre and post CT scan assessment pre and post-TAVI CT scan assessment is the fact that if you do the supraannular tracing at 4 millimeters above the annulus in type 0 and type 1, tubular or flared configuration, you're going to anticipate the final diameter of your THV, mean perimeter derived diameter of the THV within the patient. And so that's quite important. It could be another way to decide when we are in a gray zone in between two valve sizes. The circle method is really useful if you plan to utilize a balloon expandable platform, helping you to understand what is going to be the relationship of your stent frame with the surrounding anatomy and the risk of sinus sequestration or coronary obstruction, or globally, broadly, any risk of injury to the aortic root. So that circle method makes sense. Balloon sizing can be utilized imaging as an adjunct to the CT sizing, because it's more about understanding what is going to be the movement of the calcium, where is the waist, particularly in tapered configuration. Useful, isolated, I don't think that it's enough to size, but in combination with the CT scan, it could be utilized. There are a part from the Bavard registry, Bavard algorithm, a couple of additional algorithms that have been tested, such as this one, the Casper algorithm. You do the tracing of the aortic annulus. If you have a raphe that is more than 50% calcified, you subtract 1 millimeter to the diameter of the annulus. If you have extensive leaflet calcification, you subtract another millimeter, and then you get a metric, a diameter to choose your valve size. It requires validation. At last, couple of procedural considerations that we've learned and that we've obtained from all the experience that has been accumulated. The first thing is that we should try to work in the equivalent of two-cusp view for bicuspid aortic valves. And it's similar to what we do with tricuspid aortic valves and the cusp overlap technique. We put fused leaflets on one part of the screen, and the isolated leaflet on the opposite side. And we need to fine-tune maybe more precisely that two-cusp projection for bicuspid aortic valves, but that's the way to go. Predilation is part of the contemporary technique, using the minor axis of the annulus at baseline, just for safety, just to open up a little bit the room for the device insertion, but avoiding to be too aggressive. Commissural alignment can be achieved for bicuspid aortic valves. It's a little bit more challenging, but that's something that we may obtain. And eye implants, in the past, some proposed to deploy the devices above the aortic annulus, and that led to dreadful complications with embolizations, aortic regurgitation. And now we clearly understood from all the registries that high implants still equals touching the aortic annulus. So we aim high, but still across the aortic annulus, and we need to reposition, if necessary, with self-expanding platform. Assess the stent frame in two orthogonal views, just to see what is the expansion. And if there is a need for post-dilatation, once again, start with the minor axis of the annulus at baseline, then extend to the mean perimeter derived diameter for safety. Couple of examples of the high implants that could be obtained, whether it be a balloon expandable platform, a self-expanding one, or the mechanically expanded platform, still across the aortic annulus. Finally, the commissural alignment. The most frequent phenotype of bicuspid is a type 1 left-right. For this phenotype, you just rotate the delivery catheter the same way that we do for tricuspid patients. It's the same philosophy. For non-type 1 left-right bicuspid, it's a little bit more challenging. So it will depend on the configuration of the leaflet distribution and the relationship with the coronary arteries. We may aim more at a coronary alignment rather than a commissural alignment. Thank you very much for your attention.
Thanks a lot, Dr. Cece, for your excellent presentation in a very special, difficult, maybe provocative topic for TAVI. Are there questions from the audience? Do you hear me? No. Dr. Tsetse?
Yeah, it was a recorded video.
Dr. Tsetse?
He's not here. Does it
No comments, no, that's okay.
So I want to make some comments,
Sure.
especially for the bicuspid aorta. As we know, since bicuspid patients are much younger patients, and there's now trend to do transcatheter aortic valve implantation in younger patients, also the lower risk patients, it's very important that we underline that we will see a lot of bicuspid patients if we do TAVI in younger population. And all these patients are excluded from randomized clinical trials. So bicuspid, TAVI in bicuspid anatomy is harder than normal tricuspid anatomy. So, for example, there's tendency of cerebral embolization. So cerebral embolic protection device must be used in bicuspid intervention. And we will see also in younger patients with larger sizes. So larger size is a problem, and as we will discuss later. So we had to avoid it to implant larger size valves in bicuspid patients.
Okay. Okay, thanks. So I would like to invite the second speaker, Dr. Sirsa Loudis, who is going to present TAVI in extreme calcium endocarditis or moving component. Please, 8 minutes because the time is so limited.
Καλησπέρα σας. Ευχαριστώ πολύ για την ιδιαίτερα τιμητική πρόσκληση. Λοιπόν, επασβεστομένη ανατομία. Πώς θα μετρήσουμε το ασβέστιο, Agatston score, επιφάνεια και βαρύτητα επασβεστώσεων, volume score, πρακτικά όγκος επασβεστώσεων. Πού μας ενδιαφέρει να ξέρουμε την επασβέστωση, μας ενδιαφέρει να ξέρουμε στη ζώνη προσγείωσης της συσκευής μας, πρακτικά στο... I'm not prepared for English, I'm sorry for that. Μας ενδιαφέρει στη ζώνη προσγείωσης της συσκευής μας, πρακτικά στην ανιούσα ορτή και στον εγγύς χώρο εξόδου της αριστερής κοιλίας. Μας ενδιαφέρει να ξέρουμε οι πτυχές πόσο φορτίο ασβεστίου έχουν και αν υπάρχει ραφή, αν υπάρχει δίπτυχη ανατομία, μας ενδιαφέρει να ξέρουμε αν είναι επασβεστομένη η ραφή και σε τι βαθμό. Πρακτικά δεν χρησιμοποιούμε σκόρ για να βαθμολογήσουμε την επασβέστωση της βαλβίδας. Χρησιμοποιούμε πρακτικά ποιοτική εκτίμηση σε απούσα, μη ήπια, μέτρια και σοβαρή επασβέστωση, εκτιμώντας το τόξο που καλύπτει το ασβέστιο, το βάθος διείσδυσης στον χώρο εξόδου της αριστερής κοιλίας και το πάχος του ασβεστίου που διεισδύει στην αριστερή κοιλία. Γιατί μας ενδιαφέρει το ασβέστιο? Για διάφορα που θα πούμε παρακάτω. Πριν απ' όλα, είναι προγνωστικός ρόλος για να έχουμε παραβαλβιδική διαφυγή με τα πεμβατικά. Φαίνεται ότι στις πρώτες γενιές των βαλβίδων αυτό ήταν δεδομένο, ειδικά για ογκώδεις σχηματισμούς ασβεστίου που ήταν προπίπτοντες και αφορούσαν ειδικά στην αριστερή και τη μη στεφανία πτυχή. Είχαμε σοβαρότερες παραβαλβιδικές ανεπάρκειες. Επίσης, ήταν πολύ πιο σημαντικό να είναι επασβεστωμένο το αορτικό τείχομα πίσω από την αορτική πτυχή, όπως και οι κόμισουρς των βαλβίδων εναντί των πτυχών, στο να έχουμε παραβαλβιδική ανεπάρκεια. Και το ίδιο το ποσό του ασβεστίου, και εδώ πέρα υπάρχει ποσοτικοποίηση, όταν ήταν πάνω από 8.000 μονάδες Agatston, φαινόταν να έχουμε και αποτυχία της συσκευής και σημαντική παραβαλβιδική ανεπάρκεια. Στις νεότερες γενιές βαλβίδων δεν φάνηκε να ισχύει το ίδιο. Φάνηκε ότι στις EPIN 3, για παράδειγμα, η παραβαλβιδική διαφυγή να είναι μικρή και να μην έχει σχέση το ποσό του ασβεστίου που υπήρχε στη βαλβίδα. Και αυτό φαίνεται και στις 3 γενιές των βαλβίδων αυτών, που φαίνεται προοδευτικά μειούμενη η παραβαλβιδική διαφυγή και φαίνεται να είναι η κατηγορία της βαλβίδας αναφορικά με τη γενιά της προγνωστική στην μη παρουσία παραβαλβιδικής διαφυγής. Αυτό αφορά και τις αυτοεκπτυσσόμενες βαλβίδες. Στη μετάβαση από core valve σε evolutar φάνηκε να έχουμε μείωση των παραβαλβιδικών διαφυγών και το ασβέστιο να μην αποτελεί προγνωστικό παράγοντα για την εμφάνιση παραβαλβιδικής διαφυγής. Τι θα κάνουμε λοιπόν για να αποφύγουμε την παραβαλβιδική διαφυγή όταν έχουμε πολύ ασβέστιο. Πρακτικά καλή προετοιμασία της βαλβίδας με προδιαστολή. Προσπαθούμε να έχουμε μια κυκλοτερή επιφάνεια, η οποία να είναι βένδοτη και ομαλή, ώστε να έχουμε μια καλή ζώνη για την εμφύτευση της βαλβίδα μας. Θέλουμε να επιλέξουμε κατάλληλο μέγεθος βαλβίδας και να εμφυτεύσουμε σε σωστό βάθος, ειδικά αν πρόκειται για valve-in-valve. Αν έχουμε αμφιβολίες, μπορούμε να χρησιμοποιήσουμε μπαλόνι για να δούμε το βαθμό του sealing που πετυχαίνουμε με την εμφύτευση της βαλβίδας και να επιλέξουμε και την κατάλληλη συσκευή. Και όταν λέμε κατάλληλη συσκευή, εννοούμε προφανώς νεότερης γενιάς, με sealing skirt και μάλιστα όταν υπάρχει και ένα ενεργό component στο sealing skirt, δηλαδή όταν ανοίγει κατά τη διαστολή και κλείνει τη δίωδο του αίματος προς την αριστερή κοιλία, αυτό είναι σαφώς προτιμότερο. Δεν έχει αποδειχθεί βέβαια σε κάποια head-to-head μελέτη. Είναι η επασβέστωση καθοριστική για την εμφάνιση ανάγκης εμφύτευσης βηματοδότη για διαταραχές της αγωγής. Η ποσότητα του ασβεστίου όχι. Η συμμετρία του όμως ναι. Όταν έχουμε επασβέστωση της αριστερής στεφανίας πτυχής, τότε οι δυνάμεις ασκούνται προς τη δεξιά και τη μη στεφανία πτυχή, επηρεάζοντας το χις και το αριστερό σκέλος του χις, με αποτέλεσμα να έχουμε διαταραχές της κολποκυλιακής αγωγής. Όπως επίσης όταν έχουμε και στην αορτομητροειδική συνέχεια σημαντικές επασβεστώσεις, εμφανίζεται το ίδιο φαινόμενο. Αρκετά συχνά χρειάζεται να έχουμε εμφύτευση βηματοδότη μετά. Τι θα κάνουμε για να το αποφύγουμε αυτό? Προφανώς θα κάνουμε υψηλή εμφύτευση και θα την κάνουμε στην cusp overlap θέση για να ξέρουμε ακριβώς το βάθος εμφύτευσης που πετυχαίνουμε στην περιοχή που μας ενδιαφέρει. Είναι προγνωστική η επασβέστωση της βαλβίδας για εμφάνιση ρήξεων? Σαφώς και είναι. Υπάρχει η ρήξη που μπορεί να γίνεται σε διάφορα επίπεδα. Μπορεί να είναι annular, subannular or supraannular. Μπορεί να αφορά την προδιάταση της βαλβίδας, την εμφύτευση της βαλβίδας, είτε τη μεταδιάτασή της. Συμβαίνει σχεδόν αποκλειστικά σε εκπτυσσόμενες με μπαλόνι βαλβίδες και φαίνεται να εξαρτάται από την ποσότητα του ασβεστίου και το βαθμό που κάνουμε oversizing στη βαλβίδα, ειδικά όταν αυτό είναι πάνω από 20%. Και αν έχουμε και μικρή ανατομία. Ιδιαίτερη ευαισθησία φαίνεται να υπάρχει στην περιοχή ανάμεσα στην αριστερή και στη δεξιά στεφανία πτυχή. Κάτω από αυτήν στο LVOT υπάρχει ένας μειώδης χώρος πρακτικά χωρίς καμία υποστήριξη. Ρήξεις σε αυτή την περιοχή, όταν υπάρχει επασβέστωση, προκαλούν μαζικότατες αιμορραγίες. Και προφανώς οι ρήξεις είναι ανεξάρτητες από την ασβέστωση των πτυχών, εξαρτώνται κυρίως από την επασβέστωση του τυχώματος και των commissures. Τι θα κάνουμε για να τις αποφύγουμε? Προφανώς όταν κάνουμε μετρήσεις θα πρέπει να λαμβάνουμε υπόψη και για τα μπαλόνια και για τις συσκευές την παρουσία αποσβεσταμένων όζων. Θα πρέπει να επιλέγουμε συσκευές και μπαλόνια που να ταιριάζουν στη μικρότερη ανατομία, ειδικά όταν υπάρχει discrepancy μεταξύ του LVOT και του aortic annulus. Θα πρέπει να κάνουμε συμβιβασμούς ακόμα και με μικρότερες συσκευές αν χρειάζεται και θα πρέπει να βλέπουμε αν αυτές είναι επαρκείς με injections όταν έχουμε φουσκωμένα μπαλόνια. Θα πρέπει να προτιμούμε τις αυτοεκπτυσσόμενες βαλβίδες και ειδικά όταν έχουμε εχθρική ανατομία αναφορικά με το ασβέστιο. Θα πρέπει να ανησυχούμε για απόφραξη των στεφανιών αγγείων. Δεν φαίνεται να σχετίζεται η ποσότητα του ασβεστίου με αυτό. Ωστόσο, η παρουσία όζων σε λάθος θέση έχουν δείξει, όπως σε αυτή την περίπτωση, να έχει μετακινηθεί ασβέστιο και να φράζει το όστιουμ. Προφανώς αυτό γίνεται εμφανές όταν κάνουμε μελέτη της αξονικής και μπορούμε να το προβλέψουμε. Και όταν έχουμε αμφιβολίες, πρέπει να προστατεύουμε τα στεφανία με σύρμα, μικροκαθετήρα και στέντ. Όταν έχουμε κινητά μορφώματα τα οποία μπορούμε να εμβολήσουμε, τι μπορούμε να κάνουμε? Πριν απ' όλα ξέρουμε ότι κατά την εμφύτευση των βαλβίδων από το transcranial Doppler έχει φανεί ότι γίνονται μικροεμβολισμοί αρκετά μαζικοί και αυτοί σχετίζονται τόσο με την παρουσία ασβεστίου όσο και με τη φάση της εμφύτευσης στην οποία βρισκόμαστε, καθώς εμφανίζονται κυρίως κατά την τοποθέτηση της συσκευής. Το 99% των ασθενών που είχαν συσκευή εγκεφαλικής προστασίας είχαν αρκετούς συγκράτηση μικροσωματιδίων μέσα στο φίλτρο, διαφέρων ποιοτήτων και διαφόρων μεγεθών. Δυστυχώς δεν δείξαμε ότι τα μειώνουμε με τη χρήση των συσκευών εγκεφαλικής προστασίας. Φαίνεται να μειώνουμε όμως τα σοβαρά εγκεφαλικά, αυτά που έχουν μεγάλη και ισχυρή κλινική συμπτωματολογία. Μπορεί να υπάρχουν και άλλα κινητά μορφώματα. Σε εγχείρητους ασθενείς έχουμε δει στήρες εκβλαστήσεις, ακόμα και νοελάστομα να έχουν παγιδευτεί με το μεταλλικό σκελετό μιας βαλβίδας που εμφυτεύτηκε. Σε άλλους χρησιμοποιήθηκαν συσκευές εγκεφαλικής προστασίας και σε άλλους όχι. Φαίνεται ότι υπάρχουν τακτικές για να αποφύγουμε τους εμβολισμούς. ακόμα και αν δεν είναι αποδεδειγμένη το όφελος από τη χρήση των συσκευών εγκεφαλικής προστασίας, ενδεχομένως, αν το χρησιμοποιήσουμε σε ασθενείς πολύ υψηλού κινδύνου, να αποφύγουμε ένα καταστροφικό γεγονός. Καλό είναι να κάνουμε ελάχιστους χειρισμούς, να αποφεύγουμε προδιατάσεις και ενδεχομένως να παγιδεύουμε και να μεταδιατείνουμε αν αυτό είναι απαραίτητο. Μια one-shot εμφύτευση με μια συσκευή με μπαλόνι, για παράδειγμα, μπορεί να είναι προτιμότερη από το να χρησιμοποιούμε ανακτήσιμες συσκευές που επανατοποθετούνται. Αυτά, σας ευχαριστώ πολύ για την προσοχή σας.
Ευχαριστούμε τον κύριο Σερελούδη, ο οποίος ήταν εντός του χρόνου του. Πραγματικά σας ευχαριστούμε. Ξεκάθαρη παρουσίασή σας. Υπάρχει ένα σχόλιο, νομίζω, από τον κύριο Τσίγκα, ο οποίος έχει συνδεθεί διαδικτυακά. Αν μπορείτε να μας τον δείξετε. Ναι, σε ακούμε, κύριε Τσίγκα. Καλησπέρα.
Hello to everyone. I would like initially to thank the organizing committee for the kind invitation. It is really an honor for me being a moderator in such an interesting roundtable. Initially, I would like again to thank and congratulate Dr. Sirseludis for the comprehensive presentation regarding TAVI in extreme calcium, past endocarditis, and moving components. Only one short comment. Aortic valve calcium scoring pre-TAVI might be important with regard to outcome and mostly to paravalvular leaks. We all know that paravalvular leaks are now considered as an acceptable outcome without serious consequences by some investigators. But this might be true for trivial or really mild paravalvular incompetence in patients within their last decade of life, if we speak for patients over 80 years old. But however, with a more liberal TAVI indication, for example, TAVI expansion to operable patients, low risk, even mild paravalvular leaks might be a matter of concern. And lastly, to my knowledge, there are limited data on the use of TAVI cases for effective treatments for infective endocarditis management, and of course, active endocarditis, which is a very severe complication. In fact, the presence of infective endocarditis following TAVI is another beast complication with 1 year mortality about 70 to 80%. Perhaps we need more, of course, in the future research trials can investigate this, the safety and the efficacy of TAVI for patients in high surgical risk with cardiogenic shock from active endocarditis. Of course, we need more data. I could thank again Dr. Sirseludis for this excellent presentation. Thank you very much.
Dr. Tsigas, is it possible to introduce the next speaker, please?
Of course. It's an honor again to present Dr. Rigopoulos, who is an Associate Director, Adult Cardiology in Mitera General Hospital, who will present to us the optimal TAVI device choice consideration algorithms. Dr. Rigopoulos.
Okay. Thank you very much, Mr. Chairman. And I would like to thank the organizing committee and especially my friend, Dr. Sparias, for the kind invitation to participate to this very important Congress on heart valves. The ideal device for performing TAVI should be one that has a small profile, is straightforward and easy for a safe application, has very good immediate and long-term results, and is suitable for the whole spectrum of anatomies that we may encounter, and of course has a low need for implantation of pacemakers. On the other hand, an operator would like to have an ease of use with lower procedural steps in performing the TAVI, and maybe some kind of convenience with retrievable devices. Nowadays, we have a great variety of valves. We have self-expandable valves with the, I think we can show here, with the valves that are supraannular, like the Evolut Pro and the Accurate series, and valves that are intraannular, like the Portico and Navitor valves. We also have the Trilogy, which is already available in Europe, and has a special kind of function in order to be very well orientated to the valve leaflets. And we have the balloon expandable valves with the Sapien valves, and nowadays we also have the My valve, which is similar to the Sapien valve, but has much more wide spectrum of choices of dimension. The mechanical valves we don't have anymore. So as far as the device success is concerned, all devices we use are successful, but there are some differences in terms of special complications and indications. So the observational studies have not shown any significant difference between self-expanding and balloon expandable valves, and also from the prospective studies that we have, we cannot choose the one over the other. So we have to deal with complications and try to avoid them by choosing the optimal TAVI device. And to do that, we have to take into account the clinical features of the patient. And in order to be very successful, we should see the anatomic factors that play a role in deciding which is the best valve. So we should measure the annulus. We should see if there are calcifications, as the previous speaker very well showed. We need to establish a coronary access after the valve, to take care of special aortic anatomies. And of course, there are some special cases as valve-in-valve TAVI and bicuspid aortic valve. For the small annulus, we have the problem of patient prosthesis mismatch because the annulus is very small. And of course, a balloon expandable valve will remain small. In that case, we should choose a self-expandable valve if we have the anxiety that there is some patient prosthesis mismatch to be seen. And of course, this has been shown also in the studies. If we have a very large annulus, then we have results that are very good with self-expanding and balloon expandable valves. With the self-expanding valves, we have some higher device failure because of AR and valve embolization, but the hemodynamics are good. And nowadays, we have the MyValve XL, which is large, it's 30.5 and 32 millimeter available, and also the Navitor Titan, which is also a 35 millimeter intra-annular valve for special very large annuli. The calcifications has been shown by the previous speaker. We have to take care not to oversize with balloon expandable valves, and if we have a heavy LVOT calcification, then probably we should avoid them and try to implant a balloon expandable valve in such cases, which self-expanding valve in such cases, which is the preference of most of operators in a worldwide survey. Coronary obstruction, the most cases we deal with coronary obstruction is valve-in-valve cases, but of course we have a significant difference when we implant balloon expandable valves. And the risk factors are the coronary ostia lie low. We have shallow or shorter sinus of Valsalva, and older patients, female gender plays also a role. Patients that are not, that do not have any bypass grafts, and there is also a delayed coronary obstruction, which if it comes early in the first week after implantation, then we probably have implanted a self-expanding valve which continues to expand and therefore leads to the obstruction. The most difficult problem we have is that we are not able to re-access the coronary arteries after we have implanted a valve. And why we have that? Either we have a very long valve that obstructs the access to the coronary arteries, or we have a commissural post exactly oriented at the origin of the coronary artery, which makes it impossible to come with a catheter afterwards in the coronary artery. Why is it important to have reaccess? Some patients have acute coronary syndromes after TAVI, and they have a bad prognosis with high mortality if there is no revascularization. On the other hand, many patients have or develop coronary artery disease and need to be catheterized. There is a possibility, apart from implanting a balloon expanding valve, which is shorter, there's a possibility nowadays also with alignment of the valve to avoid blocking the origin of the coronary arteries, also with self-expanding valves. Conduction abnormalities is also a big issue because it has an ominous prognosis if the patient receives a pacemaker after the TAVI. And we have seen that the self-expanding valves have a higher percentage of need for a pacemaker, excluding the valves that have a lower radial force, such as the accurate valves, which should be preferred when we have pre-existing abnormalities in the ECG. Patients with left ventricular systolic dysfunction is also a special population of patients. These patients might have prolonged hypotension during the TAVI, might evolve to a need for a pacemaker, significant PVL, or have a high transprosthetic gradient afterwards. And in these patients, we should avoid very prolonged pacing, rapid pacing during the TAVI, and therefore valves that do not need pacing, such as Accurate Neo and Navitor, might be a good option. The bicuspid valve is a chapter by itself. Not all bicuspid valves are the same. We need to be sure that we are going to do a TAVI to a young patient with a bicuspid valve and not send him to the surgeon. There is also a difficult task to measure what dimension of valve we need. And the problem is that these valves are extremely calcified. They have large annuli. We need pre and post dilatation most of the times, and we need to recapture and reposition the valve. And of course, there's a higher conversion rate to surgery. With the new generation devices, we have somewhat good results, but still, if we have extreme raphe calcification or cusp calcification, then we have to deal with mortality, PVL, and aortic root injury. In valve TAVI, we need to take care of a possible patient-prosthesis mismatch and coronary obstruction. We have to carefully plan the procedure beforehand in order to identify the mechanism of the failure of the initial valve and see if there is any historical hemodynamic deterioration or there is some patient-prosthesis mismatch in the original operation. And then we have to deal with it if there is some kind of suspicion for a patient-prosthesis mismatch by using a supraannular device and also by making a fracture of the surgical valve in order to achieve a larger annulus. There is not a real difference between self-expanding valves and balloon-expanding valves.
Consider the time.
It's the two slides. In performing TAVI, valve-in-valve TAVI, but we also have other tools in order to avoid coronary artery obstruction, such as the basilica, and of course the implantation of valves with commissural alignment. TAVI in TAVI, we have more or less the same problems, but here we also have the problem if we have a self-expanding valve in place that we might certainly, almost certainly block the coronary artery access. Peripheral vessels, I'm not going to go into that. It's important to deal with aortic root angulation. Of course, Didier Cheche would not agree with that, but it's more difficult to implant a self-expanding valve in an angulated aortic arch with a flat aortic arch. And of course, if we deal with patients with a younger age and lower risk, we have to take care of the valve durability. About that, we don't have many data yet. The only data that we start to develop are such as the NOTION trial at 8 years, which shows that the TAVI valves are more or less the same or even better than the surgical valves in this issue. So in conclusion, no TAVI device is better for addressing optimally the entire spectrum of challenging scenarios in TAVI. The selection of the best processes should be done according to the individual anatomy of the patient and specific clinical factors. There is a continuous evolution in processes and techniques. And until we have an optimal device, we should try to tailor the selection of the valve to the specific anatomy and clinical scenario of the patient and not only have one valve in the lab. Thank you very much.
Dr. Tsigas? Okay.
Congratulations, Dr. Rigopoulos. You carefully underlined the need for some degree of expertise and, of course, in-depth training to be able to select the most appropriate transcatheter heart valve for each case, of course, aiming at optimal results. I would like to summarize the existing knowledge and some guides to follow. Balloon expandable valves are really more suitable for large annulus with high risk for paravalvular leak, horizontal aorta more than 70 degrees, high preprocedural risk for permanent pacemaker implantation, multivessel coronary artery disease at high probability of future PCIs. Self-expandable valves are more suitable for dense annular or subannular calcification, intolerance to rapid pacing, for example, for patients with low ejection fraction. Small or challenging arteries, of course, are better to choose self-expandable valves because of the sizes of the seats. And of course, for cases for valve-in-valve and any kind of such situations, I believe it's better to use a self-expandable valve, especially for patients, as you mentioned well, for great probability for severe prosthesis patient mismatch. Thank you very much, Dr. Rigopoulos.
Good afternoon, dear colleagues. I would like to congratulate the previous speakers, and I would like to invite Dr. Cardiothoracic for his presentation. Dr. Cardiothoracic is an interventional cardiologist at Mitera General Hospital. You have only 8 minutes.
Thank you very much, Mr. Chairman. I would like to thank the organizing committee and especially Dr. Sparias for this kind of invitation. So, hemodynamic performance of TAVI device and outcomes. I'll try to make this a long story, make it short as much as I can. So, why we should care about hemodynamic performance of TAVI devices? So, first of all, because we're aiming for the optimal durability of the device. Secondly, because we're aiming for the optimal outcome. I think this is a very impressive slide from the American registry. So we can see that in patients older than 65 years old, almost 9% with severe aortic stenosis will receive a TAVI implant. And this is almost 50% for patients older than, younger than 65. So we're moving to younger patients cohort, so we need to improve our outcomes. I think the most important marker regarding the hemodynamics in TAVI cases is the prosthesis-patient mismatch index, and which is translated to an effective orifice area of the biprosthesis when it's too small in relation to the body size, which consequently will generate higher than expected gradients through the normally functioning bioprosthesis. We know from the surgical cohort that significant prosthesis-patient mismatch is related to higher risk for structural valve degeneration. And not only that, but also with higher cardiac mortality, almost 6.5-fold. This is the case for TAVI biprosthesis as well. This is, again, a large American registry. And we can see that the incidence of prosthesis-patient mismatch in TAVI cases is almost 12.1%. This is associated with a higher mortality within 12 months, and it seems that the most important risk factors is involving the small bioprosthesis, larger BSA, valve-in-valve procedure, and a female gender. Now, it's very important, as Dr. Rigopoulos said, about the variety of the available TAVI devices, and the structure is very important to define the hemodynamics post-TAVI. So we have, for instance, the self-expandable evolute valve that has this tapered frame stent, the Navitor, which is a cylindrical valve, and the Sapien, the balloon expandable valve, which has the tapered leaflets. And as we can see here with the Navitor, there's a difference in the attachment of the leaflets, which is non-tapered, in contrast to the Sapien, where the leaflets have a tapered attachment. Now, when we measure the hemodynamics and the gradients, so when we finish the TAVI, we use the invasive gradients and then the echo gradients. So we need to consider the discrepancy between the two measurements. And it seems that the phenomenon of the pressure loss recovery plays an important role in that, and which explains, at least in part, this discrepancy. So we have the echo measurements which usually overestimate the pressure gradient, in contrast to the invasive gradients, which is usually almost zero after the procedure. Now, this is an in vitro study which actually confirms that notion, and that involves both the self-expandable and the balloon expandable valves, and it seems that is more pronounced when we have high flow states. This is another study in TAVI cases, which again confirms this discrepancy. That again involves both balloon and self-expandable valves, but it seems that the difference is more pronounced when we implant small balloon expandable valves with a size of less than 23 millimeters. This is a case of our laboratory, which is a 26 millimeter Sapien 3 Ultra valve. We can see an excellent invasive pressure gradient, almost zero. The day after, the echo gradient was approximately 17. But that was associated with significant systolic LV function recovery. There's a ejection fraction of 40 to 55%. And we can see that 1 month later, again, the echo gradient with the same operator showed a decrease in the mean pressure gradient to 9 millimeters of mercury. So let's see the available data. So first of all, TAVI versus surgical valve. These are the results of the 8-year NOTION trial. We can see the excellent hemodynamic performance of the Evolute self-expandable valve compared to the surgical valves. And we can see that the improved hemodynamics were associated with a significant reduced risk of structural valve degeneration within 8 years. This was the case for retrospective analysis of multiple registries in the US, again with the same results, better hemodynamics with a self-expandable valve, and which was associated with less risk of structural valve degeneration. In this specific registry, the improved hemodynamics were also associated with less risk of cardiac, all-cause and all-cause mortality. And the most important factors were the mean gradients and the severe prosthesis patient mismatch. With the balloon expandable valves, the results are not so impressive. These are from the partner 3 low-risk cohort, which was no difference in terms of hemodynamics between the surgical and the balloon expandable sapien valve. Sorry for the blurry slide. But there was numerically higher significant prosthesis patient mismatch in the surgical cohort, so 6.3 versus 4.6%. In this particular cohort, the sapien XT was associated with a higher risk of structural degeneration compared to the surgical valve, but that was not the case for the third generation of sapien 3 valve. With the balloon expandable valves, again, the bigger the valve, the less the gradient, so better hemodynamics. And regarding the new kid on the block, the Navitor valve has demonstrated excellent performance in small annuli, and we can see that in this figure. And the most important thing is that the significant prosthesis patient mismatch was noticed in the large annuli, more than 23 millimeters, where the small annuli did not demonstrate any prosthesis patient mismatch. Now, regarding the self-expandable versus balloon expandable bioprosthesis, these are the results from the CHOICE trial, where the self-expanding valves demonstrated better hemodynamics compared to the balloon expandable valves. That was associated again with less risk of structural valve deterioration. This is retrospective analysis, single-center retrospective analysis in a Swiss center, which showed that the self-expandable valve was associated with less incident of significant prosthesis patient mismatch, 6.7 versus 15.6%, with their overall mismatch of 33.5 versus 46.9%. That was not translated, however, to clinically significant higher cardiovascular mortality within 1 year, even though we can see that with the case with significant patient prosthesis mismatch was numerically higher mortality, and we can appreciate the divergence of the lines in this figure. There was no difference, however, in terms of symptoms in between the groups. That's another retrospective analysis, again, that demonstrates the superiority of balloon expandable, self-expandable valves versus balloon expandable valves across all the annuli sizes, from small to large annuli. And that was associated with less incident of significant prosthesis patient mismatch in the self-expandable valves. However, again, that was not translated in any significant difference in 2-year mortality. So one size does not fit all, and of course the hemodynamics are very important, but we also need to consider, when we choose the appropriate valve for the patient, many factors, including conduction disturbances, facilitate coronary access, as my colleague said before, Dr. Rigopoulos. And perhaps with the use of technology, artificial intelligence, perhaps in the future we'll be able to choose the appropriate valve for each patient. So in conclusion, significant prosthesis patient mismatch is an important factor which we should consider in all our patients in order to improve long-term outcomes. There is a discrepancy between the echo and invasive gradients that we should always take into account, and consider that the echo gradients usually overestimate the gradients. And finally, balloon expandable valves are associated with higher gradients compared to the self-expandable valves and higher incidence of patient prosthesis mismatch, especially in female patients and patients with smaller annuli. Thank you very much.
Congratulations, Dr. Kalogeropoulos. I don't know if there is any question. I'd like to make one comment. It's
a very good talk, but I want to correct one misconception I hear over and over again. Echo does not overestimate the gradient. It gives you the exact gradient at the effective orifice area of the aortic valve. The pressure does go up due to pressure recovery, but echo does not overestimate the gradient. The work the heart does has already been expanded by the time it pushes that blow through that opening. And when the pressure goes up with pressure recovery, that does nothing but add to the afterload. So this is a misconception I hear repeated over and over again. Echo does not overestimate the gradient. It gives you the exact gradient at the EOA of the aortic valve. And that's something that's used all the time to try to explain higher gradients. But again, echo gradient is at the EOA. Pressure recovery is downstream. By the time you get downstream, the heart's already expended its energy getting the blood out. That's really an important concept for us to take.
I agree with you, and even dimensionless index, or coming from echo, is also another predictor of also patient prosthesis mismatch. So always trust echo. But for the balloon expandable valves, as you underlined, most of the patient prosthesis mismatch occurs when you put smaller valves. So if you had variation for a balloon expandable valve, like intermediate size, I think this problem will solve.
I completely agree with Dr. Riordan's comment, and I agree that echo is the gold standard. I said that to my conclusion. Secondly, I think it's a misunderstanding. So the echo measures velocity. So that means that sometimes we have, for instance, high flow, and that might overestimate the gradient because we have hyperdynamic contraction, you might have high flow status, and yeah. But
you have higher gradients with higher flow. Yeah. That is true, but it's not overestimated. It's giving you the true gradient at that flow level, which is why we really should go back to Doppler velocity index, which is then indexed to that patient's flow and that patient's size, because it compares their EOA to the LVOT diameter. But again, you know, the higher the flow, the more work the heart's doing to get that blood out. Because remember, work is force over distance, and force is mass times acceleration. And so when you put those things together, you get higher flow, you're doing more work. The heart works harder at high flow than at low flow. That's why when you run, you're expending more energy.
Maybe peak velocities, you want to say that peak velocities can overestimate, but mean gradients and Doppler velocity index solve the problem. So we had to trust echo gradients.
No, absolutely. I agree with that. It's just in the case that I showed that initially the day after the TAVI, the gradient was 17, and a month later was 8. What I'm saying is that when you see an 18, probably, you know, it's not like it's a very high gradient because, for instance, when I saw that, when I used a 26 millimeter valve, I was a bit disappointed. I said, okay, 18 millimeters. But a month later, it was 8. So, I mean, I don't know what's your opinion about that, but exactly. So we're saying the same thing.
Then you got the real gradient.
Great.
And so, you know, flow is everything. You know, flow is what keeps you alive. And that's why when you see people that look at people that have gradients less than 20 and longevity and gradients over 20 longevity, they often say, well, look, these people less than 20 don't do so well. It's because they have a lot of people in there that have bad EF and low flow, and they can't generate a gradient, but they still have stenosis and they're all going to die because they have low flow. So, but it is common when you're hyperdynamic, yeah, then it drops back down.
I promise I won't use the term overestimation again.
It's a very interesting discussion, but we have to proceed. Professor Tsigas is connected. I don't know if you have any comment or a question. Greg?
We cannot hear you.
Sorry for that. I would like to congratulate Dr. Kalogeropoulos for the excellent presentation regarding, I could say, an issue. Hemodynamics are always a problem. How to measure exactly what it means in clinical scenario. Okay, but all the comments are really very helpful in that way. So let's move to the final presenter for this roundtable. I would like to present Dr. Kalavriziotis, which is an associate professor in Department of Surgery, Quebec City, Canada, who will present transcarotid can become a standard access. Dr. Kalavriziotis.
Γεια σας, ευχαριστώ πολύ, καλησπέρα σας. I'm especially thrilled to be presenting because I think this is the first time at a meeting where people pronounce my last name correctly, so I'm very happy about that. So let me start by asking, do we really need alternative access in 2023? And I think the answer is a definite yes. I think, and I'm going to go out on a limb here by saying that if you're doing close to 100% TF, one of two things is going on. Either patients with prohibitive iliofemoral disease are not being referred, or they're undergoing medical therapy, which is, as we know, is disastrous in severe AS. What we know from the partner data is that TAVI versus surgery, the benefit is greatly reduced when you're doing transthoracic alternative access. So we've had to be innovative to find alternative vascular routes that are safer. And this is, Dr. Shamadi was a fellow with us. We presented our initial 100 cases of transcarotid, and we see that outcomes are better than the transthoracic approaches, and they can be compared to the transfemoral route. And I'll get into more detail in a few slides. So transcarotid became our main alternative access of choice since 2015, and we've done a little over 400 transcarotid cases. When you speak about transcarotid, people get nervous because they're afraid of vascular injury, they're afraid of cerebral embolism or hypoperfusion. And I just want to take a moment and say, I think it's very important in 2023 that we have to fit the access to the patient and not the patient to the access that we want for the patient. So look at the CT scan and the patient will tell you what access to choose. And so what's our transcarotid preoperative workup? I get nervous if the diameter of the common carotid is less than 6, but we've done less than 6. You definitely don't want to see any mid-artery calcification, and bovine arch is okay. So a common origin of the innominate and left carotid. Everyone can see my slides, right? Yeah, okay. I think I'm not getting the same picture here. Okay. We do not do brain imaging. We do not do brain imaging in these patients. So we do not image to assess the integrity of the circle of Willis. We do not do any peri-procedural perfusion assessment, meaning, initially in France and some centers in the US, we're clamping the carotid after exposing it in order to assess back pressure. We find that doesn't help. And we only actually do carotid echo only in patients with a history of stroke or TIA. So this is another one of our fellows, Dr. Campello Parada, a few years back showed that there's absolutely zero positive predictive value in peri-procedural brain perfusion assessment by clamping the carotid after exposing it prior to the TAVI. And this is very important because this is not an endarterectomy that you're performing on the internal carotid. You're way down on the common carotid, so the bifurcation stays intact during the operation. So there's minimal risk of hyperperfusion. So the connection between the external carotid and the internal carotid stays intact during the operation. So these are our data. We early on in our experience, 2015 to 2018, we did 127 transcarotids, compared them to transfemoral patients. And the residents tell me, these are the patients referred for transcarotid TAVI are the sickest patients in the hospital. And they're right. They have significantly more diabetes, more chronic lung disease, they have more coronary artery disease, and obviously more peripheral vascular disease. So how about the outcomes? If you look at outcomes, and now we've adjusted in a multivariate logistic regression model, transfemoral versus transcarotid, the outcomes are actually comparable. There's no differences. There's no differences in stroke. And this is surprising because transcarotid patients are much sicker than transfemoral patients. And these outcomes are preserved out to 12 months in terms of survival and freedom from stroke and TIA, TC versus TF. So this is our experience up until December. We've done a little over 400 transcarotid patients. Procedural mortality is less than 1%. Procedural success, 97%. Stroke, TIA is 2.7%. And we're working on length of stay. That's a problem, 5 days. And I think at our institution, what happens is that these patients go down the cardiac surgery postoperative trajectory. So they tend to stay longer because of these ingrained kind of traditions that we have at our center, whereas obviously the TF patients go home the next day. So we're still working on that. It's suboptimal for now. Potential pitfalls, luckily these are rare, okay? Hematoma, now what I do is I leave a small caliber drain in. Vascular injury was early on in our experience. There were 11 patients, 7 requiring patch repair, 4 requiring a shortened position graft. These were all done after removing the introducer, so immediately kind of diagnosed. And you don't really need a vascular surgeon. Cardiac surgeons, most cardiac surgeons are comfortable with the common carotid, given that we do type A dissection repairs and things like that. So now what I do is I pre-dilate the artery with a 12 to 18 French dilator. And really, this is the important part. I clamp the carotid proximally and distally after withdrawing the delivery system in order to do an intima to intima repair. So you really want to repair this arteriotomy under direct vision and not just tie down a purse string or something like that. And I'll show you a video in a few slides. If you need to put an S329, that's not a problem. If the artery is borderline, you can use the commander system. That's rare, but you can use it via the carotid. Evolute is good too. You just pull back the inline sheath. We've done accurate neo. The introducer is a little bit long, but you can use the Cook introducer. That's not a problem. And obviously, commissural alignment is feasible by the transcarotid approach. Dysphonia and mouth droop were extremely rare. Luckily, in most cases, it was completely reversible. And for the surgeons in the room, I think the important thing is to open the carotid sheath, isolate the artery, avoid clamping the nerves around that area. And if you see bifurcation, you're too high, and there's a lot of kind of dangerous nerves in that area, so you want to be away from that area. So I think James Velianu presented a nice talk yesterday. Unfortunately, the case didn't turn out well. Dr. Mazilis from Thessaloniki, I think, presented a transcarotid case, which went very well. So why not just do transubclavian? I think, and I'm going to go out on a limb here, and I'm 7,000 kilometers away, so no one can kind of shout at me or anything like that. But the common carotid artery is a privileged vascular access. It's like the internal mammary artery when you have 3-vessel disease or you have peripheral vascular disease. The mammary is protected. We don't understand fully the mechanisms of that, but the common carotid, it's not the internal carotid, but the common carotid is a protected artery that God made it like that, and I don't know why. But it's got a low rate of severe tortuosity. You seldom see calcification in the mid-body of the common carotid. You can see it at the arch, at the origin. But if it's not stenotic, then I don't shy away from that. And small diameter common carotids are rare as well. There's no concerns of a patent limit LED graft. And I think in the morbidly obese patient, transcarotid access is excellent because even in our transcarotid cohort, 15% of patients had morbid obesity as their only indication to go transcarotid, meaning they had beautiful iliofemoral access, but a huge pannus, making, per close usage a little bit tricky. Is there a learning curve? I think this also reflects our early experience with TAVI in general, but I think in a high volume center doing TAVI, transcarotid learning curve is extremely favorable. In other words, 5 to 10 cases. So this is kind of our algorithm now at our center. Obviously, we do TF when we can. If TF isn't possible, then we do TC. In the extremely rare cases where TC isn't possible because of common carotid calcification or tortuosity, then we go to the subclavian. If there's an ipsilateral mammary or there's calcification or tortuosity of the axillary or subclavian, then we go transaortic. If there's a previous sternotomy or porcelain aorta, then we'll go transapical. And that's kind of how we go down the pathway with these alternative access patients. So I'll just show you a short video. I'll fast forward here because I know we're tight for time. The major problem with transcarotid is that it requires general anesthesia, okay? We don't do them under local anesthesia. I know some centers do. Cerebral SATs, this is the important part here, okay? This is a previous sternotomy because for previous bypass surgery. The incision is way down in the neck. So this is the sternal notch over here. It's way down. 2 to 3 centimeter incision is basically all you need. And then I'll just fast forward here to show you that the carotid, you find the triangle. Here's the omohyoid, sternocleidomastoid is over here. We don't see it very well, but the carotid, as you can tell, it's extremely superficial. Even in obese patients, it's actually not that deep. And here it's completely soft, despite the fact that the patient has an aorta bifem graft. And you can really, increase the working distance by pulling the artery out of the chest, get proximal and distal control. And I put a purse string in. I don't tie the purse string at the end of the case, but I use it for hemostasis purposes because sometimes there's a caliber change in the delivery system, and you don't want it bleeding around the introducer. So we put a purse string in, and then we do the TAVI as per usual. And here we use the S3 Certitude platform. I'll just fast forward here because these steps are pretty standard. And just to show you here, after removing the introducer, we clamp proximally and distally, and we really want to do an intima to intima repair. And this is to avoid kind of an invagination of the intima if you tie the purse string down, and you really don't want any residual stenosis or flow acceleration in the common carotid at the end of the case. So then what we do is we infiltrate the skin and the subcutaneous tissues with local anesthetic, and we leave a small caliber drain in. And that's the end of the case. This 2 to 3 centimeter incision, and that's it. So in summary, I think alternative access is necessary for any TAVI program, and I'm going to go the extra step and say, because I'm very far, so no one can get mad at me, but I think when we increased our alternative access, our vascular complications transfemorally went down. So the more safe alternative access, preferably non-transthoracic, that you do, the less vascular complications you have transfemorally. So that's what our experience has been. We see that among the available alternative routes, transcarotid is a safe vascular and effective access. The stroke rate is no different to that seen after TF. And despite the fact that these TC patients are extremely ill, and they're way sicker than the transfemoral patients. And the learning curve is definitely favorable. Σας ευχαριστώ πολύ. Θέλω να ευχαριστήσω τον Γρηγόρη τον Πατάκο και όλη την Επιτροπή και συγχαρητήρια για το συνέδριό σας που είναι μοναδικό στην Ομιλία. Ευχαριστώ πολύ.
Okay, so I think it's the time for case presentation. Dr. Sparias is ready. So I would like to invite the patient presentation will be done by Dr. Stathogiannis. That's okay. Dr. Katsianos.
Dr. Viziotti, thank you very much. I'm Kostas Sparias, if you're here. And the truth is that this is the second choice, the second access. It's a very local, preference issue. In our center, we are mostly into transaortic as a second access. But the presentations I had by Dr. Verianu and your presentation today, I think we would move to transcarotid. I'm very much convinced. The only fear, let's say, is the learning curve. You said that the learning curve is quite quick, right?
Yeah, no, definitely, especially if you have experience with transaortic, which is, it's a little bit tougher than a mini sternotomy. I don't know if you're doing a suprasternal incision or you're doing just a mini sternotomy to the right. But we found that there's so many contraindications to transaortic in terms of porcelain aorta, previous sternotomy. Sometimes the aorta is quite far, and you're limited in the platforms you can use. So Evolute is not. It's difficult to do. But if you have experience with transaortic and transapical, I think you'll find that transcarotid is actually super easy, and I think it's worth trying. I think it's worth seeing it, and I think you'll find if you have experience with alternative access that 5, 6, 7 cases is all it takes to feel extremely comfortable.
And it's a straight shot in almost all
Yeah,
anatomies.
definitely. I mean, 80% of the cases are from the left. Sometimes you have to go to the right. The right is a little bit more difficult, but it's a straight shot to the aortic annulus, and it's actually a lot of fun to do. To be honest, there's a few details in how you set up the room. You need like a long table that's perpendicularly oriented to the patient's left side, so it's a little bit difficult from the TF where all the wires kind of fall on the patient's legs. This time the wires are going perpendicularly on another table that's to the side, but I think it's very easy to set up. There's not a problem.
And I think this is also a surgical embolic protection by going in surgically your way, right? Because you protect that carotid from embolism, you clean it at the end.
Yeah, that's an excellent point. I mean, with Josep Rodez, we did a study for the transcarotid patients, and we did MRI in about 50 patients, and embolization is less than transfemoral, subclinical embolization. And interestingly, as you just mentioned, it's on the contralateral side. So it's not access related, it's valve deployment related, and the ipsilateral carotid that you're using is completely occluded by the introducer, so it's protected. So the strokes, even subclinical events and strokes that we found are they happen on the other side.
Excellent. Ευχαριστούμε πολύ.
Και εμείς και εγώ. Να είστε καλά. Καλή συνέχεια. Ευχαριστώ πολύ.
Do you use, for example, shockwave lithotripsy for severe femoral calcifications, or you directly go to the transcarotid?
We do not use shockwave lithotripsy. I mean, I would gladly see the data, but we do not use. If our threshold for going to carotid is quite low, to be honest, because vascular complications, I think, transfemorally are catastrophic, and so we actually go our threshold for doing transcarotid. In fact, you may not believe this, but 20% of our TAVI at our center is alternative access, mainly by the transcarotid. So it's 20%. We're 80-20 right now.
And one important point also for both subclavian and transcarotid approaches for the self-expandable platform is you cannot do cusp overlap technique in that angles, because the angles automatically change.
You can actually, by the transcarotid, you can do cusp alignment, but it's not the same. So, going in with the evolute at 6 o'clock, it doesn't, not at 6 o'clock, but at 3 o'clock doesn't work by transcarotid. You got to go more noon. But you can get the left views, and then, the double cusp view, and really align that valve. You can. It is doable.
Okay, thank you. Let's move on. We have another task now to complete this pre-recorded case within 10 minutes. So, Kyriakos, can you present the clinical background and history of this patient?
Hello, dear colleagues. I'm happy to present the next patient. If we could please see the next slide. So it's a 70-year-old male patient with a BMI of 23.6. As a title, we could have streptococcus endocarditis with 2-month hospitalization and IV antibiotic therapy. In the initial TE, we could see a possible vegetation on AVR leaflet and a moderate AR. Later, and after the IV antibiotic therapies and multiple positive blood cultures with streptococcus, then we had a smaller size of vegetation by 0.7 centimeters and severe AR with a pressure half time of 242 milliseconds, a hollow diastolic flow reversal, a mild MR and TR and the RVSP up to 70 millimeters of mercury. In the meanwhile, the blood cultures were sterile, and we had the green light from the infectiologist to proceed with the interventional therapy. At that stage, the patient was in NIHA stage 2 to 3, a BNP 314. Some words about the history of the patient, CAD with prior PCI to LAD, and RCA, CABATS back into 2016 with Lima to LAD. Just prior to the endocarditis, had a stress echo negative for ischemia, and the rest of the medical history, hypertonus and gout. Euroscore 4.3%, STS mortality 1.5%, STS morbidity and mortality 9.8%. We can see the parasternal long axis, the mobile structure through the aortic valve. I'll move a bit quickly. 1.5 centimeters at the beginning. We see the moderate AR. And then after the IV antibiotic therapy, we see a rest of this mobile structure through the aortic valve. We measured it was 0.7 centimeters. And we can see here the relevant regurgitation through the aortic valve, the dilated LV, a pressure half time of 242 milliseconds. Additionally, a mild MR and a TR with signs of definite signs of pulmonary hypertension. The coronary angiography, diffuse circumflex atherosclerosis, LAD is proximal occluded. We see also diffuse atherosclerosis in the right coronary artery. With the, here we see the Lima graft, which is open to the LAD. And now we can proceed with the image analysis by Dr. Kilic.
You can continue with your image analysis.
So I'm going to fast forward in favor of time. This is the CT of the patient.
This is 4D CT, so you could see the movement of the leaflets, and there is no calcium, basically. It's isolated aortic regurgitation post-endocarditis with vegetation that was much bigger earlier during the course of the antibiotic treatment, but now it's smaller, but it's still there. It's thinner and shorter. If we can go slower here, the dimensions. Can we go back? Back? Okay. Let it play. No, the previous one. Kyriako, the dimensions of the aortic annulus, the aortic anatomy.
Yeah.
Before.
It doesn't.
Before this. The previous.
It doesn't follow the.
Next. Stop it. Just stop it now.
Can we stop?
Can you stop this?
You have the slide the same?
Organizing committee and especially to Dr. Spargias for his kind invitation and hospitality to this important congress. And on behalf of the Turkish Society of Cardiology, I want to underline that we will strongly support these important events, and this event is very good structural meeting. Can you put my slides, please? Sorry, can you put my slides? Okay. So I'm not an imagist, I am an interventional cardiologist, but I want to underline that every interventional cardiologist must carefully look at the image of all patients. The present case has three important challenges for transcatheter aortic valve implantation. One, patient has recent history of infective endocarditis. And two, patient has a pure aortic regurgitation with large spherical annulus. And TAVI for pure aortic regurgitation is, we know that, very difficult and an off-label indication. But the patient had previous CABG, high STC and high Euro scores, and high-risk patient for radio surgery. Thus, TAVI may be a reasonable alternative therapy. And the presence of posterior wall calcifications in both common femoral arteries are also the other challenge for TAVI. The current literature mainly focuses on the risk of infective endocarditis following TAVI. However, the risk of development of infective endocarditis in patients waiting for TAVI or TAVI in patients with previous controlled infective endocarditis is not well studied. There is only 2 cases reported. In one case, TAVI was canceled due to the development of severe mitral regurgitation because of infective endocarditis, which caused anterior leaflet perforation, and the patient died. And the second case, emergent salvage valve-in-valve TAVI was performed in a patient developing cardiogenic shock due to the prosthetic aortic valve degeneration with free-flow aortic regurgitation, and patient survived. So when we look at the vegetation before antibiotherapy, it was 1.5 centimeter, and after antibiotherapy, it was regressed, and there was no oscillation vegetation during the procedure also. So how would I treat this patient? I will definitely do transcatheter aortic valve implantation in this patient. But when we look at carefully to the imaging analysis, the perimeter is 9.3 millimeter, but the area is, we made 3 different measurements. One measurement is from other guy, and the other, and I will also show the Dr. Sparks' guest team's measurements. We measured area first with the trematio is 639.4 millimeters square, and area derived annulus was 28.5. And yesterday we discussed that it's a cutoff point for the usage of the largest balloon expandable valve of Edwards valve, and so over 29 millimeter valve, it is not recommended to do balloon expandable valve, or oversized valve. We will discuss also. And the second measurement also, I used both Osiris and other programs, and area derived annulus was found as 29 millimeter. And when we look at the Dr. Spargus' team, they also measured area derived annulus as 29 millimeter. So TAVI in a case of pure aortic regurgitation and spherical annulus is very, very hard, because when we look at the aortic stenosis annulus, it's an elliptical annulus, but aortic regurgitation annulus is spherical annulus. So there are some platforms, all we know, self-expandable valves. We can, for example, use Evolut R, Jena valve, G valve, Acrytis Sematis, and the balloon expandable valve, Edwards S3, and Merrill My valve. But when we look at the area annulus, we cannot use, for example, 34 millimeter Evolut R in this patient, because there's no calcification. There will be tendency to do pop out into the left ventricle. This means higher pacemaker raise or severe aortic regurgitation. There are a lot of cases like this. And Jena valve may be in mind, but when we carefully look at the sizes of the transfemoral Jena valve, it's an investigational device, and the largest size corresponding annulus diameter is 27 millimeter. And maybe accurate estimates, but the largest size when you look at to the annulus size, it's only 27 millimeter. So we can do either upsize, oversize the S3 valve, but when we look at the oversizing chart yesterday, we also discussed this point. When you inflate and oversize, there can be risk of annular rupture. So my valve is a different and a new valve, and when we look at the MyVal valve, it's a hybrid honeycomb cell design concept, and the most important attractive part of the MyVal is also the intermediate size. When we look at the oversized diameters, you can use 30.5 millimeter or 32 millimeter valve in area like 800 millimeter square. And when we look at the detailed sizing guide, you can either select an intermediate size, large size, or small size, and with a great variation. So when we look at the cases, one case was Professor Halleck from Sunning Hospital. Area derived annulus was over 800, and they put a 32 millimeter valve and another 32 millimeter valve. And valve in valve, my valve, you can see in a 32 millimeter valve, and another oversizing 32 millimeter valve in a patient with annulus area 900 diameters. There are some difference between S3 and balloon expandable MyVal valve. MyVal is directly mounted on balloon similar to a standard insert into the introducer sheath, just deliver an implant. But the most attractive part is the intermediate size for me. And when we look at the femoral arteries of this patient also, you can see in the dimmed background views, there are posterior valve calcifications. So how would I treat this patient? I will definitely do TAVI. I will use a 30.5 MyVal size. I will use a contralateral safety guide wire, and I will use a cerebral protection device. Thank you for your attention.
Thank you. And I think now is the time to start the video, please. And I will turn to my right side and ask Dr. Labropoulos, having seen all this data of this patient, what would his choice would be?
Yes, thank you very much. Thank you very much for your for all information and the cases. The case is very interesting. We see that the patient is high risk for surgery. We see also that we have a severe AR, so we need to have intervention in this patient. I agree that the right choice is to put a TAVI or a valve in the aortic position. My first choice is to see the, this is wrong.
Guys, this is the wrong video. Okay, this is the wrong video. So this is the... Sorry about this. This is the last case, the case 13. Okay, till you find the video, please carry on.
Okay, so we need to have intervention in this patient. Surgery is high risk. So we need to have a valve for severe AR. We have the Jenna valve, as you said, we have the J valve, but we don't have sizes for this patient. So we need to continue off-label in another valve. We don't have much calcification in aortic annulus, so I think one of the balloon expandable valves is suitable for this patient.
Since we have a lot of surgeons here, would any of you would rather operate on this patient instead of doing TAVI?
guy is certainly an increased risk. He's had a previous coronary, he's got a lot of other stuff going on. But he's only 70, and we all know 70 is the prime of life when a man hits his peak. At least to me, that's a young guy. He's had a previous bypass, but the rest of his arteries look okay. His heart looks okay. Typically, endocarditis, unless I can't operate on him, we're going to operate on him because the risk of this coming back and in the my valve is still pretty high. It's really hard to totally eradicate this. That being said, if I looked at him and he looked like a bad candidate, then yeah, this is what I'd do. And if it came back, then I'd operate on him then and take out the my valve, take out the native valve, and put in a surgical valve. But you got to see somebody before you decide if you're really going to operate on him.
Yeah, the truth is that he could go for operation. I don't see any problem, and the lima is patent, and it's not in the middle of the sternum, so it's a bit lateral. So I think surgery will be a perfectly good therapy for him, but his preference also played a very important role. So,
but everybody's preference is to not be operated on. You have to start with the fact nobody wants you to operate on them. And sometimes you have to explain to them why an operation is better. And if you explain to them that there's a pretty good chance that this valve I put in you is going to get reinfected, then it sometimes helps them understand, because the real key with endocarditis is getting rid of all the infection. Not what kind of valve you put in, it's getting rid of all the infection.
So, Dr. Abropoulos, you see there is a surgeon who is very willing to take on this patient.
This is a good option.
Well, again, I haven't seen the patient, and again, if the patient looked like a high risk, then we might not operate. But again, nobody wants you to operate on them. Nobody. But there's some people that it's just you need to explain to them why surgery is still the better option. Now, I haven't. He doesn't have an annular abscess or some of the other things that would just absolutely preclude a TAVR. But there is a high risk of this valve getting reinfected.
At least we're sure about this from our infectious people. We are now at least 4 months after the end of the antibiotic treatment, and the patient was clean. And the patient was symptomatic and was getting more and more symptomatic. So it wasn't just an asymptomatic aortic regurgitation, and he delayed any treatment for a long time, hoping that the problem will just go away, disappear. But it didn't. And then I think what played a major role was that his experience from the first operation was not very good. So it was a very complex, long post-operative course after the bypass operation that he had in the past. And I think this played a major role in his decision to rather have TAVI. But we discussed with him very thoroughly the options, and also our recommendation was to have an operation.
Yeah, and there's a lot of reasons. I have people come to me that have had a bad first operation, and I understand that. I have somebody like this who's taking care of a debilitated wife and has to get back to taking care of their wife. I mean, there's a lot of subtle reasons to not operate that sometimes you don't see in a presentation.
Is this the right video? Okay, good. Good to see the right video. So it's not clipping, it's a valve. So in this case, that was the reasoning and the rationale behind, and you can see also Dr. Kill is behind us. He was proctoring our first MyValve case. So clearly, the sizing of this valve and the complete lack of calcium was the major reason that we decided to go with an extra large MyValve. I think when you go with a self-expanding valve, you need to have an oversizing of at least like 20–25% in typical aortic stenosis. So when you don't have aortic stenosis, but just a pure regurgitation with no calcium, probably with a self-expanding valve, you need to have a 30–40% oversizing, and a 34 evolutar, which is the largest self-expanding valve, would have a higher risk of moving up, of needing a second valve, or of having PVL. And then for the sapien valve, as Dr. Kelly said, even if you overdilate it, the maximum, it will be impossible to achieve any oversizing. So probably with a balloon expandable valve, it's okay to implant with zero oversizing in aortic stenosis with calcium, but it's not okay to implant it with zero oversizing in pure aortic resuscitation with no calcium. So, Dr. Kilis, you want to just describe the procedure since you're much more familiar, although it's
No, you can go
straightforward.
Straightforward, please.
It's a straightforward.
I think you put a safari guide wire in the left ventricle, and you prefer to use the safari guide wire. And different from the sapien valve, as you know, my valve is mounted on the balloon, crimped on the balloon, so you can easily go without balloon loading in the descending aorta, or
So-
in any case that you cannot pass through for example, the aortic valve, like bicuspid heart anatomy, you can pull back the valve inside the sheath also.
My comment is that it has the flex feature of the Sapiens commander system, but it doesn't have the pusher of the commander system. If you notice, it's just the pusher is much smaller than the commander system pusher. So the valve is directly crimped on the balloon and not pre-crimped on the back of the balloon and then pulling the balloon back. So you don't have to do this alignment with this valve. And the advancement is straightforward. The sheath, it's very similar to the E-sheath, we know. And then the flexing in the aortic arch is easy. I don't know if the lack of the commander pusher has ever created problems to advance this valve through a very calcified aortic valve.
No.
Because in this case, with no calcium, it was very easy to go through.
We saw no problems. And another advantage is, for example, if you cannot pass through the valve, you can pull back the sheath and pull back the valve into the sheath. So it's a partial recapturable property.
So otherwise, the length of this device, of this valve, when it's expanded, I think it's 22 millimeters, right, for this size. And the positioning is similar to the sapien because the alignment of the cells is very similar. So the foreshortening of these valves also occurs from below because there are the smaller cells and the multiple lines of them. And of course, because there is no calcium, in this case, we need to be very careful in the positioning, and we wanted to have the largest part of the frame above the annulus, and also to give some flaring of the valve above the annulus because aortic regurgitation, and you don't want to have your valve moving back into the ventricle. So this is the extra large valve that has a diameter of 30.5 millimeters, and the oversizing was about 20% for the balloon expandable valve. And this is because of the lack of calcium.
Just a little bit different from the S3 valve. You can see the second dense marker on the MyVol valve, but since Dr. Spargios is very experienced on balloon expandable valves, normally he puts just the pigtail to the marker, but second dense marker in the middle of the dense marker on the annulus, at the annulus level.
So I think the edit is not correct here because you see a lot of fast pacing from earlier that it wasn't there in fluoroscopy. So this is the fast pacing and the inflation of the device. We kept the pigtail down because the anatomy was huge. And this is the inflation of the device. The patient went into VF, if I remember correctly. Yes, and we defibrillated the patient because it was a longer than usual fast pacing. We wanted to take the blood pressure really as low as possible so we don't have movement of the device. So this is after defibrillation, and the blood pressure recovers slowly. Can we move fast forward, please? And now you see the effect of the inotropes, the anesthesiologist is administered to the patient, and the blood pressure now is very high. And let's see, oh, we need to go. This is a problem with the fast forward. You miss the most important points. Do we have a autogram here now to see the final result? I think you have to go backwards. Can we go backwards to see the autogram? Okay, it should be somewhere here. Yeah, just let it play here and we'll see the autogram anytime now. Anyway, the autogram was zero regurgitation, if I can describe it.
And one important point also.
And you see the diastolic pressure also, that is very good.
Yes.
Can we find the point of the autogram just to see where is our frame within the aortic root? Okay, I think we're out of luck to find that point. In
yes,
the video here it was. Just immediately after that. So yes, it should be here. Yes. So you see we have like an 80% above, 20% below the annulus with no paravalvular leak and with the wire still into the valve. And I think we should stop here and just go to the presentation of the CT scan that we obtained 2 days after, before discharge, the pre-discharge CT scan, just to see the positioning of the frame of this valve into the aortic root. Okay, can we move the slide on? Next slide, please. Yes. So you see here that the valve frame goes almost at the level of the origins of the left mainstem and the right coronary artery, and we know from the pre-procedure planning CT scan that is very high. Because there's no calcium, it's difficult to find exactly where is the annulus, but we make the comparisons to, oh yes, this is very nice. So there was no movement of the valve backwards into the LVOT. It was in the intended position and working very well. And with this, I would like to thank you, and I would like to ask Professor Vardas and Professor Dangas to come over the podium and to go for the key lectures. Thank you.
Okay, great. So, dear colleagues, we have to move on. We have already a bit delayed. And I am very pleased to co-chair this session with Professor Danges from Mount Sinai, New York, and to introduce two important key lectures. The first one will be presented by Professor Riordan from Texas Methodist Hospital. Professor Riordan is really extremely known specialist, and I'm sure that his presentation is going to be a very good opportunity for us to learn. Professor Riordan.
Well, thank you very much. I know we're way behind, so I'm going to fly through some of this, particularly the where we stand stuff. My conflicts of interest have not changed since yesterday. We already talked about this. High risk was already done. The primary endpoint of all-cause mortality, TAVR is either non-inferior or superior. We went to intermediate risk, primary endpoint of all-cause mortality, disabling stroke, both studies, non-inferior. We went to low risk, either non-inferior or superior, depending if you had a 3-point or a dual endpoint. That got it improved. In the U.S., this is what's happening. That orange line is TAVR rising up. The blue line at the top is all aortic valve procedures. This only goes up to 2020. If we got to 2023, we're probably going to do 93,000 TAVRs in the U.S., so it's going to continue to grow. But we do need to know what the differences were in the two trials. The one difference was there's pacemakers. There were more pacemakers statistically in the self-expanding trial than there was in the balloon expandable trial. Although I went back and looked at this, and what I found was the more you did, the lower your pacemaker went. This is Jaime Delgado, who was my lead implanter. He had a pacemaker rate of 1.9%. My pacemaker rate was 6.5%. And it's really not about the valve. It's all how you implant the valve. We were implanting them in the coplanar, which always gave you a bad impression of how deep you were. As soon as we went over to the double cusp overlap, we were able to land these more accurately, and the pacemaker rate went down. In fact, in the TVT registry, at the last quarter that we have for the self-expanding valve, the pacemaker rate is 8.5%. I really want to see mine. I follow mine quarter to quarter between 6 and 8%. I really am looking to try to get it down to the 5 to 6%. The other difference was HALT. Both these trials had a core lab for CTs. The same core lab, Vancouver, Philip Blanque, and Jonathan Leipzig, and they looked at HALT of 50% or more, and what they found is that in the Evolute trial, there was more HALT in surgery than it was in TAVR. The other way around, there was more HALT in the balloon expandable TAVR than there was in surgery. Not a surprise. The difference between the valves is a self-expanding is porcine pericardium. The balloon expandable is bovine pericardium. Every bovine pericardium out there has more HALT because it's a thicker material and it opens and closes slower. Now, you saw the one-year data for the partner trial, but what you notice is the primary endpoint is now the delta is starting to narrow between 1 and 2 years. In fact, if you look at death, it's narrowed even more, and stroke, it's narrowed even more. Now, if you remember the partner 2A intermediate trial, the lines crossed at 3 years. We'll get the 5-year data from partner this year. Hopefully, the lines won't cross in that trial. This is the 2-year data for all-cause mortality or stroke in the Evolute low-risk trial. The initial advantage of TAVR does not go away, and in fact, it doesn't go away for death or stroke. In fact, we presented the 3-year data this year. John Forrest presented this. We published this in JACC, and what you see is the delta at 30 days and 1 year was 1.8%. It went up to 2 in favor of TAVR at 2 years and went up to 2.9 at 3 years. So this is pretty encouraging data for where we stand right now, at least for this valve. The early advantage is actually widening out rather than going the other direction. And this was largely led by a mortality benefit in TAVR. We know what we have in the U.S., 65 or below surgery, 80 or below TAVR, 65 to 80 physiologic risk of surgery, anatomic risk of TAVR, and what the patients want. We know in Europe that it's 75, over 75 TAVR, less than 75 and low risk, they still recommend surgery. But who wasn't tested in the randomized trials? Where we stand is very important. Randomized trials are the best data we have, but they only apply to populations similar to the ones that were tested. So who was excluded? Bicuspid valve, significant coronary disease, unfavorable anatomy, associated procedures, and anybody appropriate for mechanical valve. We've already eliminated about half the people that I see as a surgeon that are below 75 years of age. We use the Sievers classification based on the number of raphe, either 0, 1, or 2. The most common is Sievers 1, left, right. That's about 80% of what I see. And they're pretty common. I was taught by Dr. Cooley a long time ago that bicuspids were young people that came in, but people 80 and above, 20% are bicuspids. By the time we get down to the 60 and 70, half these people we see are going to be bicuspid valves. Now, Yoon and McCarr at Cedars have done a lot of work to show us who can and cannot be treated. And what they've shown us is if you don't have much calcium, you do okay. If you just have a calcified raphe, another leaflet's okay, or a calcified opposite leaflet and not a calcified raphe, you do okay. But if you have a heavily calcified raphe and a heavy calcified opposite leaflet, you will not do well with TAVR in the majority of cases. Now, we ran a low-risk bicuspid trial. John Forrest was the PI in this. I served as the study chair. And what we found is that we actually got very good hemodynamics with EOAs over 2 single-digit gradients and no PVL above mild. We took this out to a year. The hemodynamics stayed up. And again, the PVL was actually better in the bicuspid valves than they were in the tricuspid valves. And we tried not to screen out anybody based on the anatomy of their bicuspid valve. So we are treating bicuspid valves now, but when you look at much of the data, particularly things that come from like the TVT registry in the US, remember, these are heavily screened patients. These are not all comers at all. How about less than 65, which is where the US cutoff is? Well, there's only 7% less than 65 in the partner trial and only 6% in the Evolut trial, and only 1.3 were less than 60. If you were less than 65, I ran the screening committee. You didn't get in unless there was something a little bit different about you. You weren't healthy 65-year-olds. We screened those out. So when people come into you and they're 65 years old and they look great, they're out there running, and they tell you they want a TAVR, you're going to have to tell them, we really don't know what people like you are going to do over the long haul. We didn't test people like you. Well, how about anatomy? Anatomy too big or too small? Bicuspid valves, if it's too big or too small, that's it. Bicuspid valves we talked about. But excessive LVOT calcium. What is excessive LVOT calcium? Jeff Pobb and I talked about this and talked about it. There's an old saying in the US about the Supreme Court when the first laws came up on pornography is that the Supreme Court justice said, I can't define it, but I know it when I see it. And LVOT calcium is kind of like that. It's hard to define, but you know it when you see it. We tried to define it as 10 millimeters long and 4 millimeters into the LVOT. So how many of those were screened out? Remember, in these randomized trials, your local art team, your local experts saw these patients, and they attest that they met the inclusion criteria, they had no exclusion criteria, and their anatomy was good both for surgery or the valve that we were tested. So one would think that when we send them up to a national screening committee, virtually everybody would be accepted because local experts have already approved them. Not so. In the partner trial, 34% of the people that were deemed okay locally and sent up to the national experts were excluded from the trial. So if you're taking 1/3 of the patients that locally are going to want to be treated and exclude them out, clearly it's not an all-comers, even with all the other things we've said. In Evolut, it was 14.8%. So again, there's a lot of screening of these patients. How about significant coronary disease? The low-risk partner protocol said you couldn't treat people with a syntax over 32. That makes sense. Those people probably should all be going to surgery. We said in Evolut over 22%. In the Evolut trial, we actually had an arm for people that needed revascularization. So what was the mean syntax in the arm that needed revascularization? 7. That is not severe coronary disease. We did not treat anybody with severe coronary disease, and that's not going to show you any mortality. So when somebody comes to you with a aortic stenosis and 3-vessel disease and says, well, I'm low risk, it's already been approved, you have to say, we didn't look at anybody that looked even remotely like you in the trials. So how about structural valve dysfunction? Well, we use David Capodanno's definition. There's 4 buckets. There's structural, something wrong with the valve, non-structural, something wrong around the valve, thrombosis and endocarditis. And we've seen that surgical valves fail at different rates. We wrote our first paper on trifecta failures back in 2017. It's been validated by multiple studies. And valves structural holding up has to do with both valve design and tissue science. And all these valves are designed a little bit different, surgical valves and TAVR valves. Now, we have a bunch of 5-year data on the randomized TAVR trials, but remember, the high risk, the mean age was 84. They're going to die before their valves wear out. The mean age of intermediate was 81. They're going to die before their valves wear out. Low risk is 73.5 to 74. We may learn something about low risk as we follow both intermediate and low risk for 10 years. Now, we have followed the NOTION trial, which is the original core valve trial in the Nordic countries, out for 8 years, and it looks pretty good. The last patient in NOTION passed 10 years this April. So sometime this year, I hope we're going to get the 10-year data from NOTION. And that's going to be the first really 10-year randomized data we have. Now, we looked at this, and we looked at structural valve deterioration in the high risk and intermediate risk because there really wasn't much data out there. You saw this earlier. In the PARTNER 2, the randomized XT had more structural valve deterioration than surgery. The non-randomized S3 did not have it when you look at it this way, but if you read the paper carefully and go through it, when they did some propensity matching and case weighting, actually S3 had more structural valve deterioration statistically in year 4 and 5. That's buried at the bottom of the supplement. You don't usually see that up on top. And we'd had some preliminary data that we may have less structural valve deterioration, so we then ran this study to try to look at the 5-year incidence, outcomes, and predictors of hemodynamic structural valve deterioration and the association with outcomes and predictors. So the way we did this, and this is pretty important, is we took the randomized arms of high risk and intermediate risk, which was over 2,000 patients, and used randomized patients to look at the rate of structural valve deterioration between surgery and TAVR. Then we took the continued access, which was non-randomized, and added those in. So now we're over at 4,700, used the non-randomized only to look at the clinical outcomes and the predictors. And the definition we used for moderate or greater was an increase of 10 millimeters or more from your discharge echo or 30-day echo to your current echo, and a final of 20 or more. And all these were seen by J.O. in the Mayo Core Lab. And in fact, I sat down with Steve Yakubov and Kendra Grubb, and we went over every single one of these before we published the paper. And we found at 5 years, there was statistically more structural valve deterioration in surgery than there was in TAVR. And this is really the first time we ever saw this, and this was actually somewhat shocking at ACC because people didn't expect this. And we used to, surgeons, I used to tell everybody, well, you should have surgery because I have the durability data. This is the first time that suggested I may not have the durability data, that may be going another way. And we looked at small annuluses, 23 or less by CT, and the difference for TAVR got even greater, which is really not a surprise if I spend some time talking about the hemodynamics of self-expanding valves. And for 23 or more, numerically it went towards TAVR, it trended, but it didn't reach statistical significance. But this is the money slide. If you develop moderate or greater structural valve deterioration, whether you had surgery or TAVR, it doubled your risk of all-cause mortality. It doubled your risk of cardiovascular mortality. It doubled your risk of being rehospitalized for aortic valve intervention or heart failure. This is a serious problem. Even moderate really increases your patient's risk. Now, who did not get structural valve deterioration? Men, older people, and people with AFib or people with a prior PCI. So why is it? Why do men get less structural valve deterioration than women? Are they because they're tougher than women? You don't say that at my house, you get in a lot of trouble. No, men are bigger than women. They get bigger valves. They start with a bigger EOA. And if you start with a bigger OA, it takes longer before you get structural valve deterioration. Older, we've known for decades in surgery, the older you are, the slower these biologic valves degenerate. AFib and PCI, it's really hard to say. I don't know if it's the anticoagulation or if these are both markers of heart disease and death is a bigger competing factor. And the people that got it more often were people that had large body surface area. Steve Yakubov did the same thing for total valve dysfunction, which included all 4 of those buckets. Still, more total valve dysfunction in surgery than in TAVR, and it's driven by structural valve deterioration and more severe patient prosthetic mismatch. And again, the hazard ratio for all-cause mortality, cardiovascular mortality, and rehospitalization was higher. Not quite as high, but higher if you got this than if you didn't get it. So now I'm going to shift a little bit because that's the stuff we talked about yesterday about where we stand. Where are we going? This is George Strain's work from Australia. What they have is they have a national database of echoes that has over almost 240,000 patients in it. And they divided everybody up into no AS, mild AS, moderate AS, and severe AS. And then they looked at it going up at velocities of 0.5 meter per second steps and looked at survival in their national database. And guess what? If you have mild aortic stenosis, it increases your risk of dying. If you have moderate, it increases it more. And if you have severe, it increases more. Any level of aortic stenosis is bad for you. We don't operate on mild, because what we do to them gives them another problem, but it's not good for you. Any level of aortic stenosis hurts your heart and increases your mortality. And that's led to a couple things. It's led to look us now in the randomized trials for TAVR with moderate AS and symptoms, because if any level is hurting you and you have symptoms, maybe we should treat that. So we have the UNLOAD trial and the PROGRESS trial. We're going to be getting the data from those over the next year or so. And we're going to find out, are we going to expand our indications for TAVR to moderate with symptoms? I suspect we will when we see the data. We also have looked at people that are asymptomatic with moderate AS, and we've looked at where they fall in Phil Genero's stages of heart failure. Stage 1, just the LV. Stage 2, it's getting to the left atrium. Stage 3, it's getting back into the lungs. And stage 4, you got a bad RV. By the time you get to stage 4, it's too late. So if you start getting down that thing and you only have moderate, we probably ought to fix you because you're going to get in trouble. Asymptomatic severe aortic stenosis. We have 2 trials, the early trial and the evolved trial. We have some data in surgery. I don't have it in here, but there's been several surgical trials randomizing asymptomatic severe aortic stenosis between medical therapy and surgery. And guess what? If you get early surgery, you live longer. Asymptomatic severe aortic stenosis is not good for you. Well, if you can do that with surgery, I suspect we'll do even better with TAVR because you won't have the physiologic insult to surgery. We've moved into AI. The JenaValve is available here in Europe. It's not available. We just finished the ALIGN trial in the US as part of that. And the J-valve, which is a Chinese valve, we're starting the EFS this year in that. So we are going to have some dedicated valves for AI, and we'll expand the indications a little bit further. So how about when the TAVR valves fail? I think this is something that's really important because you have 2 options. You can take it out and put a surgical valve in, or you can do a TAVR and TAVR. So how about the explant? We have a lot of data that shows if you do the explant and then do a surgical valve, the mortality is pretty high, 10 to 13%. But these earlier studies looked at all explants, and about half of them are for endocarditis. So we went back with Gilbert Tang, and we did the same thing, but we just eliminated everything endocarditis and just looked at those that have a TAVR explant and a redo surgery because they had a valve that degenerated. And what we see is that TAVR explant versus redo TAVR, TAVR and TAVR versus explant and surgery are both rising and rising fairly rapidly. But what we also see is if you get a TAVR and TAVR, your mortality is a whole lot less than you get with an explant and surgery. Now, part of this may be due to the fact that the mean number of TAVR explants done by surgeons in this trial was 1. Most surgeons had done 1 of these, and a lot of them are surgeons that weren't TAVR surgeons, and they got in there, they didn't even know what the TAVR valve really looked like. They're just going to take it out. And I always tell surgeons, remember your first redo aortic valve is probably a lot harder than now you've done 200 of them. I think surgeons are going to have to learn this because we're going to see this because about half the ones that are sent to me for TAVR and TAVR really aren't good candidates because either they have patient prosthetic mismatch to begin with or they have risk of coronary occlusion, which carries a 50% mortality. So do we need to evolve? That was one of my questions. Of course we do. We need a randomized bicuspid trial. It's hard to get one because you got to get somebody to pay for it, and nobody in the industry wants to pay for it. They just want us to treat them. We need more knowledge about coronary artery disease in TAVR. We just don't have good knowledge yet. TAVR devices for AI are improving. Our trials for moderate and asymptomatic AS are ongoing. We're going to get that data pretty soon. We need longer-term durability data. We have the 10-year data coming up from Notion. Both the partner intermediate and low risk and the Evolut intermediate and low risk are going to be followed for 10 years. That's going to give us some good data. We need commissure alignment. We can do that with all the self-expanding valves. The SAPIEN 4 is planned for that. That's on hold right now, but hopefully that'll come back. And new devices will continue to improve. This is what we've done in 20 short years, which for somebody who's been doing this for 40 years doesn't seem that long. The next 20 years are going to be really busy. I wish I could be around and working to see it all because I think it's all going to be great. Thank you very much.
Great. So just I kept also very much the last sentence that we have made a lot so far, the last 20 years, but we have to make more in the next 20 years. Is anybody who likes to have 1 or 2 questions here? Yes, please. Dr. Harris. Yes, it's a really very good opportunity.
Thank you very much for this very interesting discussion. My question is, should we consider the anatomic criteria that we use for self-expanding valves? Right now that we look at the sinus of Valsalva, the STJ, the lengths, and so on, and based on that we decide. Should we also add to this, especially in individuals who are, say, less than 80 years old, less than 75, some markers for future valve-in-valve, whether they're going to be able to get one?
Yeah, so I think that's something that's worth considering, but it shouldn't be your first consideration. There's a saying in surgery that the first cut is the deepest, and it means that you should do the right thing on the first operation because that's your best chance to do it. So, you know, in the U.S., I have 2 valves that are approved for all risks, the SAPIEN and the Evolut. Which one has superior hemodynamics? The Evolut. That affects your patient each and every day. Which one's the only one that shows superior durability compared to surgery? The Evolut. That affects your patient each and every day of their life. Now, somewhere in the future, they may get coronary disease. They may not. They may get a valve-in-valve, or they may not. And so if all things are equal, then those are the things you think about. So if I have somebody that I can put a 29 SAPIEN in that's going to give me a better chance, then yes. But if you have a man that looks like they're going to get a 23, then no. That patient's going to live with
with bad hemodynamics for every day of their life. Yes.
I understand what you say about everyday life and so on, but if I'm a patient and I get a valve and I know that in the future I might need a valve-in-valve, I should know if this valve that I have implanted, it will be feasible to do VIV.
So are you going to tell them that the valve you're going to put in that's better for the valve-in-valve may wear out faster and has worse hemodynamics, and that may lead to them having doubling a risk of mortality?
Well, I don't know. Professor Eden, is answering in a little bit tangential way in that any valve can receive a valve-in-valve, particularly if it's big. So the answer, he said it before also, is that you involve, you implant the biggest valve possible. Or surgically, you have to also place the biggest valve possible, because that's what matters. And, it's not something, as cardiologists, we don't know, even from the time of the stents and angioplasty. Bigger is better. I guess bigger is better for the valves. And I don't know there is any technical limitation to put a second valve in regarding the type of initial valve, self-expanding or balloon expandable. I can tell you that if the initial valve is big, the second valve is also more feasible. No?
Well, again, I'd also say it depends on what particular valve you're going to get in. So, if you have a man that could either get a 34 Evolute or a 29 Sapien, it probably matters very little, but if you have a man that you think you're going to put a 23 Estri in, that's going to be problematic unless you're dealing with a little tiny guy.
Yeah, that's right. So, that's what we try to match a little bit the... I wonder, and I guess there was always this question, the echo now, they give all the reports, give this index valve area, and we always read that. I'm not sure we evaluate it as much as we should. Yeah. They give a valve area, and then they give an index valve area. Yeah. And I don't know that it goes so, I don't know that it is so much clinically important information yet, although I tend to think that it should be.
Well, I'm a big believer in Doppler velocity index. As we all know, getting measuring the LVOT and getting an index DOA is fraught with measurement errors. Now, you can make measurement errors, of course, as you get your envelopes when you do your Doppler velocity index, but I think that's a lot less. But that gets indexed already to that patient's flow rate, because it's flow above and flow below based on the continuity equation, and it's indexed to that patient's size, because what it does is it gives you a ratio of that patient's EOA to that individual patient's LVOT. So when you look at Becky Hahn's charts that she generated, you'll notice that the EOA for the partner valves from 20 to 29, the DVI is the same. And you look at the Evolute, and the DVI from the small valve, the 23 to 34, is the same. Because it's a ratio, and big people getting a 34 valve usually have big LVOTs. So DVI doesn't tell you what the EOA is, it just tells you what the ratio is of your aortic valve area to your LVOT. And it eliminates measuring the LVOT.
I agree with you, Dr. Dagas. We have the same problem with surgical aortic valves. Yeah. Many times we have small valves, and when we need to implant a TAVI, this is a major problem.
Yeah. So again, I'll bring you back to that echo, the echo of George Strange from Australia. What it should show you is that any level of valve disease is bad for you. The question is it bad enough that we're going to replace it with something else? Right. None of us would, if we asked you, who wants mild aortic stenosis versus a normal valve? Nobody hand goes up. Nobody. Even though it's not going to kill you, nobody wants it. Right. You know it's not a good thing.
Right. No, and the correction, all these formulas now, the velocity, everything corrects for BSA. Yeah. There's another theory, of course, correct for BMI. Yeah. Do you have any idea about that? Any opinion?
So I think that there are corrections for body surface area are a way to make ourselves feel better, that we have less PVL versus really helping the patients. I think that's to me, kind of problematic. I don't think that those things really help us at all.
So you think the BMI is a better?
I think either one of them.
Measure of.
I wouldn't correct for either one of them. What I will say is you remember everybody says less than 0.65 centimeters square per meter squared is severe. 0.65 to 0.85 is moderate. That came from a study by Philip Peabrow with 68 patients in it. 68 patients is what we use, and Now, we did 1,200 patients in the Paragon trial with the Valus valve, and what we showed was that the smaller the EOA, the higher the gradient, but there weren't these curves that Pibro showed. You get enough patients, and it starts to smooth out. And so the smaller your opening, the worse you're going to. Now, remember, of course, gradient's related to flows. If you normalized all the flows, that would take care of things.
No.
Great, thank you very much, sir.
Great.
Thank you very much indeed.
Well, Houston is a hallmark of cardiac surgery, but Texas is bigger than Houston. There's another hallmark of cardiac surgery just around the corner, and that's where else? Dallas, Texas. And we have the past president of the Society of Thoracic Surgery and a leader of the American College of Cardiology, a board member, Dr. Michael Mack from Bellows Scott and White Health, Dallas, Texas, give us another futuristic view, bird's eye view of the transcatheter field directions. Michael, thank you so much for joining in live transmission for this session. Thank you.
Well, thank you very much, George, and appreciate you having me. And now you'll hear from the other Michael from Texas. Can you see my slides okay, George?
Absolutely. Go right ahead.
Okay. So this is my conflict of interest disclosure. I've been involved with a number of trials in the structural heart space. So the outline of this 15-minute talk will be 5 minutes on aortic valve, 5 minutes on mitral, and 5 minutes on tricuspid of where this field is going. So, you know, it seems like transcatheter valve or TAVI has been a tsunami that's overtaken the field in the last decade, but it's actually been 35 years since the original valve to the current valves that we use today. And to me, this is like lightning striking. It's been the most impactful change in any therapy that I've seen in my career. And I would say one of the reasons that the adoption has been so great is because of the strong evidence base that has been generated here. And Mike Reardon just took you through all the evidence that has led to a robust evidence base that has changed clinical practice. Now, in addition to the randomized trials, every patient in the United States is captured in the TVT registry. So we have outcomes on over 400,000 TAVR procedures. And as you can see, it's in the decade since the approval, we have gone from 252 sites in the United States performing TAVR to now over 813 sites. A threefold increase, and you can see there's about 1,000 TAVR or SAVR sites in the United States. So about 4 out of every 5 sites in the United States has a TAVR program. If we look at the annual volume, it has gone from 4,000 to 87,000, a 20 times increase in the last decade. And you saw this slide from Mike that he highlighted that in 2020, there were 82,000. You can see that the number of all surgical valves has decreased to 50,000 and isolated aortic valve replacement, 15,000. So that means that 85% of all isolated aortic valve replacement is now TAVR. But the good news is that 30% more patients with aortic stenosis have been treated over the last decade than were treated in the previous decade. So the remaining questions, and Mike touched on this, is the lifetime management of valvular heart disease, and specifically bicuspid aortic valve patients, young patients in which durability has yet to be determined, procedure sequence, if a patient is facing 3 procedures in their lifetime, where does surgery fall into there? And then the issue of TAVR explant and TAV and TAV, which is an emerging area, as Mike alluded to. And then expanded treatment into asymptomatic, less severe, and then increased methods for screening and detection. And lastly, medical therapy to slow aortic stenosis. So for asymptomatic, as Mike said, we have the early TAVR trial, and moderate, the Progress AS trial. We are doing a study right now called the Preview Trial, in which we really don't know what the true prevalence of valvular heart disease is in the population. It looks like patients over 65 years old, there is probably about a 9 to 10% incidence of significant valvular heart disease, about third aortic, a third mitral, and a third tricuspid. We're also seeing if we can diagnose aortic stenosis earlier, and specific using AI for EKG interpretation is a burgeoning field at the current time. And then lastly, can we slow progression of aortic stenosis with medical therapy, and specifically using such classes of drugs as PCSK9 inhibitors? So regarding my summary thoughts on TAVR, to be able to experience the treatment transformation in less than 2 decades has been truly remarkable. I think that surgery is not going away, and it'll be the same ratio as PCI and CABG, that 3 out of 4 patients with aortic stenosis will be treated with TAVR. Although TAVR seems the right answer for everything right now, there will be disappointments that come up, and TAVR will not meet all expectations. And as transformative as TAVR is, arguably the creation of the heart team is even larger. So the question is, will lightning strike twice? As I mentioned, it happened in TAVR. I do not think that we are going to see it in mitral valve disease, impact therapy as rapidly or as in depth as we have in aortic valve disease. So in mitral valve therapy, we have 3 options to address the leaflets, the annulus, or replacement. And I think we have to clearly separate out primary MR and secondary MR. If we look at the same slide for TAVR with what's happened in mitral valve disease in the United States, you can see there's about 37,000 surgical mitral valve operations, of which about 20,000 are isolated surgical mitral valve operations, and there's about 14,000 TEER procedures. Now remember, there's about 87,000 TAVR procedures at the same time. If we look at TMVR, and these are mostly valve and valve, there's about 1,600 done per year in 2021. There are 507 sites in the United States performing TEER procedures. And this is the increase since commercial approval in 2014. You can see there's been about a 10-fold increase, but about 13,000 procedures total done. This is the percent of DMR, FMR, or both. And you can see that the percentage of DMR is decreasing as the percent of FMR is increasing. And that's due to the fact of the results of the COAPT trial, which came out in 2018. And that led to approval in the United States. So where is this going? For primary MR, there are 2 randomized trials, the REPAIR MR trial and the primary trial. The REPAIR MR trial is sponsored by Abbott. It's a non-inferiority trial in intermediate risk patients. There are 2 co-primary endpoints. The target population is a total of 500 patients, and it has been enrolling now in its 3rd year at the current time. The other is the primary MR trial, and this is sponsored by the NIH in the United States. It's an all-risk trial, and this trial is enrolling very well, and about 70% of the patients enrolled in the trial are low risk. And this is in 4 countries, the US, Canada, Germany, and the United Kingdom. It is a superiority trial of surgery, and patients will be followed until the last patient is 3 years out. So the mean follow-up for the primary endpoint in this trial will approach 5 years. Now, regarding functional MR, we got the results of the 5-year results of the COAPT trial that was presented at the ACC. This is the 2-year results, and this is the 5-year results for the primary endpoint. and the results have held true out to 5 years. There have been multiple studies that looked at real-world implementation of TEER and separated by COAPT-like criteria and non-COAPT-like criteria. And if you adhere to the criteria of COAPT, the outcomes are much better than if you treat patients that did not meet the inclusion criteria of COAPT. However, a lot of things have changed since COAPT, and specifically guideline-directed medical therapy. There were no patients with SGLT2 inhibitors treated in the COAPT trial, and there were very few patients treated with Entresto. Guideline-directed medical therapy now is institution of all 4 pillars of medications of heart failure at the same time right now. And this is much different than guideline-directed medical therapy. Guideline-directed medical therapy was in the COAPT trial. So the COAPT trial showed a benefit to the addition of TEER to guideline-directed medical therapy at 5 years. However, GDMT has changed and therefore raises the question, are the results of the COAPT trial still relevant today? And I would say the heart failure community in general remains unconvinced of the addition of benefit of TEER since guideline-directed medical therapy has improved significantly. So then we also have replacement and not just TEER. It's less invasive than surgery. It's a predictable and durable elimination of MR. It's a straightforward procedure, and many patients are not eligible for TEER. And there are now 5 valves that are in trials in the United States at the current time for transcatheter mitral valve replacement. So the question is, if lightning isn't going to strike twice, will it strike 3 times in the tricuspid field? We have a whole plethora of devices that are in trials at the current time. The 2 most common are repair, and there are 2 devices, both the Abbott device and the Edwards Pascal device, as well as at least 2 in replacement at the current time, the Intrepid valve and the Evoque valve. This is the results of the Triluminant trial, which were presented at the ACC by Paul Saraja 2 months ago. And what this showed is that tricuspid TEER was safe for patients with severe tricuspid regurgitation, reduced the severity of TR, and was associated in improvement of quality of life only. There was no benefit in terms of life expectancy or other functional outcomes. What this slide shows is that the better you are at correcting the amount of tricuspid regurgitation, the better your quality of life improves. But the question is improvement of quality of life only sufficient for wide adoption of this therapy? Or do you need to show a mortality benefit, which has not been demonstrated? Now, it may be that 1 year is not long enough to be able to demonstrate a mortality benefit in tricuspid valve disease, but the ballot is sure out, and I think in general, there's a general sense that the results of the Triluminant trial were somewhat underwhelming. Now, we also have transcatheter tricuspid valve replacement. This is the Evoque by Edwards, and you can see that you can completely correct tricuspid regurgitation. In a lot of ways, it's a technically more straightforward procedure than the transeptal mitral approaches. And this is the results of the TriScend 30-day trial, and you can reliably reduce TR. There is a significant improvement in functional class and acceptable safety. This is the TriScend 2 trial, which is the randomized trial of Evoque tricuspid and to optimal medical therapy. And the results of this will be presented at TCT in 2023. So this will be the second piece of evidence in addition to the Triluminant trial to determine whether in a randomized trial we can demonstrate a benefit of tricuspid regurgitation. So as a former U.S. Secretary of Defense says, we are we have known knowns, known unknowns, and unknown unknowns. So regarding tricuspid regurgitation, the known knowns is we know TR is bad. We know it has a bad prognosis. Diuretics are the only therapy, and it's now more commonly operated on with surgery now that we're seeing all these patients referred for transcatheter therapy but don't qualify for it. The unknown unknowns is we really don't know the prevalence of TR. We don't know the rate of progression. We don't know who's futile, so-called cohort C, and this probably has to do with severe right ventricular dysfunction. We don't know how the RV will respond to TR reduction, especially with replacement. It's unclear that correction of TR changes the prognosis, and as I mentioned, is improvement in quality of life sufficient to warrant intervention and surgery? And the unknown unknowns, we're going to learn a lot more about the time course and management of TR by transcatheter approaches, since we now have a robust referral line of patients that previously weren't referred for surgery. And this is going to be a robust area of investigation over the years to come. So I'm sorry I'm not with you all there in Greece, but I hope that this gave you some insights into where we stand at the current time with the whole field of transcatheter intervention.
Thank you, Michael. And thank both Michael Zrilli from Houston and Dallas for an incredible session. Anyone who has a comment or a question from the audience, please go ahead. At the same time, would like to, while we entertain these possible questions, get Dr. Tsoulakis to join us up in the podium together with Dr. Voudris and Dr. Sbaruni, please, to start chairing the next session. Michael, what is an unknowns, and I think that is an incredible last thought, because a lot of things we find. One of the examples of an unknown was the hypoattenuated leaflet motion. Clearly, it was unexpected. It was imaging driven, and that was an example of like nobody knew how to handle it. And everybody was thinking the worst. Turns out it was an intermediate type of activity or marker, and you know, we're looking into other things than the obvious for this initial unknown. I'm just going to give an example so everybody doesn't think that this is kind of up in the air and the unknowns never happen. It has already happened about 10 years ago, and the community needed several years and several trials to put their arms around it.
So I give a very related area in the tricuspid field, George, and that would be valve thrombosis. You know, we don't know what the incidence of valve thrombosis is going to be on the right side. We also don't know the durability of valve replacement on the right side. And we also don't know what replacement does to right ventricular function.
Yep.
Now, most of these patients that undergo tricuspid valve replacement are on pre-existing anticoagulation for atrial fibrillation. And they're going to need to be on anticoagulation afterwards. And what happens in these patients with advanced liver disease in terms of, we've seen GI bleeding significantly in trials already, but I think the issue of halt or valve thrombosis on the tricuspid valve is one of those areas that we have absolutely no information or no clue about right now.
Great indeed. I think this concludes this great session. It was really two expert presentations, one after the other. Mark Reardon, Michael Mack, thank you so much for joining.
Thank you, George.
At first, I would like to congratulate Kostas Parias for this superb meeting. We heard excellent talks, and now it's time to move to the most interesting cases from Greece and Cyprus. And the first speaker is Kostas, that is going to present Evolut Pro Plus in patients with extreme calcium. Kostas.
Thank you, Manolis. So we added this case that we just did a few days ago, just to show, because you've seen a lot of pre-recorded cases that were taken in 4 consecutive days of our work in the cath lab, and it just happened that there wasn't any self-expanding valve for those patients, and this happened a few days ago. So we want to show you the selection process we're using lately. So this is a patient, elderly patient with significant aortic stenosis, mild coronary artery disease, Parkinson's, proximal fibrillation, and mobility problems, spinal problems, and previous cancer. So his baseline is sinus rhythm with left bundle branch block, nice normal chest X-ray, and this is his echocardiography, a normal ejection fraction, and the mitral valve, there is some calcification there, and here is the aortic stenosis. You can see there is a lot of calcium and no movement. This is the maximum velocity. This is the coronary angiogram. As I've told you, no significant coronary artery disease there. And this is the his aortic, the aortogram, the CT scan. You can assess and evaluate all the arterial tree here. You can see the calcium, extensive calcium on the aorta, and as we'll see here, it's also inside the aorta, not also on the outside. And this is the aortic valve. So it's an extremely calcified aortic valve, as you can see in all 3 leaflets. And so here is the LVOT. Calcium starts from the annulus, all 3 leaflets, and then again, and the STJ, it's almost circular calcium. It's almost a porcelain aorta, I would say. And also, you can see that the dimensions of the sinus of Valsalva are large, but not huge. And the coronary ostia, you can see them clearly there. They're like borderline distances, I would say. So this is the sizing. We are talking about 72, if I can see well, of, yes, perimeter. It's 72, and the area is 485. So, and the LVOT is slightly larger, as you can see. This is a sinus of Valsalva, about 30 millimeters diameters, and the STJ, which is just a 23 or 24, and this is the Agason score on the aortic valve, which is really high, 5,000, more than 5,000. And the peripheral vessels are good to go for a transfemoral TAVI. So in a case like this, we have a lot of calcium in all over the aorta. So we would like to use, as an idea, the sapien, because we can flex and deflect the system so we can avoid contact with the aorta in this very calcified aorta and atheromatous. But then we have this extensive calcium everywhere that the risk of rupture with the balloon expandable valve, I think it's high. And also, if we're going to use a balloon expandable valve, it should be 26 millimeters, but the STJ is just 23. So that is an additional problem. So we're very close to say that this is a final decision. And I think this BAV with aortography made our final decision, because what we saw there, this is a 20 millimeter balloon, and you can see that there is a lot of regurgitation around this balloon. And with this, you can estimate that if you use the 23 sapien valve, which is the only one you can use for this STJ, you're going to end up with significant regurgitation. So that was the final decision to go with the 29 millimeter Evolut Pro Plus. Here you can see the positioning. Nothing important here, just straightforward positioning with fast pacing here, opening, and then releasing with this very good result at the end. A lot of calcium, so we know that calcium is connected with some PVL, little mild PVL, and we see that the valve is not folded. And this is the final result, a very good precursor with 2 proglides of the artery. And this is the gradients before and after, and the diastolic separation. And this is the pre-discharge echo of this patient with very mild paravalvular regurgitation and the good gradients and velocities after the implantation. Thank you.
Thank you, Kostas. We have time for one question or one comment. Just to notice, Kostas, that you don't use cusp overlap view.
No, it is used, but it's just used just to put here very few video runs. Because this is what this is the cine, but we also have the fluoro that is not saved. Yes, we use it.
Don't apologize, I just asked. It's time to move to Dr. Hamilos from Creta, from our hospital, that is going to present complication valve embolization.
I would like to thank the organizing committee and Kostas Parias for this kind invitation to present our case from Creta. I would like to change a bit the title of my presentation. Actually, you will see in the end that it's not a valve embolization, but rather a valve dislocation. And it's a case that we did together with Dr. Skalidis in Creta. So it's a relatively young patient, a 65-year-old, hypertensive with a history of cancer and metastasis, who was advised to have a metastasectomy in the liver, and he was refused by the surgeons because he was found to have a severely reduced ejection fraction with severe aortic stenosis, low flow, low gradient with an SVI of 22, and high calcium score, Agatston score in the aortic valve of 2,500. So this patient was discussed in the heart team, and it was decided because of his main disease to undergo TAVI, because his life expectancy maybe is not too big. But on the other hand, we were assured by the oncologist that it was more than 2 years. So coronary angiography showed normal coronaries, as you can appreciate here in these films. Nothing to remark. Of course, his Euroscore was low, and ST score low. And this is his CT angiogram. You can appreciate it's a tricuspid valve with some calcium there. And the dimensions of the access was quite okay from the right. From the left, he had the thrombus next to the common iliac, near to the common iliac artery. The coronary head was okay. And you can appreciate that a self-expandable valve was decided to be implanted. And the annulus dimensions were borderline to choose 29 or 34 Evolut. As you can see, the Evolut Pro, you can, when you have a 26 millimeter annulus or perimeter of 81, it's borderline between 29 and 34. So we chose to undergo with a direct implantation. We used for access the right femoral artery, and we chose a 29 Evolut Pro self-expandable valve. This is the aortogram of the patient. You can appreciate that there is also aortic regurg, quite severe. And this is the first attempt to implant the valve. This was quite low implantation, so we recaptured the valve and we reimplanted. You can appreciate those images. And after we released the valve was dislocated into the left ventricle, causing a very severe aortic valve insufficiency. So at this point, the pressure went down, but still the patient was relatively stable. So what we have to choose to do something. So we decided to do a snaring of the valve, and because we thought that one of the causes of this complication was the sizing of the valve, we decided to go for the bigger valve and use for the second valve implantation an Evolut Pro 34. So we first snared the valve. You can see the images. The third image shows that the valve is moved upwards, but finally, with trying to move it a bit, it popped up in the ascending aorta. So our decision was to go on with the second valve, keep the first valve in place, and go on with the second valve, with the 34 valve. You can see the implantation. Our first attempt was to have the two valves consecutive, but in the end, you can see that the valve was released and the aortogram is okay, with no paravalvular leak. The first valve moved a bit towards the aortic arch, but the check of the arteries that goes from the arch was okay. So we decided to leave it there, and we thought that this was a good result. Some very, very fast thing about the valve embolization and dislocation. The aortic dislocation is much worse than the ventricular dislocation is much worse than the aortic dislocation, with a higher mortality and higher rate of reoperation needed. And the use of a self-expanding valve is, and the presence of a bicuspid aortic valve are independent predictors of embolization or valve dislocation. So to close the case, appropriate sizing is of paramount importance in any case, and when a complication arrives, be ready to solve the problem. Thank you very much.
Congratulations, excellent case. Of course, excellent case, thank you very much. Obviously, the decision for the selection of the first valve was not that successful, right?
Yeah.
Probably, in retrospect, of course, you had to put the 34 valve in, right?
Yeah. Or a balloon expandable valve of 29.
Finally, I mean, there was an excellent demonstration of what to do with the dislocated valve. You first decide if the position of the new valve is acceptable or not before you insert the second valve. And you do the right thing in the ascending aorta. Thank you very much.
Thank you.
And in this marginally sizes, 62, 72, or 82 millimeter perimeters, maybe it's better to go for another kind of valve to be most to fix with annulus. Next case will be presented by Dr. Voudris from Onassis cardiac surgeon, TAVI for the treatment of degenerative bioprosthetic aortic valve.
Okay.
Dr. Voudris.
Dear Chairman, dear colleague, I would like to present 84-year-old lady, symptomatic, with surgical aortic valve replacement, Documus plus aortic, number 21, and a mitral valve repair 4 years ago. The scores are high. The screen echo shows preserved LV function, severe aortic stenosis, aortic valve area, 0.6 centimeters square, mean gradient 30. However, the ratio aortic velocity versus LVOT max was 4.8, so it is a low gradient, severe aortic stenosis without aortic regurgitation and mild to moderate mitral regurgitation. This is the images from the screen echo. You can see the opening of the valve, the mild to moderate MR. The coronary artery are normal, but have a look, there is no visible marker of bioprosthesis. The heart team of our hospital decided to have TAVI, valve-in-valve procedure. This is the valve we are going to treat. The Docimos is a pericardial leaflet valve without fluoroscopic markers. The size 21 means the true ID 18 millimeters and the stent ID 18 also. But during the measurements, the annulus diameter was less than 15 millimeters. Considering that this valve is not visible, we should use echo and similar methods to stentless valve. What is the type of valve we can use? It is the Evolut or the S3, 23 and 20 millimeters. So before the procedure, we have a transesophageal echo. The AVR planimetry was 0.06 centimeters square. You can see the gradient, it's around 80 millimeters. This is the angiography. You can see no markers of the valve, nothing. So we decide to have balloon inflation, 16 millimeter, and then to continue with implantation of a Medtronic Evolut 23 millimeter valve using angio and transesophageal images. This is the implantation of the valve without aortic regurgitation, but the gradient is still higher, more than 20 millimeters square. So we decide to have a post-valve balloon inflation with 18 millimeter balloon and the zero, and then we have zero gradient. And the final aortography, so no aortic regurgitation. This is the images from transesophageal echo just after post-dilatation. The max gradient is 14 millimeter without aortic insufficiency, and these excellent results were confirmed on pre-discharge echo that show a mean gradient of 10 millimeter. I would like to have your attention on a very recent paper in JACC Cardiovascular Intervention concerning the cracking of valve-in-valve procedure, data from the TVT using the SAPIEN 3 Ultra valve. The conclusions were that cracking is associated with a higher risk of in-hospital mortality, excess bleeding, modest reduction in echocardiographic valve gradient and gain in valve area. And finally, the author suggests that when clinically indicated, cracking should be performed after rather than before transcatheter valve implantation. Thanks for your invitation.
Thank you, Dr. Rudis. At what pressure the valve cracked? At what pressure that you feel that the valve cracked in the...
It's not cracked because this is not a cracked valve, but just we use around manual and with the device pressure around 4 to 6 atmosphere.
So you achieve a better area?
Just to see that the balloon is almost open on the valve.
With 18 millimeter balloon?
Yes.
Yeah.
Yes.
Any questions or comments?
Excuse me. In my experience, I have never used this kind of valves, Radcor, with pericardial tissue, but all the other valves that you are using till now, they have also a manual what pressure to push after to do the cracking. So do you have any manual how many atmospheres and how long you to do this balloon expanding after putting the valve? Or you decide it by experience?
Of course, the experience is a main issue. Don't forget. But if you intend to crack the valve, of course, you need to use an interflator plus manual pressure.
Yeah,
together.
Plus manual pressure. Okay, thank you very much.
But in this case, we are not intending to crack the valve. It's impossible to crack the valve. The only things we would like to have is to improve the gradient and to have a better function of this device. So we have a manual compression with 80 balloon. It was a risky procedure because it's nobody knows.
Absolutely.
And for this reason, we are going to show and to discuss this case.
Excellent result.
In any case, you are not accept 20 millimeter of gradients maximum. You have 20 millimeter of gradient before.
23.
23.
23, 25.
Instead of 60 before the valve. Before
60
was the
before
gradient,
valve implantation, the gradient was around 80. 80 millimeter before valve implantation, 25, 26 millimeter after valve implantation, and 0 after post-dilatation.
Okay. Thank you, Dr. Dravouris. Because of time, we are moving to the next speaker, that is Dr. Mitsis, with didactic transcatheter edge-to-edge repair as online. Dr. Mitsis.
Good afternoon from Cyprus. Do you hear me?
Okay, yes, we hear you well.
First of all, I would like to thank the organizing committee for this kind invitation. In the next 8 minutes, I will present the case of a secondary ischemic MR and a dedicated stepwise therapeutic approach. This is a case about a 75-year-old lady with a history of arterial hypertension and type 2 diabetes, who was admitted to our hospital almost 1 year ago with an inferior stem. She was treated with primary PCI to the right coronary artery. Her hospitalization was complicated with an acute pulmonary edema, which was quite tricky to treat, and paroxysmal atrial fibrillation. As you can see from this transthoracic echo, which was recorded left ventricular function a couple of days after the STEMI, there is a moderately impaired LV systolic function with severe hypokinesia in the RCA territory with basal and mid-inferior wall hypokinesis. Also, there is a moderate to severe MR with an ROA calculated to 28 millimeter square, while the right ventricle has normal size and function. So the question is how we should approach this case. And of course, we all agree that medical management at this stage is necessary. The patient requires diuresis, restoration of the sinus rhythm, of course, And all this guideline-directed medical treatment that we discussed the last years, treatment of the ischemic cardiomyopathy, including ACE inhibitors, MRAs, SGLT2s, and beta blockers. And this is what we did, of course, and this is the medication that the patient received after the discharge. Of course, we keep the patient under close clinical and echocardiographic follow-up in view to reassess the MR after the optimal medical treatment. And 6 months follow-up, the patient comes back to us with symptoms and shortness of breath, elevated BNP, and we did some changes in the medical management. As you can see, we increased the diuretics and added Entresto. But again, 12 months later, the patient is still symptomatic. And these are the images from the transesophageal echocardiogram that performed 1 year after the STEMI. And as you can see, there is a severe MR with severe functional MR with restriction of the posterior leaflet. ROA was measured 32 millimeters squared. There was a systolic flow reversal in 2 pulmonary veins. The LVEF, as before, 45%, with an left ventricular end diastolic diameter of 5.1 centimeters, while the right ventricle was normal. So again, the same question as before, how now we should treat the case. And taking under consideration that this is a case of severe symptomatic secondary MR on a patient with optimal medical treatment in absence of severe left ventricular dysfunction and with a relative good right ventricle. Should we still watch and wait, or should we think something like a surgical repair or a transcatheter repair? We thought that this is an ideal patient for a TEER, for M-TEER, as this case fulfills almost all the COPT criteria. As we said before, this patient is in optimal management, but still symptomatic, and with a left ventricle, which is not completely destroyed. So the next step is to judge the valve per se if there is anatomically suitable for the procedure. And this is the TOE analysis of our patient. As we said earlier, this is functional MR because of the restriction of the posterior leaflet. There is tethering of both leaflets. As you can see in the bottom right corner, there are 2 jets, one centrally directed, which is the larger one, and another one that seems to start from the lateral commissure. Few issues that we have to take under consideration: the relative small length of the posterior leaflet, measured up to 7.4 millimeter. And as you can see, the 3D reconstruction of the valve, this cleft-like indentation between the P2 and P3 scallops. Transeptal height was measured 3.5 centimeters, while there was no issues with the gradient in the area of the valve. So it seems that it's a suitable case for transcatheter edge-to-edge repair. And our strategy was to treat the patient with a Pascal P10 device, focusing on the placement of the device in the mid position, with a clocking from 12 to 6, capturing the A2 and P2. And this is at the right of the presentation. You can see the hemodynamics just before the procedure with a V wave of 89 millimeter mercury, with a relative, of course, elevated blood pressure of the patient because of the vasopressors. The first attempt of placing the device, we tried to do an independent grasping, starting with the short posterior leaflet.
Sorry that I'm interrupting you, but you have 1 more minute to complete the presentation.
Yeah, it's 1 minute more, and this is the result after the first attempt with some residual MR from the medial of the valve, and then V wave of 25 millimeters. We thought that we have probably to optimize the result, optimizing the grasping of the anterior leaflet. But now it seems that the MR is more and the V wave more elevated. So we did another optimization. At this time, we tried to move the device more medial, and this is the final result with mild residual MR and a V wave of 24 millimeter mercury and the mean pressure gradient of 2.8. So I think that and this is the follow-up 2 months after the procedure. To conclude, the learning points of this case is to highlight again how important is the patient selection and the optimal timing for this group of patients with a secondary MR. We have to be aware about the COPE criteria, and we have to try to offer this procedure in patients who fulfill this criteria, because these are the patients that will benefit more. And always be aware that despite the fact this is a case of functional MR, sometimes there might be some cleft-like indentation that probably we need to be careful, because we might need another device to fix the problem. Thank you very much for your attention.
Thank you, Dr. Maginas. A brief comment or something?
Thank you very much. That case illustrates very nicely that we have to wait for the appropriate timing, always starting with the optimal medical treatment. You waited several months and looked at the patient still was in heart failure, and you did a very good procedure, and you improved very much the MR, the V waves, and obviously the clinical condition of the patient. Congratulations. Thank you very much.
Thank you.
Now we are moving to the north of Greece with Dr. Didangelos. Cracking of a bioprosthetic aortic valve is also online. Huh?
Hello, good afternoon from Thessaloniki. We'd also like to thank the organizing committee for the kind invitation. After the great presentation from Dr. Voudris with the much experience, we will try to present our first case where we try to crack the bioprosthetic, degenerative bioprosthetic aortic valve. We have the 18.
Δεν είναι ξεκάθαρο, δεν ακούγεστε. Μπορείτε κάτι με το μικρόφωνο να κάνετε?
Τώρα με ακούτε καλύτερα?
Νομίζω, ναι.
Ναι. Ωραία. So we had an 82-year-old female lady. She was a small lady, as we can see here. She had the mitral flow surgical valve 21 almost 13 years ago. She had diabetes mellitus, arterial hypertension, dyslipidemia. She had developed secondary pulmonary hypertension. She had chronic kidney disease, mild thermatus coronaris, and a high Euro score 2 of 18%. That was her ECG pre-TAVI. She had an LBDB, and nothing more. So that was her echo before TAVI, an ejection fraction of 50%. The bioprosthetic mitral flow valve was severely stenosed with a peak gradient of 67 millimeters mercury and a mean gradient of 43. She also had developed, as we said, pulmonary hypertension, right ventricular systolic pressure of 62 millimeters mercury. As we can see here in the transesophageal echo before the procedure, the valve was calcified, the leaflets were thickened, and they had developed pumps more likely. And here we can see the jets from the prosthetic valve and the 3D images of the valve. So we decided to go on with the valve-in-valve TAVI. The valve we have available in our center is the portico valve. I will not describe the features, just the length of the skirt. To keep in mind, it's 26 millimeters for the 23 portico valve. And that's the mitral flow surgical valve. It's a standing valve with a supraannular position. It's made of bovine pericardium, and it has this this radio-opaque ring. It's the only thing we can see during fluoroscopy. It's a sub-shape ring. And also here we can see the construction, the dimensions of the valve. So we had the CT before TAVI as usual. All measurements were performed. We decided for a 23 portico valve. As you can see here, the inner diameter of the surgical valve was 17 millimeters. The height of the coronaries, the right coronary was 12 millimeters. It was good. The left coronary was about 7 millimeters. We also measured the distance from the virtual valve to the left coronary. It was good for a portico valve. The right coronary was a bit closer to the limb. So we used the app. We tried to follow the steps. By using these tables, we see that the mitral flow valve is a crackable valve, and we use that through dilatation balloon at 12 atmospheres, as we can see here during the procedure. The pre-TAVI aortogram, you can see here the ring of the mitral flow valve, and here the portico valve expanded. We can see there's a limitation of her waist here. So we decided, we performed all of the procedure was done under TOE guidance in order to be able to see the depth of the valve, and we also measured the gradients afterwards. We had the minimum gradient of 22, the peak gradient of 35 just after the implantation. So we decided to go on with post-dilatation with that through balloon, 20 millimeters through balloon. You can see here the waist of the balloon. It's left a bit, and then second post-dilatation with a better result, and the cracking of the valve. You can see here that tissue, that material that floats into the aorta. Post-dilatation angiogram, we can see flow in the coronaries and a good final result. These are the gradients after the post-dilatation. Pulmonary gradient has dropped, and also we had the peak gradient of 12 and the minimum gradient of 7 millimeters mercury. That's the setup of the balloon. We checked it afterwards ex vivo. We can see here the manual syringe where we inflate the balloon, and then with the inflator, we turn this three-way manifold to the inflator, and we reach the 12 atmospheres, as you can see here, in order to reach the indicated cracking pressure for the balloon. We also check the balloon afterwards if there is any leakage through the connections here. As described in the literature, we didn't have any leakage. However, things didn't went so good. We had femoral artery bleeding at the end of the procedure, despite a third proglide that we tried to place there. We had prolonged manual pressure and then an external iliac artery thrombosis, as you can see here. So we ended up somewhat like that. We had a vascular surgery consultation. The patient had the femoral artery cut down. Here you can see the sheath the vascular surgeons put in. And then they performed thrombectomy of the external iliac and the femoral arteries with a Fogarty catheter. Here is the material they retrieved from the arteries. You see thrombotic material, endothelium from the cut down, and also we have the proglides that have failed, and also they performed the endarterectomy with a thermomarks plaque removal. They closed the artery with a patch, and these are the final angiographic results of the femoral and the iliac arteries. We didn't have any issues with the rhythm afterwards, just first degree AV block in addition to the LVB. So the peripheral arteries gradually recovered. We didn't have any further complications. She had a respiratory infection that was managed with intravenous antibiotics. She stayed in the hospital for 25 days, and she was discharged home on clopidogrel and low molecular weight heparin, and she's now mobilized in New York to class. So biprosthetic valves degenerate during time. Approximately half of them may degenerate at 15 years, and the problem is mainly stenosis. The valve-in-valve implantation is a procedure similar to the standard TAVI, but it's technically more demanding. It needs a careful pre-procedural planning, and we must be ready to face all the possible complications, device malposition, coronary obstruction, and elevated post-procedural gradient. So optimal patient selection and pre-procedural planning is of the utmost importance to minimize this risk. And this is my take-home message from the literature. Careful planning, identify the risks, and perform the procedure really meticulously. Thank you very much for your attention.
The only thing that I have to say is congratulations, excellent case, great result. And for the time restriction, we will proceed with the next talk. Inflow, infolding, Dr. Sirsaludis in Perceval valve, valve in Perceval with infolding.
Hello again. So another case from Athens. A female, 75 years old. She had aortic valve replacement, surgical aortic valve replacement on May 2022. 6 months later, she presented with dyspnea, worsening on exertion, and paroxysmal nocturnal orthopnea. She was NIHA state 3 to 4. She was diagnosed with severe paravalvular and valvular regurgitation, and she had also a stenotic profile. In the echocardiogram, she had preserved left ventricular ejection fraction and pulmonary hypertension, intermediate. She had a high Euroscore because of the previous surgery. However, she was not willing to go on with another procedure. Neither her surgeon was, because he had concerns about the feasibility of explantation of the previous implanted valve. So there was a Perceval medium-size valve with massive regurgitation, multiple jets of regurgitation, infolding of the stent frame in the inflow of the Perceval valve. And there was also restriction of the leaflets of the Perceval. There was this is the shape actually of the Perceval valve in the inflow and the site of the regurgitation. These are images from her CT analysis, and there was this heart-shaped deformation of the Perceval valve. She had excellent access from the femoral arteries. And the question was why she has this deformation in her surgical valve. It could be a massive calcium nodule in the inflow. This was not the case according to the CT images we had. There was no entangled sinusoidal struts of the prosthesis. This is something that can happen during the crimping of the valve. And what happened was that the valve was too large for her size. The CT measurements was about 19 in the annular size, and she had a medium valve. So we proceeded for a valve-in-valve implantation. We sized the valve not according to the previous Perceval, which was failed, but according to the actual annual size of the patient. We had extra care not to cross the valve behind the infolded struts. So we used a pigtail and we advanced the wire after creating a loop and then advanced it into the left ventricle. And we confirmed the central position of the valve with the TOE after crossing. We had a high pressure balloon for dilatation, an 18 millimeters balloon, an Atlas. We had an injection also to confirm the patency of the coronaries. However, the coronary ostia was were high, so we didn't feel that there was any danger of obstruction. Pre-dilatation was performed in order to prepare the landing zone of the valve. We wanted to stretch the enfolding so as to make it right, or compress it, creating a double layer of struts in the side where the enfolding was. After the pre-dilatation, there was some improvement in the aortic regurgitation. Following that, we started the implantation of the new valve, an Evolut R23. The Evolut was placed in line with the lowest visible stent of the Perceval stent frame. Otherwise, the outflow of the Evolut would be compressed and incompletely expanded. We had concerns about annular rupture, incomplete expansion of the valve, or relapsing of the enfolding. However, we released the valve, and before making any checks, we performed post-dilation of the valve with the same balloon. This was because we wanted to make sure that we would have an optimal valve expansion and we would seal the regurgitant orifice behind the struts. Following the post-dilatation, there was only trace aortic regurgitation, and we were quite happy with that. No pressure gradient, patent coronaries, and no AV conduction disturbances. 3 months later, only trace AR, a fine circular prosthetic valve in the echo. The patient is symptomatic, and that's it. Thank you.
Thank you. Any specific reason that you use balloon self-expanded instead of balloon expandable valve?
No.
In any case, you perform post-dilatation.
It was mostly due to the experience of our center.
Yeah, it's okay. Any idea for the reason for this enfolding of the valve?
I believe that the Perceval is a valve which is made for TAVR. After it's not working. I believe that the Perceval valve is a valve that's made for TAVI. After that, the surgeons they didn't have very good results in TAVI, and it was difficult to put this valve in TAVI. After that, they decided to use this valve only for small annulus. There are 3 sizes: small, medium, large, and they put this valve only with 3 stitches that we take off the stitches and have a good result. But the long follow-up of this valve is very bad, but in great use. So it's difficult also for the next generation of cardiologists to see what to do about this kind of valve.
This one was also oversized, and that's another reason.
Okay, thank you very much, Dr. Sisaloudis. We have Dr. Ninios now, a case of transcatheter mitral valve replacement.
Good afternoon, good evening from Thessaloniki. Thank you very much for the kind invitation. Can you hear me?
Yes, very well.
Okay. We'll present a case of TMVR with an Alta valve. That's about 81 years old lady with functional severe mitral regurgitation, and she was in NIHA class 3 with elevated pro-BNP and regurgitation volume of 51 milliliter and regurgitation fraction of 44%. We assessed the valve and analyzed the left ventricle and analyzed the aorta mitral angle with CT, and we measured also the mitral annulus, and assessed also the left atrium, measured the height and the width of the atrium, the volume and the change of LA volume between systole and diastole. And after that, we sized for the alta valve, and we chose the right valve. There were no risk factors for some. And we assessed also for the septal puncture, and the femoral veins were also adequate for the procedure. That's the TOE, shows FMR with a central jet, and that's the valve with the 3D images. We started first with the transeptal puncture, and after that we proceeded the ballooning of the interatrial septum to have enough space for our guide. And that's the fluoroscopy of the ballooning of the septum, and on the right image is the guide that is advanced in the left atrium. And again, the TO images. And then we placed the valve into the left ventricle, and we had to measure exactly the distance of the tip of the valve to the mitral annulus. We aimed to engage laterally with our alta valve, and after measuring exactly the distances and the depth, we started with the deployment, as you see in the right images. And in the fluoroscopy, we start with the deployment of the valve. And here the valve is functional, but not fully deployed, not released yet. Then we start with the deployment of the gauge of the valve, of the supraannular frame that anchors the valve within the left atrium. And that's the final result. There is no LVOT obstruction. That's very important for the TMVR concept. And there seems to be some intravalvular regurgitation, and the fluoroscopy images of the frame that is expanding into the left atrium. And that's the final result after the deployment of the valve. There is some mild residual regurgitation, and also some images, some 3D images from the left atrium of the alta valve. That's the 1 month follow-up with the mild residual MR, and our patient is doing fine. Thank you very much.
Thank you, Dr. Maginas, your comments. Please.
Congratulations, Dr. Niños. A very nice case. I would like to ask you only, what do you think are the advantages of this particular valve over the other TMVRs?
Yes. Thank you, Dr. Maginas. That valve has a supraannular system that she has a frame that self-anchors within the left atrium. And that's very important, because we know that a very big challenge for the TMVR is the anchoring and the sealing. She does also not develop an LVOT obstruction, and that's also a very important point. And of course, she has also a low-profile delivery system for the transcatheter concept of 29 French that is also steerable. And that's good for the device delivering and the positioning in the left atrium with different anatomies. But also, we can use that valve also after MV repair and in cases of MAC or after TEER, because the placement of the valve is practically supraannular.
Okay, thank you, Dr. Ninos. Do we have Dr. Karagounis online to present?
Yes, yes.
Mitral transcatheter edge-to-edge repair in a patient with a refractory cardiogenic shock. We are listening to you.
First, to congratulate Kostas Sparias for organizing this meeting and to thank him for inviting me. I would like to recognize my colleagues, Vlasi Ninos, Ilia Ninos, Ioannidis, Kitikolou, Apostolos Papas, and Kodos for their contribution to this case. Patient is a 57-year-old male presented.
Please share your screen. It's okay. Full screen, please. Okay.
A patient is a 57-year-old male who presented the emergency room with dyspnea on exertion and burning sensation to the jaw on and off for a week, morbid obesity, heavy smoker, obstructive pulmonary disease, hypertension but not taking his medication, and a remote history of renal dysfunction which was resolved. The initial vital signs did not show anything significant. The electrocardiogram also a little bit later on, hand elevation in the inferior leads. The admission labs were significant for leukocytosis, 14,000, and a troponin about 1,000. Soon after the arrival, developed pulmonary edema, hypertension, intubated, and he rushed to the cath lab. Here's his electrocardiogram with ST elevation in the inferior leads and ST depression in the lateral leads. The angiogram shows three-vessel disease. Here's the LED, which shows multiple lesions. It's not well seen here in this video because of his weight. His circumflex is occluded with collaterals provided from the left system, and the right coronary artery also occluded. Attempts to open the RCA or the circumflex